Hello, hello, mic check 1 2 3.
I, Dr. Uma Shivanand, Senior Resident, Department of Anatomy, JSS Medical College, welcome you all for the second day of 7th Annual International Conference, BGCI. Let's start the first session of today's program, that is Genetic Counseling in Disorders of Musculoskeletal System. Achondroplasia, Duchenne muscular dystrophy, and osteogenesis imperfecta are among the most frequent rare genetic disorders affecting the musculoskeletal system in children. Rare genetic disorders are severely disabling and can have substantial impacts on families, children's, and healthcare systems. Let us understand in depth about these conditions from the renowned experts from this field. So, I would like to start the session with the introduction of our moderators, Ms. Yashodhara Bhattacharya, who is a level 2 certified genetic counselor by BGCI. Currently, she is working at Perkinreimer Genomics, Calcutta. I welcome you, ma'am. Next, Vaishnavi Suresh, who is also a level 2 certified genetic counselor by BGCI. Currently, she is working at Map My Genome, Know Yourself, Hyderabad. I welcome you, ma'am. I would like to hand over the dials to the moderator. Thank you.
Wish everyone a very good morning and a very warm welcome to today's session. So we will to start with, we'd like to introduce the chairpersons, but before that, I'd like to ask everyone to switch off their phones so that they can concentrate on the wonderful lectures. And also, all questions will be taken towards the end. And further, at your free time, please do check out our fun booth and the poster booth as well. So I'd like to introduce our chairpersons for today, Dr. Usha Dave. She is the Vice President of ISPAT and the Secretary of MPAI. She is the Research Director of MILS International India and Japan, a National Professor and Visiting Scientist at Hapkin Institute in Mumbai, and an Honorary Medical Geneticist at N. Wadia Maternity Hospital. She is PhD and her interests are in clinical and biochemical genetics, cytogenetics, and congenital metabolic disorders by mass spectrometry. Her career highlights include establishing the Center for Research in Mental Retardation, started the first GCMS metabolic testing service, an honorary member of the Japanese Society for Biomedical Mass Spectrometry. Our next chairperson is Dr. Jayashree Ramesh. She is an associate professor and HOD of the Department of Physical Medicine and Rehabilitation at JSS Medical College. She's an MBBS with a post-graduation in rehabilitation medicine from the Government Medical College of Trivandrum. Her interests include neurorehabilitation, and her career highlights include the associate professor and the HOD of the Department of Physical Medicine and Rehabilitation at JSS Medical College. She has worked in many medical colleges across Kerala, and she has worked at the All India Institute of Physical Medicine and Rehabilitation in Mumbai. We welcome you, ma'am. I'd like to now introduce our third chairperson for today, Dr. B.R. Lakshmi. She's the founder director of the Molecular Diagnostics Counseling Care and Research Center, MDCRC, at Coimbatore, Tamil Nadu. She's the vice president of the Board of Genetic Counseling India and a board member of the Asia Pacific Society of Human Genetics. She is a PhD in biochemistry and genetics from IIT Madras. Her interests include community genetics, DMD and SMA, public health genomics, molecular genetic diagnosis, and career highlights include she spearheads the state-level project for the identification and prevention of DMD in collaboration with the National Health Mission Tamil Nadu. She directs and leads many research projects funded by Ayush, ICMR, and SPC, and the Yuva Shakti Award about the top 15 women scientist awardees. I'd like to welcome all three chairpersons for today, and I'd like to hand over the session to our chairpersons. Thank you, ma'am.
Good morning, everybody. I take this opportunity to thank the BGCI. And of course, I am the part of BGCI. I am my chairperson colleagues who are also from Bombay and again here from Chennai, Coimbatore. So two up and down, north and south. Okay. And this session is going to be on disorders of musculoskeletal system. So another medical specialty. There is slightly change in the program. We are going to have the academic partner Illumina, Dr. Amol Zimmer now, I believe. And he will be giving his presentation over here. Can I have his CV, which was not given to me? Dr. Amol, you can come over here on the dais if you are there. Oh, he is the head of medical affairs for Japan and Asia Pacific region at Illumina, responsible for driving clinical research and medical education. He has received his medical training at GS Medical College, Mumbai. Oh, you are my colleague there from Bombay. MBA from Symbiosis Institute Business Management, Pune. Currently, he is based in Singapore at Illumina's region and headquarters. He has been working in pharmaceutical biotechnology industry for many years, has various positions with increasing responsibilities with different geographies and companies. I'm sure from the Takeda, Sanofi, and Scrip, Amol will bring a breadth of experience in clinical research, new therapeutic product launches, and educational partnerships, which we look forward, Amol. Amol, you have a tough time. You have 15 minutes. Welcome.
Hello. Thank you, Chair. Thank you for the kind introduction. And thank you, BGCI, for inviting me on behalf of Illumina to present here. So can I have my slides up, please? Okay. So today's session is focusing on the first session on the musculoskeletal disorders. And I'll be talking about the rare diseases because most of the muscular dystrophies and the neuromuscular disorders can be categorized as a rare diseases. And hence it is very important for us to understand that what genomics role, in there for the diagnosis of those rare diseases, including muscular dystrophies and neuromuscular disorders. So let's dive into, it's now working? Yeah. So yes, this is the first session, so we expect some of the technical issues. Anyway, so I'll move ahead with that. So next slide, please. So these are my disclosures. Next slide. Let's talk about rare diseases. And the next slide, you will see the definition of the rare diseases, which is more of a prevalence base. So World Health Organization defines rare diseases as diseases which affects less than 10 people out of 10,000. But most of the countries across globes, they have adopted their own definition based upon the local situation. For example, in US, the rare diseases are defined as diseases which impact less than 200,000 individuals, versus in Japan, the prevalence fewer than 1 in 2,500. In Europe is 1 in 2,000. And in Australia, it is 1 in 10,000. So if you look at the kind of prevalence range, it falls between 1 to 6 per 10,000 in different countries. So what is in India? So do we have any definition in India? So no. So there is no standard definition of rare diseases in India, but ICMR and ORDI has suggested some of the thresholds, which are like 1 in 2,500 and 1 in 5,000 could be considered as the definition of the rare diseases. But as of now, there is no formal definition of the rare diseases in India. The reason because we don't have a good epidemiological data for the rare diseases. We don't have the centralized registries on which we can really standardize the definition in India. However, if you look at, if you take these numbers and extrapolate those numbers, the foundation of the research on the rare diseases, they have estimated that there are around 70 million to 100 million people who are impacted by the rare disease. So in an Indian context, when we speak about rare diseases, it says rare, but if you look at the actual numbers and considering the population of the billion people, the rarest of the rare disease can pose a very huge public health problem in India. Okay, so why we should focus on rare disease today? So if you look at the rare diseases, there's a broad categories. Almost 7 to 8,000 rare diseases are clubbed together under umbrella of the rare diseases. Out of those, almost 80% or nearly 90% have genetic origin, and the 50% of those diseases impact pediatric population. And these diseases are very difficult to diagnose because of non-specific symptoms, and the patient may struggle with the diagnosis for years, which is called as diagnostic odyssey. So average specialist, a patient might visit in the diagnostic odyssey maybe around 10 to 8 physicians over the period of 5 to 7 years or over the decade, and misdiagnosis is very common in this particular population. Focusing on pediatrics, and this is data from the West, of course. But if you look at the NICU admissions, almost 30% admissions could be contributed to the genetic disorders, and 40% deaths in developed world are attributed to some of the genetic conditions in the pediatric population. That's why it is very important for us to talk about those diseases, see how we can expedite diagnosis and treat those patients when treatments are available. Okay, so let's talk about genomic testing in rare diseases. When it comes to the testing in rare diseases, what is important is to have a very comprehensive genetic testing. Reason because if you look at these disorders, there is a significant diversity in the pathogenic variations of these diseases. Though the single nucleotide variants (SNVs) form majority of the genetic mutations, but if you look at other genetic mutations such as CNVs, indels, and the combination of those can form almost 40%. And that's why any test we employ to diagnose rare diseases need to be very comprehensive. So when we look at currently available technologies or the test, next slide, please. Back. Yeah. So these are some of the technologies which are currently available. We have Sanger sequencing, we have targeted NGS, we have PCR, chromosome microassays, we have exome and genome sequencing. Except whole genome sequencing, most of the technologies, they cannot detect all the the relevant genetic signatures or the mutations. But whole genome sequencing is currently the only available technology which can cut through across the different genetic mutations which are clinically relevant. So okay, let's talk about what happens when patient presents into the clinic. The patient may have some kind of a symptoms. We call it as a phenotypic presentation. If that phenotypic presentation is pointing towards a particular genetic disease, we can directly test for that particular genetic disease. And patient gets a diagnosis, and it's the end of the diagnostic journey. But what happens when patient doesn't get a diagnosis? Patient would land up into the right side of the bucket, which is non-specific phenotypic presentation. And what options do we have? We can deploy targeted assays, which could be single gene, multiple gene, mitochondrial testing, FISH, etc. Or we can do genome-wide assays. But the problem with this targeted assays is if we don't get a diagnosis, then we have to look for some other assay, and the process becomes very iterative, which is time consuming and also costly. But if we deploy whole genome sequencing in this particular population at the beginning, then potentially we can expedite the diagnosis and in a minimal time available. So the whole genome sequencing has a definite utility for the rapid diagnosis of the diseases, especially if patient presents with a very non-specific phenotypic presentation. Okay, so there is a data talking about the utility of whole genome sequencing versus other genetic testing. And this is a meta-analysis of 37 studies looking over 20,000 children. And you can see the diagnostic utility increases from CMA to whole exome to whole genome. And the whole genome sequencing provides much more better diagnostic utility compared to other genomic assays or genomic testing. So the whole genome sequencing offers significant advantages. One is improved diagnostic utility, faster and more efficient workflow. And secondly, it saves a lot of time and cost for the patient as well. Okay, so let's look at the diagnostic utility and the clinical utility of whole genome sequencing. Uh, sorry, the slides are moving pretty slow here. Okay, so values are gone, but the key message here is in the same analysis, it was shown that whole genome sequencing has much higher diagnostic utility compared to chromosomal microassays. There are a number of studies which have looked into the diagnostic utility of the whole genome sequencing, especially in the patient population, in pediatric patient population, who are admitted into the NICU and PICU. So on the right side, you will see the number of studies which are head-to-head comparison between the standard test versus whole genome sequencing. When I say standard test, which means CMAs, FISH, karyotyping, targeted gene panels, etc., and multiple publication, not necessarily the head-to-head studies, all have shown the higher diagnostic utility for whole genome sequencing, ranging from 20 to 70%. And not only into the sick patients in NICU, PICU, but also the patients who are presenting in outpatients. On the next slide, if it moves, yes. And most of the musculoskeletal disorders, muscular dystrophies, they will fall into this category. They will have the chronic presentation. They'll be visiting different specialties very often without any diagnosis for years. And even in outpatient, the diagnostic ability has been shown to be much better compared to standard of care about targeted genome sequencing or gene panels. Sorry. So over the last decade, what has happened, the interest in whole genome sequencing and specifically its application into the pediatric population, because that's the population gets impacted majorly by these rare disorders, has increased tremendously. And you can see the number of publications which are coming out for last decade. Okay, so let's look at some of the important studies here. The one is INSIGHT trial from US. So this is the first study they looked into. This is a randomized controlled trial. So they recruited 65 infants into the two group. One half receives a rapid whole genome sequencing along with the standard test. Other half received only the standard testing. And if you look at the findings, the mean age of diagnosis was 25 days if a child has received rapid whole genome sequencing versus 130 days in a control arm. Mean time to diagnosis was 14 days versus 107 days in a control group. And at day 28, the diagnostic rate was as high as 31% compared to 3% with a standard test. So this study clearly demonstrated that rapid whole genome sequencing has a great utility in NICU and a PICU setting when we are trying to diagnose the critically ill children. The stems Another study looking into the intellectual disability, where the diagnostic yield was 27% versus the standard of care currently, which is chromosomal microassays, which has diagnostic ability of the 12%. And this is a study in the medically complex children. So sometimes you will have a patients where we struggle to find a diagnosis because the presentation is so complex that we don't know what's happening. And in that group, if you deploy whole genome sequencing, we can see almost 1/3 of the patient, they received a new primary molecular diagnosis. So this was a study where 49 probands and their family underwent the whole genome sequencing. And at least 11 families in this study, they received some diagnostic information with implication on the clinical management. So it shows that whole genome sequencing has a utility in different settings, whether it's an acute care, whether it's outpatient, whether it's intellectual disabilities, or whether to trying to identify the medically complex diseases and patients. Sure. So I'll skip some of the slides here. This is the result limited setting. This is economic analysis from NICU setting, and we can see that economically also it makes a lot of sense to deploy whole genome sequencing in NICU setting. There are other studies going on. Next slide, please. I'll skip this. Why it is important to diagnose diseases? Because if you look at the pharmacological intervention, there are new therapies which are coming in nowadays, gene therapies, enzyme replacement therapies. And if we could diagnose these patients early enough, those patients could be really benefited from those therapies. Okay, so I will quickly move very quickly to some of the national projects which we have in India, because in India, we have high disease burden of genetic disorders because we've been genetically isolated in different regions on a base of religion, caste, etc. That has led to the higher prevalence of the recessive allele. And these are certain some of the initiatives which government India has started. UMID, there is a genetic, Genome India project to map 10,000 whole genomes in India, and rare disease policy which was rolled out in 2020. Okay, so I have time. I was told here, so I'll go this slow. Okay, fine. So this is very important for us to understand the national policy on rare disease here. Okay, so what is this policy is all about? So policy aims at screening and detecting rare diseases early enough so that we can prevent those diseases. And of course, it focuses on lowering the cost, it focuses on indigenous research and the production of the medicine. But policy direction is very clear that because of the competing healthcare priorities and the resource limited setting which we have, the focus is on lowering incidence and how the government want to achieve it by raising awareness on the rare genetic disorders, facilitating premarital, postmarital, preconception, and post-conception screening and counseling programs that will prevent the birth of children with rare disease. And third is enable access to the affordable healthcare to the patient with rare disease. So if you look at next slide here, the policy has divided rare diseases into three groups. The group one are the disorders which can be treated by one-time curative treatment. Group two requiring long-term and lifelong treatment, and group three, they have a definitive treatment, but patient selection is challenging. So under this policy, the patients who are falling into the group one will be given 20 lakhs of financial assistance for the one-time treatment. But for group two and group three, there is no financial assistance, and it relies majorly on the voluntary donations and the crowdfunding. So what does it? So in addition, the government of India has, or Ministry of Health, have notified 8 centers of excellences across the country for diagnosis, prevention, and treatment of rare diseases. Those centers will receive one-time financial support of 5 crore for upgrading the facilities for the genetic diagnosis. And also, ICMR has set up a national registry on the rare diseases to collect and very important data on which the policy decisions could be made. So what it means for us, what are the implications of this policy? So if you look at the policy doesn't define what is rare disease. So unless we have a proper definition of the rare disease, it is going to be very challenging for us to address the issues which surround these diseases. Secondly, the registry has been set, but the collection and the study of the epidemiological data and the clinical data is a complex task, which need a coordinated effort across the institutions and also the deployment of the focus resources. Third, the patients with one-time curative treatment may get benefited because they have financial assistance of 20 lakh. But the patients who are in group 2 and group 3, where there are enzyme replacement therapies or gene therapies available, they are at mercy of the voluntary funding or the crowdfunding. The NGS technologies will become more accessible, reason because we are setting up center of excellences across country. On other hand, the NGS cost is going down. So we may say increase in utilization of the NGS for patient diagnosis and also the prenatal or the preconception testing. The policy focuses heavily on the primary and the secondary prevention to reduce the disease prevalence. Therefore, the need and the role of the trained professional who can counsel patients in the family will become increasingly important moving ahead. So what is the future directions? Last couple of slides here for the genomics. The future of rare disease, we can envision the faster diagnosis thanks to NGS and high-throughput sequencing. The utility of the whole exome and whole genome sequencing and other omic platform like proteomics, transcriptomics, and metabolomics will increase. And that will definitely increase the yield of the diagnosis for this patient population. But there are certain limitations, and it is important to recognize the role of genetic counselors, which will role of genetic counselor will be very important in context of those limitations. For example, there will be a technical limitations of those technologies, patient privacy, ethical issues, limitation of identification and interpretation of the variants of uncertain significance, and secondary and incident findings. Some patients may have the multiple disease scoring variants, such as polygenic diseases and several genetic diagnoses at one point. So that will complicate the situation. That's the reason it requires expertise in geneticists, such as clinical geneticist, genetic counselor, and genetic laboratory geneticist to provide the enough information and the relevant information for support of this kind of patient.
Thank you, Amol. I think we will request you to stop over here. I gave you 2 minutes more because there was a technical issue. Uh, Are there any questions? One or two if we can take, otherwise we'll move it to the next speaker.
So these are my
Any,
conclusion
any
slides.
question? Import, anybody having, yes?
Hello. I just want to correct the Rashtriya Arogya Nidhi rupees 25 lakh is increased to 50 lakhs now.
Oh, that's great news.
Oh,
So
so
that is
that
not
people
reflected in
get that.
policy yet, but that's a great news there.
Thank you.
Thank you. Yes, Dipanjana?
Hello, sir. Nice presentation. I just wanted to ask you, are talking about WGS and we are talking about economy over here. Um, there will be a lot of variant of uncertain significance. We get it in clinical exam, like the smaller versions of exam itself. How do you justify doing a WGS in these cases? Maybe the undiagnosed ones are definitely there, but what about the simpler ones? Why do we need to go for WGS in those cases? Because again, we have to do a trio because otherwise it will not make sense, right?
Yeah, absolutely. And that's when I presented, the kind of, the patient journey, it really depends upon the phenotypic presentation. So if we have a clear phenotypic presentation, then the targeted test could be employed, which is more cost effective. But there will be group of patients who would have a non-specific clinical presentation or kind of, the ill-defined the phenotypic presentation. And the challenge in that group is the iterative testing which happens with a single gene assess, multiple gene assess. And hence the clinical utility is more for WGS in that group compared to the situation where you have a clear phenotypic presentation. Of course, when it comes to the economics part of it, there is no data in terms of the prevalence. There is no data in terms of healthcare utilization. So at this point of time, it is very difficult to prove the health economic benefit of WGS application in that group. But as we get more data on the prevalence, as we get more data on the healthcare utilization, and as the cost of the whole genome sequencing goes down.
Till now, what is the yield of WGS?
Sorry,
What is the yield of WGS till now?
till now, different studies have shown different kind of yield in different patient populations. So I presented certain in NICU setting, in OPD setting, in certain group like the intellectual disability and so on and so forth. So it's very difficult to say the yield in general because studies has been conducted in very subgroups. So ranging from some studies 15%, some studies show 70%. So it depends upon what kind of patient population you're looking at.
And those were new genes?
Sorry?
Those were new genes discovered or old genes only?
So those include the new genes as well because
What's the percentage and do you have any idea of the percentage?
so one of the studies looking at medically complex children, I think the yield was nearly 30% in that population.
Okay, thank you.
Thank you.
And also, I would like you to share with these youngsters over here as a genetic counselor, when you say increase in yield or CMA, holding, but do you think that you shouldn't give CMA at all and everything is covered in WES?
No, absolutely not.
That's what. So give that message very clear, as a protocol, especially with developmental disability and mental retardation. We know the gold standard is
Still
karyotype, which is still going on very nicely in the best hands in our country. And then if it is not, of course, for microdeletion duplication, we can go microarray. I think that's a stepwise, and then maybe whole exome. Would you agree?
Absolutely. So
Thank
whole
you.
genome. So if you look at the recommendations, right? So certain societies, certain experts, they recommend whole genome in tier 1, tier 2 testing, but in a very defined population and not as a blanket test. So we have to make a decision that where the whole genome will play a critical role in diagnosis. And it cannot be offered to everyone who's walking into the clinic.
No, because there are companies over here and the clinicians sometimes do not know. Of course, they are getting, knowledgeable throughout, maybe through our genetic counselors. But there is sometimes maybe we are, scared that a trend is that any case which they cannot diagnose, they are just prescribing whole exome sequencing.
Absolutely.
And that is a very, very alarming situation. And I think the genetic counselors are over here, they should take care of
So
it.
that is a
Thank
very
you.
important point. And in my conclusion slide, I made that point, that lack of access to the trained professional will increase definitely the cost of diagnosis, the incorrect test prescription, and the overall, anxiety for the patient. So it is very important for us to create that access to the trained professional who can be part with the clinician to really identify what is appropriate for that particular patient.
Thank you, Amal. We are moving on to the next
Thank you very much.
speaker. We have technical problems with Dr. Valeris, and my co-chairpersons over here, Dr. Rajeshri, will introduce the next speaker, who is going to be Dr. Chaitanya Datta.
Good morning, everyone. I'm Dr. Jayashree. I would like to introduce Dr. Chaitanya Dada. He's going to speak on case-based clinical approach to musculoskeletal disorders. He's a consultant, clinical and metabolic geneticist. He has more than 14 years of experience in this field, and he is consulted in various hospitals in Pune, and he is the director of Sujanan clinics in Pune, Mumbai, Nasik, and Sholapur. He has more than 30 publications to his credit, and he has written 4 book chapters and many lectures in national and international conferences. And he has edited a book on IEM protocols also. And his professional achievements, he is a member of various organizations, to name a few: IAM, ISIEM, etc. And his field of interest is dysmorphology, phenotyping, fetal autopsy, prenatal diagnosis, reproductive genetics, neurogenetics, analysis of next generation sequencing, and microarray data. So welcome. I will not take much time introducing because it is a very vast introduction. So over to you, sir. Dr. Chaitanya Datta.
Yeah, thank you so much for the kind introduction at the outset. A very good morning to everyone. I hope I'm audible. And if I can allow to share the screen. Yeah, thank you so much. So I hope now the screen is also visible to all. Okay. So at the outset, let me thank BGCI for this opportunity and a very good morning to everybody. Now, the topic that has been given to me is a little vast. It's musculoskeletal disorders, the clinical approach to that. So essentially, if you're looking at the human body frame, it would comprise of bones, joints, and muscles. So that together comprises what is the musculoskeletal system. So what we do is we first discuss about muscles, because that disorder group is quite vast, and then we go to the joints and the bones towards the end. So in muscle, when you're evaluating, the most important thing that we're evaluating clinically is something what is called tone. So when we're assessing the tone, it is the resistance to the passive movement. So you have to make a movement across or around the joint to assess the tone. So when that movement, so there is very less resistance to that movement, that is what is called hypotonia. Sometimes what happens, there is weakness. Now this weakness can occur because sometimes there could be the child is dehydrated or ill or something of that sort, so the child is weak, and therefore the muscle power or strength of the child is low. In that case, that is called weakness. So usually all weak infants will have hypotonia, but whenever hypotonia will present with normal alertness, so this child is quite alert, otherwise is quite well fed, but still the muscle tone is weak. So muscle tone being reduced is hypotonia, and when the muscle power is reduced, that is called weakness. On the other hand, hypertonia is increased resistance of muscles to stretching. We have a component what is called dystonia. So whenever this, what is dystonia? So essentially it's a movement disorder wherein there is a abnormality in muscle movement which occur involuntarily. So usually when the child is moving or trying to move, at that point suddenly the muscles would twist, and that repetitive twisting movement is what is called as dystonia. Now, when you're evaluating hypotonia, the abnormality can be at various levels in the brain. It can be in the brain, it can be in the brain stem, it can be in the spinal cord, it could be in the peripheral nerves, neuromuscular junction, or the muscle. Occasionally, when we're talking about hypotonia, it is sometimes synonymously called as a floppy baby. So usually a floppy baby is equal to hypotonic baby, but this sometimes can also include a weak, the babies who have weakness or sometimes even ligamentous laxity. So how does this tone abnormality really present itself? So it can be an antenatal period with contractures because of the poor in utero movements. Sometimes it can be a real floppy baby. Occasionally the child may regress in motor skills, may begin to show some proximal muscle weakness as we see in the Gower's sign there. And sometimes loss of independent ambulation may occur later in life. So when we are assessing a tone of a child, there should be two methods. One is the child should be at rest, and one is we are actively doing you're assessing the tone actively. So when the child is at rest, you have to evaluate if there is atrophy or wasting of the muscles or their fasciculations, and how is the child moving the limbs. You know, it's falling in a frog-like position like is shown in the picture, or it is moving the limbs well. And then what kind of weakness is there? So whether it is more of axial weakness or the more of appendicular or the peripheral weakness. And when we're doing the active testing or evaluation, you are doing various tests like you're putting the baby in prone, supine, you're flexing, extending all the and various tests are available in clinical practice wherein we can assess the tone quite well. Now, the hypotonia can occur in two ways. One is a central hypotonia, which involves more of the axial skeleton, as you can see in the picture, while usually these children have better peripheral strength. They won't hold their head, but they may roll over. So all these things, so that indicates that they have a central hypotonia. While peripheral hypotonia, as we classically see in SMA, they usually have more of a complete this thing where an absent deep tendon reflexes and the appendicular skeleton is involved. So again, we are looking at disorders at various levels. It could be a CNS disorder, wherein chromosomal disorders, metabolic disorders, injuries, brain asphyxias, hypoxic ischemic encephalopathies can all lead to a central cause. Then we have abnormalities at the motor neuron. The commonest disorder at the motor neuron is called as a spinal muscular atrophy. Then it can be at the nerves. So wherein congenital hypomyelinating neuropathy or in neuroaxonal degeneration at the nerve level. Then it could be at the neuromuscular junction, which is myasthenia as the commonest, and then the disorders of the muscle. So if you're talking about hypotonia, it is not only the muscular dystrophies and the myopathies we are talking about, it's a whole range which can be right from the brain to the smallest muscle unit. Now, central hypotonia, as we have discussed, it acutely occurs in cases of birth trauma, hypoxia, or hypoglycemia. But see the chronic causes, which include all metabolic disorders, the inborn errors of metabolism, chromosomal abnormality, peroxisomal disorders, endocrine disorders, all will present with central hypotonia. Well, peripheral hypotonia is usually the neuromuscular conditions, that is spinal muscular atrophy or your myasthenias or congenital myopathies, congenital muscular dystrophies, or even sometimes rarely metabolic myopathies also. Now, how do we differentiate clinically between the two? Now, something what we call floppy strong and floppy weak. In floppy strong, it's usually a central involvement. It's more of a central hypotonia or upper motor neuron disease, wherein the reflexes, when you elicit, they are increased. There could be clonus, when you're moving this thing, and then there'll be a vibrating type of a movement. The children will have an affected CNS, which they will have global developmental delay. They will have small head size. These children may not be very alert also. They may show convulsions, axial weakness. While when you're talking about floppy weak babies, they could have hyporeflexia or areflexia. They have preserved social and cognitive interaction. Like you see in SMA, these children are smiling, or even in Pompeii, children are smiling, looking at you, but they have severe weakness. So usually the weakness is in the anti-gravity muscles, and there could be a low-pitched cry, tongue fasciculation. That is when you're talking about a lower motor neuron. So when it's a central cause, you're investigating more generally, like you're looking at electrolytes, you're looking at calcium profile. You may have to evaluate for chromosomes. Metabolic conditions have to be evaluated by amino acids, organic acids, fundus evaluation, and a brain MRI. So whenever a central cause is suspected, you will have to look at the brain properly. When a peripheral cause is suspected, when the child is otherwise alert, we are looking at CPK, we are looking at lactate, we are looking at EMG NCV studies, occasionally muscle or nerve biopsy, and more of genetic testing here would give us the yield. Then you have some pickup clues based on certain evaluations. These are some brief things which which help us in deciding as to which conditions it could be. Like it could be dysmorphic baby, the head size, the intelligence. When there's a cardiac enlargement, we are looking more at Pompe disease. ophthalmic involvement, we are looking more at possibilities of peroxisomal disorders or congenital muscular dystrophies. When there's a visceral enlargement, there's organomegaly. Again, you're looking at a storage condition. If there is a reduced fetal movement with polyhydramnios in the antenatal period, you're looking at a neuromuscular condition. You're looking at the face. If it's very, very myopathic, or a drawn type of a face, you're looking possibly at a neuromuscular condition. So all these are various clues which help us in picking up the overall differential among the many hypotonia disorders. So if perinatal risk factors are present, you can suspect an HI. If there's significant central hypotonia, but the child is very alert and showing very good response or tongue fasciculations, you're looking at a spinal muscular atrophy, a very dull myopathic face, MRI abnormalities are noted. You may be looking at a myotonic dystrophy or congenital myopathies here. When the baby is very lethargic, not alert, and there is increase in progressiveness with neurological involvement with seizures, you have to evaluate for metabolic causes. If there's dysmorphism, again, you'll need to evaluate for karyotype and by arrays. And again, a few conditions wherein very, very poor suck, a real floppy baby, lethargic, weak cry, you may have to look at a Prader-Willi syndrome. So various genetic causes can lead to this. Common ones are Down syndrome and Prader-Willi, which leads to a hypotonic baby, but various other syndromes as well. Now, this baby presented with neonatal seizures, weak cry, dysmorphism, microcephaly. You can see the significant dysmorphic faces, see the abnormal curvature of the spine. So this indicates that the child already had hypotonia in utero. So these are indications that it could be a central cause based on the dysmorphic features. You will have undescended testicles as such. Now, this baby turned out to have a chromosomal or karyotype abnormality. This is in those days wherein karyotype was more routinely done than today. Nowadays, everybody is going for exome, as the way Madam was suggesting. Then you have certain cases wherein there is dysmorphism. Now, this baby has a significantly myopathic type of a face with short stature, cardiac involvement. So you are looking at a spectrum of or multisystemic kind of involvement. So here you are obviously first going to consider a microarray, and here it showed up as a Jacobson syndrome. So chromosomal level issues have to be evaluated when there is significant dysmorphic features which are noted. Then going to the metabolic disorders, the commonest metabolic disorder is obviously Pompe disease, which presents with hypotonia. It has two components. One is infantile onset Pompe, wherein the cardiomyopathy onset is before 12 months. And sometimes the onset will be in utero. They could have hypotonia, generalized weakness. There could be feeding difficulties, failure to thrive, and a hypertrophic type of a cardiomyopathy. While late onset Pompe disease is of two kinds. One is individuals without a cardiomyopathy, or those all individuals wherein the onset there is a proximal muscle weakness. So sometimes they can just present with a Gower sign being positive. And later on, we just find out that they have a Pompe disease. So whenever we are evaluating for such proximal muscle weakness, even at a later date, Pompe disease is one of the important differentials. Fairly common condition in our population. So wherein we can do an EMG which shows a myopathy, but enzyme studies, which is alpha glucosidase enzyme deficiency, and a definitive diagnosis by GAA gene sequencing or even deletion duplication studies is crucial in diagnosing. We know that enzyme replacement therapy is available, but we are all aware about the cost implications of the same. But nevertheless, we can always offer a definitive diagnosis for future prenatal diagnosis. Now, some children wherein this child was severe, has seizures, lethargy, paucity of movements. You can see the large head size, sparse head. So here, obviously, we are possibly looking at a central cause, and we do a metabolic evaluation by a TMS and GCMS, and you find it's a maple syrup urine disease. So we must remember that hypotonia, not all conditions will be a neuromuscular condition. You have to think of other conditions as well. Now, going beyond the metabolic conditions, this particular case, you can see the child is a little macrocephalic, came with delayed development, was smiling initially, but then regressed, now has no head control whatsoever. And obviously the next line of investigations in these cases is going to be an MRI, which is suggesting a definitive involvement of the subcortical U fibers and the large NAA peak. And definitely this, based on the presentation, you have done the MRI, you have the clinical picture, it is strongly suggestive of a Canavan disease. So which is diagnostic, the diagnostic test is NAA levels in the urine, or the ASPA gene mutations have to be considered. Then now we are going to the motor level. So we have seen that the central level hypotonia will present with either dysmorphism, a global developmental delay, with or without intellectual disability, along with associated sometimes metabolic conditions also will have more of a central hypotonia. Now we are moving to the motor unit, which is actually the muscle unit. So the commonest condition we are aware is a spinal muscular atrophy. So we are aware that two genes are there on chromosome 5q, the SMN1, which is telomeric, SMN2. Both have almost similar sequences, except at this particular point, 840C to T, and that causes a full-length transcript to be coming from SMN1, but only less than 20% of the transcript or even 10% of the transcript from SMN2. So essentially, when SMN1 is active and there is no mutation in exon 7 and 8, a full-length SMN2 protein is produced. But if this protein is absent, then the entire thing would be on the SMN2, which produces very little protein actually. But it is very, very important that we are evaluating for SMN2 copy numbers whenever there is an SMN1 deletion. If SMN1 is normal, then there is no, the SMN2 copy number is immaterial. So we have cases which vary from the most, mildest to the most severest form. So mildest form will be, severest form will present very, very early at around 6 months of age with severe hypotonia. And sometimes we have seen a 55-year-old individual who was walking normally. He had a fracture, fell down, and thereafter he became non-ambulatory and was found to have SMN1. So there's a vast a continuum of this particular condition. So always we are going to consider SMN1 deletion duplication testing first by MLPA, and then based on that we are going to evaluate for SMN2 only if SMN1 is deleted. Essentially, if SMN1 deletion duplication is absent, there is no deletion duplication exon 7 or 8, we go for SMN1 gene sequencing. But we must be aware that there are other forms, which are atypical forms of SMA, which we come across quite common. One with a very, very severe arthrogryposis multiplex-like condition. Then there is a SMARD-like form wherein there is a severe ventilatory dependency of these babies. SMALED, which occurs a little later in life, wherein it's only a lower extremity involving type of an SMA. So there are various, it's a large spectrum of atypical forms as well. Then going to the various muscular dystrophies. Now, what we know is that the muscle unit has numerous proteins within it. So dystrophin is here, you have sarcoglycans, you have dystroglycans, laminins, etc. And all these proteins or mutations in any of these will lead to a neuromuscular condition. And we have a whole big list of the commonest dystrophinopathies, that is Duchenne or Becker. Then the non-dystrophinopathies, we have calpainopathies, dysphorinopathies, sarcoglycanopathies, which are now differentiated by the means of the genes. So it is essentially now gene-based classification that we follow. Then we have a congenital muscular dystrophy, Emery-Dreifuss muscular dystrophy, myotonic dystrophy, and numerous such conditions. The commonest, again, is a Duchenne muscular dystrophy. So we are all aware of it. But what we must always understand that Gowers sign being positive is not the only, DMD is not the only differential. You can have it in many, many other limb girdle muscular dystrophies, Pompe disease, congenital myopathies also. Here we are aware that 70% of the mutations will be gross deletions in one of the exons tested by MLPA. And if it is negative, we proceed with the sequencing to find out the rare point variants, which is there in 30% of the cases. Going for the further congenital muscular dystrophies, which is a very, very large spectrum. But one thing that we must remember in these cases is that there is weakness which is noted at birth. CNS abnormalities are very common and they would have contractures. So these 2-3 things differentiate a CMD from a congenital myopathy. So in muscular dystrophies or CMDs, we have to evaluate for the brain. We have to look at the brain wherein we see a large number of cases wherein, like a muscle eye brain disease, wherein a significant involvement of white matter would be noted. Ophthalmic evaluation is necessary along with the EMG and CV. And in some cases, biopsy may precede the genetic testing, but rarely. But again, as we mentioned, nowadays the classification is more gene-based, and we call that the various types of these things, and they are increasing by the day. But essentially, the diagnosis is by exome sequencing. Now, there could be some associations. Like in this particular case, it's a non-consanguineous family. This child had a motor delay. So independent sitting at 9 months, she walked at 5 years. She's unable to walk. She has other features. She has autism. She has behavioral issues, very severe behavioral issues. And when further investigations, everything turned out to be normal. The MRI was normal, BERA was normal, and she was diagnosed to have moderate autism. when they underwent a muscle biopsy, and wherein a very typical presentation was seen, wherein there was significant absence of mitochondria from the core, and this turned out to be something what is called as a megaconial congenital muscular dystrophy. So again, the spectrum is increasing, and we are finding various associations. So along with, in this case, a muscular dystrophy, there was associated autism as well. Then some muscular dystrophies are very typical. When the child comes to your OPD, you understand that this could be one of the Ehrlich or Bethlehem type of a congenital muscular dystrophy, which is called 6A1 related. But again, there are many, many complexities of the COL6A genes, which we know. So wherein there could be diagenic inheritance, there is heterozygous, homozygous variants, which are noted in these genes, and they all complicate the scenario for genetic testing or evaluation for some of these congenital muscular dystrophies. Now, what is the role of muscle biopsy? Now, usually it is not used as a first line test anymore. It is usually maybe used for confirmation of the VOUS which is obtained on exome sequence. Still, it has that particular role where it could be used, to resolve whether the VOUS is actually a significant one or not. It is invasive. There are very few labs who are doing this. It requires significant expertise, not only in sample collection, but transport and processing as well. So there are many, many challenges here. Now, from the hypotonia spectrum, we are going to a hypertonia spectrum. What we must remember is many of these hypotonic cases who are early on hypotonic may become hypertonic later on, especially whenever they have brain involvement. They appear as very, very floppy babies earlier, but later on, as age increases, they become hypertonic or spastic. Now, in hypertonia, we must focus more on the metabolic conditions, various metabolic conditions, neurotransmitter disorders, leukodystrophies, will present with a hypertonia or spasticity, which is a genetic in origin. And there's a spectrum called hereditary spastic paraparesis, so which involves usually sometimes only the lower limbs or the distal upper limbs also. The acquired causes are more commonly causing spasticity, which involve hypoglycemic or hypoxic brain injury. There could be birth trauma, meningitis, encephalitis, or infections. Okay, so you can see the list wherein the disorders which cause spasticity. If you look at it, majority of them are related to a metabolic spectrum. So inborn errors of metabolism, errors of neurotransmitter disorders, and various single gene conditions which are responsible here. None of the, and as I mentioned earlier, many of these neuromuscular or hypotonic conditions initially, they will progress later on to spasticity. Now, some of these conditions are very, very treatable. Like you can see this particular case where I'm highlighting the dystonic part of it. You can see the spasticity or the tightness and the twisting of the muscles there. And this turned out to be a non-PKU hyperphenylalaninemia, which is because of the PTS gene mutation. What we are knowing that this is a treatable condition. So if you start Dopa, this child is going to school. So essentially, some of these conditions will have very, very good treatments. Argininemia, biotinidase deficiency will also present with spasticity. Now we're going to the next part, which is the joints. Now, joints, there can be issues at two things. One is there could be contractures, that is tightness of the joints, or there could be laxity, looseness of the joints. So whenever you're talking of contractures, we are looking at an arthrogryposis spectrum, which is a huge spectrum. So various arthrogrypotic disorders are known. Then secondary to neuromuscular disorders, because there's significant hypotonia and the joint remains in the same position for a long time, and therefore it becomes there's a contracture at the joint. Various storage disorders and genetic syndromes also lead to that, while joint laxity is more so because of the common connective tissue disorders. Some of the common conditions which lead to a spasticity or abnormal, joint abnormalities, sometimes laxity in cases of Morquio, and contractures in cases of other MPS types. So you can see the MPS is one of the commonest metabolic conditions which will present with a joint abnormality. Then again, here you are seeing a case of a cutis laxa type 3, which is a progeroid syndrome of Bibarsi. So you can notice that there is significant pectus excavatum, very thin skin. You will always appreciate an umbilical hernia, and wherein there is a hyperextension or laxity of the joints, which will be noted in these cases associated with dysmorphism. So when you're assessing a case of a connective tissue disorder, you're looking at various points. You will always, as I mentioned, you'll see various hernias being present. See the foot position, so this is a lax type of a joint which is noted because it is getting straight when you're making the child stand. Okay, so it is the laxity, the tone is normal, muscle bulk is normal, but it is then you can see the skin which is hyperextensible and the joint which is hyperextensible. So when we're evaluating a case of a connective tissue disorder, these three things have to be evaluated properly. Occasionally, what you will find is sometimes the baby will have a very, very painful joint movement. There are very few conditions, including some of the immune conditions, which will have painful joint movements. One of this is this. Here you can see that the child has normal tone otherwise, but has developing contractures because the child is keeping the limbs in a fixed position. And essentially, it's more looking like an arthrogryposis syndrome. But when a genetic evaluation was done, this is what is called hyaline fibromatosis syndrome or infantile systemic hyalinosis, wherein there is hyaline material which is getting deposited. A very, very bad condition to have because these children have very severe joint pains. They are unable to move their limbs. Later on, they'll develop various, cutaneous eruptions around the mouth, around the ears, but that develop quite later. But initial part, you can always see this kind of hyperpigmentation and thick skin developing at the joint. So that gives us a clue that this is not an arthrogryposis, but possibly a hyaline fibromatosis syndrome. Now, you can have a combination of conditions. Like, for example, this child is almost 9 years old, and you can see the abnormal this thing, and at the same time associated with laxity of the joint. You can see you can almost flex the joint entirely, but it is associated with other skeletal abnormalities. So again, a combination of a muscular skeletal dysplasia associated with this turned out to be a KIF22 related spondyloepimetaphyseal dysplasia with a joint laxity. So this is a dominant inheritance wherein two siblings are affected and the mother is also mildly affected. So again, you will have varied type of patterns of inheritance for these conditions. Now, to the last segment, we'll go to the bone. So wherein you'll have the bone which is under-mineralized. So under-mineralized bone, the commonest condition, you will have osteogenesis imperfecta. We know that there are multiple genes which are involved. There are various inheritance patterns and variable expressivity also. In the same family, you will have individuals who have the genetic mutation, but they will not manifest. And their children perhaps may have very, very severe early onset of fractures. So very varied severe expression is known, and varied inheritance patterns are also known. You can see that there's significant hypomineralization, and therefore the bones break quite easily. Similar to hypomineralization, there can be hypermineralization, as you see in osteopetrosis type. But osteopetrosis will have a very typical presentation wherein they'll have relatively large heads, they'll have optic atrophy, hearing loss, and some bit of dysmorphic features or more fullness of these faces because of the bone involvement. And here you see that the bones are very, very dense, and there is osteopetrosis which is noted in this. Now, in this case, it was a SNX10 gene related osteopetrosis. Then bone abnormalities can include abnormalities of the bone length, which can vary from the severest, which is a thanatophoric dysplasia, which is usually diagnosed in utero, to milder presentation of achondroplasia, to individuals with hypochondroplasia who would have a moderate type of a short stature. So all these are FGFR3 related, but it's a big spectrum, again a continuum, wherein from the severest to the mildest it could vary. Then there can be some syndromes wherein, the clues based on the evaluation that you would do will tell us about the diagnosis. Now, this individual has peg-shaped teeth. You can see the pectus excavatum, a very severe scoliosis, a mono atrium is there, a single atrium, along with a polydactyly. And this is nothing but Ellis Van Creveld syndrome. So evaluating the individual completely. So even if you're looking at a possibility of a skeletal abnormality, we should evaluate the heart and look at the other organs as well, because they will give us a clue towards a specific diagnosis so that you do not have to really search for multiple genes. Now, when you're evaluating the bones, always it has necessary to look at the entire skeletal survey. So look at everything together. Now here, if you look at it, it is more so a thoracic narrowing which is noted. The other long bones seem to be fine. The skull bones seem to be fine. And this is something what is called as a short limb asphyxiating type of a thoracic dystrophy, when there's significant thoracic narrowing which may be noted. So generally these children will have some antenatal presentations, but as they are born, there is a significant the respiratory distress which comes in at around 4 or 5 months of age, and there is early demise in these children. Now, when we're evaluating skeletal dysplasias, typically, again, as we mentioned, it should be based on the entire evaluation. Now, this child presented short stature, with dysmorphism. So you can see the dysmorphic features here. There was significant intellectual disability with behavioral issues, and even limb abnormalities were noted. So as I mentioned, when we are evaluating for bones, it should be an entire skeletal survey which should look at all the bones. It should not be only an X-ray of left hand and wrist or only X-ray of the pelvis. So here, if you look at the bones, sometimes you can see this platyspondyly, which is very much limited to the thoracic region. So you can see the wedge-shaped thoracic vertebrae. Then here you will see the abnormal or narrow type of a pelvis. The coxa vara deformity is noted. Very short femur necks are noted. And if you look at the skull, there is a copper beaten appearance. You have those kind of vessels which are there. So copper beaten appearance of the skull is seen. So along with that, you have significant epimetaphyseal dysplasia, which is there. So you can see these, the metaphyses and the epiphyses are completely abnormal of all the bones. And you can see the significant thinning of these bones also. So now in this particular case, when the child came to me, we first asked for a skeletal evaluation. And thereafter, just based on the clinical and skeletal evaluation, we had reached a conclusive clinical diagnosis of this SEMD or spondyloepimetaphyseal dysplasia of the Fadin-Alkuraya type. And genetics did confirm that. So essentially, a proper clinical phenotyping is essential to be able to reach a definitive conclusion as regards to skeletal dysplasia. So similarly over here, you can see this child is presenting with consanguinity. There's increasing motor issues which are noted. EMG is suggestive of a myopathy. But if you look at the bones, you can see the severe osteolysis, almost no bone at the mandible. So it's almost like a flat thing which has happened. So essentially, we found that there was not only involvement of muscles, but involvement of bone as well. Okay, and when we evaluated further, we could find that yes, there are a lot of other issues. You can see the distal phalanges; they are almost acrolized. So this distal acrolysis is noted, and you can see almost loss of fat here in the fingers. Okay, and thinning of the limbs also. So a proper phenotyping sometimes helps us in leading to a clinical diagnosis, which in this case was something called as a mandibular acral dysplasia with skeletal abnormalities and a progressive osteolysis. So when you're evaluating this musculoskeletal system, as I showed you in some of these cases, it sometimes may not be limited to a particular system alone. There can be a combination of various things which would be there, and therefore a proper clinical evaluation is very, very essential before we really proceed for the further genetic testing. So I would summarize with only 2 points. One, musculoskeletal disorders will have significantly overlapping phenotypes, but a proper clinical evaluation and baseline investigation. We never should forget baseline investigations, because nowadays people are used to just writing down exome sequencing without really doing a proper phenotype. So therefore, and in most of the cases, they land up with some BOUSs in that case. So we have to be really certain about the clinical phenotype. So go for X-rays, go for USGs. In case of musculoskeletal disorders, go for EMG and CV as required. Come to our clinical diagnosis and then order your genetic evaluation. So I think I would end my talk here so that I'm open to questions if there are any at this point. Thank you so much.
Thank you, Dr. Datar, for that lovely illustrations and taking us through these skeletal-muscular disorders. We are going to have a question answer in the end of the session. So
Sure.
there is one more speaker last. The talks by Valerie is cancelled, and that will be introduced by. So please be with us, all the speakers. In the end, there will be question answer. And over to Dr. Lakshmi, who will be introducing the next speaker.
Good morning, all. I'm happy to introduce Dr. Monish Suri. He's a consultant in Department of Genetics, Nottingham University Hospital, NHS Trust, UK. With regard to his academics, he has done his medicine Maulana Azad Medical College, Clinical Fellow Pediatric Neurology and Genetics, All India Institute of Medical Sciences, Clinical Genetics Training in Kennedy Galton Center, Harrow in UK. His interests are clinical dysmorphology, skeletal dysplasias, pediatric ataxia, and several other malformations. Career highlights: elected to FRCP of Royal Colleges of Physicians, running Nottingham Skeletal Dysplasia Clinic since July 2000, clinical lead for the National Pediatric Ataxia
Honorary Clinical Associate Professor, School of Medicine, University of Nottingham, Associate Editor of Journal of Medical Genetics and European Journal of Medical Genetics. We welcome him for his talk. Thank you.
So thank you very much. I hope you can all hear me. And thank you so much for the introduction and also to the BGCI for asking me to give this talk. I'm just going to share my slides now. So I hope you were able to see my slides. Can someone confirm that you can actually hear me and see my slides?
Yes, sir.
Okay, great.
Yes, we
Thanks
can
very
see.
much. Thank you. So the title of my talk is Genetic Counseling and Skeletal Dysplasia, and quite a lot of that of information about skeletal dysplasias was already given in the previous talk by Dr. Datta. So thank you so much for that. So in this talk, I'll just briefly mention about the 2019 nosology of the skeletal dysplasias, which is like a classification system. And then I'll talk about a few of the things that Dr. Datta also mentioned, which is that with one gene, you can have multiple phenotypes, or you might have a single phenotype, which is a good, well-defined phenotype. But in fact, it may be caused by many different genes, and there may be different inheritance patterns, which complicates the counseling of these conditions, the genetic counseling of these conditions. Then you might think of some types of skeletal dysplasias as skeletal dysplasia plus. In other words, these are dysplasias that have additional finding outside of the skeletal system. And one of the examples that Dr. Datta gave was Ellis Van Creveld syndrome, where obviously you can have quite severe cardiac anomalies, congenital heart anomalies, in addition to the bone dysplasias. But there are others as well. I'll briefly talk about situations where you might have to counsel where antenatally scans have shown that the baby has a skeletal dysplasia. And obviously this can be either a lethal or a non-lethal skeletal dysplasia. Then there are some other complex counseling situations which need to be addressed. The first is where both parents have achondroplasia. What are the risks of their children? How do you counsel in that situation? How do you counsel in the shocks-related dysplasias? How do you counsel when couples have two different skeletal dysplasias? What are the risks to their children? And how do you counsel there? Now, just briefly talk about gonadal mosaicism, which obviously again can complicate the counseling of offspring recurrence risks in skeletal dysplasias. And then just very briefly mention about the different treatments that are coming on stream for many skeletal dysplasias, which obviously will change how you counsel patients and families with these conditions. And just one slide for my conclusions. So what are the skeletal dysplasias? So these are genetic bone dysplasias, and there's a very nice classification system which is currently in its 10th version, and that's called the 2019 Nosology of Genetic Skeletal Disorders. And in total, these disorders comprise 461 conditions, which are caused by 437 genes. And the classification system is actually three-pronged. So you have some of the dysplasias are classified on the basis of clinical findings. So for example, mesomelic dysplasias. So that means the middle segment of your limbs is shortened. There are others that are classified on the basis of the radiological findings. So for example, you may have platyspondylic skeletal dysplasia. So there you're describing very severe flattening of the vertebral base. And then obviously you have a whole group of skeletal dysplasias that are classified according to the underlying gene that causes it, for example, FGFR3 related chondrodysplasias or COL2A1 related skeletal dysplasias. So the nosology is a very good place to begin. It is also a very good reference. If you're stuck with finding a diagnosis for a patient with a definite skeletal dysplasia or even a dysostosis, which is where you have abnormalities that are limited not to the whole skeleton, but maybe just a few bones, maybe just like, for example, the head, like the craniosynostosis, for example. And this is the last version of the nosology, the 10th version, which was published in American Journal of Medical Genetics in 2019. I understand that, in fact, this nosology is currently in the process of being revised. and probably in the next couple of years, we'll have the next nosology, the next version of the nosology. So just look out for that. So what did I mean when I spoke about one gene, multiple phenotypes? So this is actually group 1 of the nosology. So this is severe Dan, achondroplasia, hypochondroplasia. These are all caused by gain of function variants. So basically, the FGFR3 receptor is constitutively active. But if you have a loss of function of this of the FGFR3 receptor, you get a slightly different skeletal dysplasia, which is called CATCHL, which stands for camptodactyly. So you get bent fingers, tall stature, and hearing loss. So it's very different from what you usually assume to be an FGFR3 related chondrodysplasia. So the one gene can give you many phenotypes. And this is quite important, particularly when you're counseling in skeletal dysplasias. And then the flip side of this is that you have a very nice defined phenotype. And you might say, oh, well, this is likely to be caused by a variant in a single gene. And in fact, it isn't. So for example, Stickler syndrome, which is something that you can recognize clinically because of the facial appearance of these individuals. They have cleft palate, they may have a pair or mass sequence type presentation. They will have ocular findings as well. They can have congenital myopia, cataracts, vitreoretinopathy, retinal detachment, and joint laxity, and all of that. And obviously, the bone dysplasia that goes with it. And the vast majority of Stickler syndrome is caused by variants in COL2A1, but you can also get Stickler syndrome if you have monoallelic variants in COL11A1, COL11A2, COL9A1, and COL9A2. And then there is a recessive type of Stickler as well that can be caused by biallelic variants in COL9A3. So you just need to be aware of that. And similarly, another very frequent condition that we see in our skeletal dysplasia clinics is multiple epiphyseal dysplasia. And so the growing ends of the bones are the ones that are affected. And it's a very painful condition. It often starts when the child is around 3 or 4, and the child usually presents with a waddling gait. And again, the vast majority of MED is autosomal dominant, and it's caused mainly by variants either in one copy of COMP, cartilage oligomeric matrix protein, or matrillin-3. But you can get MED, dominant forms of MED, due to variants in COL9A1, COL9A2, and COL9A3. And then you have 2 recessive forms. So it's again very important to know this, that you don't always counsel in an autosomal dominant manner, because there are situations where somebody has MED, but in fact, the underlying cause is a biallelic SLC26A2 variant or a CANT1 variant. And just to sort of stretch that thing out, that point out a little bit. So SLC26A2 will give you autosomal recessive multiple epiphyseal dysplasia. But more severe variants in the same gene will give you dystrophic dysplasia, which is a very severe type of autosomal recessive skeletal dysplasia. And the same is true for CANT1. So if you have biallelic variants in CANT1 and the variants are relatively mild, you'll get a multiple epiphyseal dysplasia. But if you have more severe variants in CANT1, then you get a much more severe skeletal dysplasia called Debouquard dysplasia. So all of this really makes counseling complicated. And then I come to what Dr. Datta was also talking about, which is these entities called skeletal dysplasia plus, which is where you have a primary bone dysplasia, but the child also has additional problems outside of the skeletal system. So for example, the child might have an immune deficiency, such as in cartilage hair hypoplasia, also in Schimke, and also in spondyloendochondral dysplasia. They can all have immune deficiency. And it can be a pretty severe immune deficiency. And in fact, that may be what is responsible for the child dying. And in fact, you may need to treat that quite urgently by bone marrow transplant, stem cell transplant or something. Or you might have skeletal dysplasia, where again, the primary problem may not be so much the skeletal dysplasia, but a pancytopenia that accompanies it, such as you get with Schwachman-Diamond syndrome. Or you may have a skeletal dysplasia, but the main problem of the child is a neurodegeneration or an abnormal neurological presentation, such as you might get with MOPD1 or spondyloendochondral dysplasia, where you can get spastic diplegia, you can get spastic quadriparesis, you can get calcification inside the brain. And lastly, you might get, so I've already alluded to skeletal dysplasia and congenital heart anomalies in Ellis Van Creveld, but you might get a skeletal dysplasia. And the primary problem, again, is not so much the skeletal dysplasia, but that the child presents with nephrotic syndrome. And you can get that sort of presentation with Schimke immunoosseous dysplasia, which is an autosomal recessive skeletal dysplasia caused by biallelic variants in SMARCAL1. So how do you approach the counseling situation? It's not easy. But these are 5 things that you should ask yourself. The first is there parental consanguinity? This is very important. Secondly, are there other affected family members? Is there an affected sibling? Is there an affected parent? Is there an affected cousin? Do you have a radiological diagnosis for this child? In other words, have you already made a diagnosis of what type of skeletal dysplasia it is based purely on radiology? And then, have you followed it up by actually confirming that genetically? Do you also have a genetic diagnosis? Do you know whether the cause is a monoallelic variant or a biallelic variant? Is it caused by a variant on the X chromosome? These are all very important things that you need to understand. And then the 5th question you have to ask yourself, and this is where you come to the skeletal dysplasia plus phenotypes. Does your genetic variant that you have identified explain the entire phenotype? So you have to ask yourself these questions before you are able to counsel properly. So here's what may happen. So we had a 10-year-old child with skeletal and ocular features of Stickler syndrome. There was absolutely no doubt about the diagnosis. So we looked at the x-rays, and those were also consistent with the diagnosis of Stickler syndrome. So in those days, before we had access to trio exomes and trio genomes, we used to have small panels, and we tested the child on a 5-gene Stickler syndrome panel that had all of the most frequently seen variants responsible for Stickler. So call 2A1, call 11A1, call 11A2, call 9A1, call 9A2. Nothing was found. We were stuck. We went back to the family tree and found parents were first cousins. So now you start thinking, oh, maybe this is a recessive Stickler syndrome. So this time we did a trio whole exome, and the child was in this 30-year-old gentleman. He had come to us already with a diagnosis of brachyolmia. So that's a type of skeletal dysplasia that primarily affects the spine. You get platypus spondyli, so you get short trunk, short stature. You can get mild metaphyseal, sometimes epiphyseal changes as well. So it's not always purely just a spinal problem. But interestingly, he also said that he had a diagnosis of sensory motor neuropathy. So he had the skeletal dysplasia, and he had a neurological entity with it. So skeletal dysplasia plus. He and his partner were planning a pregnancy. He and his partner were unrelated, and they were wanting to talk about risks of recurrence of this man's problems for their kids. The man didn't have any other family history, so there was nobody else in his family with brachyolmia or the sensory motor neuropathy. So we arranged an urgent singleton whole exome on this gentleman, and we found that he was heterozygous for a pathogenic missense variant in TRPV4. And that we were quite happy that that fitted in with his clinical diagnosis of brachyolmia. So that is autosomal dominant brachyolmia type 3. But what about the sensory motor neuropathy? We'd done a whole exome, we found nothing else. So, and this was well, it wasn't gene agnostic, but it was a pretty good test, and we hadn't found any other variant. So again, we had to go back and look at the literature, and this is what we found. When you go back and look at the literature, you see that if you have monoallelic pathogenic variants in TRPV4, it can give you a type of hereditary motor and sensory neuropathy type 2C. And in fact, there are reports of one individual, and obviously other individuals that have a variant in TRPV4 and have both a brachyolmia and a sensory motor neuropathy. So in fact, his whole phenotype was explained by that variant that had been identified. And we were able to give him and his partner proper counseling to say that there is a 50% chance of the children having, in fact, both conditions could occur together. So then they went in for a prenatal diagnosis on the basis of that. So I come now to some of the antenatal situations that you might find you have to counsel for. So the first situation might be that you've seen a couple, they're pregnant, they've had detailed scans in the pregnancy, and the scans clearly show that the baby has a lethal skeletal dysplasia, possibly thanatophoric dysplasia type 1 or campomelic dysplasia or whatever. So this is actually not a difficult counseling situation, but it is very likely that the parents will choose to terminate the pregnancy. But it is always a good idea that even though you are fairly convinced on the basis of the scans that this is a latent skeletal dysplasia, then in fact you back it up either by non-invasive prenatal diagnosis or perhaps a fetal exome, so that you're absolutely sure that you are giving them the right advice, that this is not a survivable skeletal dysplasia. If parents choose to terminate, it's a good idea to try and get it postmortem, or at least to try and get a babygram done so that you can try and confirm the diagnosis. If the parents elect to continue the pregnancy, obviously you have to raise neonatal alerts so that the neonatal team are aware that a child will be coming. And it's very likely that child is going to die soon after birth. And so they need to make sure that the child is comfortable without actually doing anything too heroic to try and save that baby, because you know that that's lethal skeletal dysplasia. So again, those are some of the counseling situations you might face. But in fact, the most common situation is this, where you have a fetal scan that shows a non-lethal skeletal dysplasia, such as achondroplasia. And here, of course, you have to counsel about the clinical features, the complications of achondroplasia. You have to tell parents that these children they are very likely to have normal intellect. There are a lot of high achievers with achondroplasia. We have a number of Paralympic athletes in the UK that have achondroplasia. But of course, there is the emotional and the psychological effects on the child, and even Paralympic athletes are subject to so much abuse that, yes, when they are there in the Paralympics, they get a lot of exposure, but when they come back out of the Paralympics back to normal human life, then they get a lot of abuse. And now, of course, there are complications because vosoritide is available for treatment in Europe and in the United States. So obviously that you will have to talk to parents about the potential treatments as well, although maybe that is not, in the UK, we don't have that available. Probably next year, NICE will make a call on it. So we are not bothered too much about it at the moment. And also there's the cost of vosoritide. So it's around £650 every day for the injection, for a single vosoritide injection. And then you have this situation where, again, antenatally, you have found that the child has a possible skeletal dysplasia. So we had a couple who had antenatal scan that showed a very small nose and possibly mild limb shortening. And we did a fetal exome, and we found that the baby had a maternally inherited aryl sulfatase E variant, and so that would be consistent with the diagnosis of brachyteliophalangeal chondrodysplasia punctata. So here there's not a lot of information available about these conditions. We can tell parents, yes, look, there'll be some dysmorphic features. There may be some effects on the spine. There might be mild limb shortening. The distal ends of the fingers may not be so well formed, but that most of these patients have normal intellect. But there are other entities, and one of those was presented again by Dr. Datta, SEMD, Fabinal type. So again, we don't have huge amounts of information about those disorders. So you might have to do the counseling based on very little knowledge about these disorders, because there isn't that much out there. Then we come to this vexing situation of where both parents have achondroplasia. So in this situation, 50% of the kids will have heterozygous or classical achondroplasia. 25% of the children will have homozygous achondroplasia, and 25% of their children will have an unaffected pregnancy. So heterozygous achondroplasia means that the children will be like the parents, and most parents with achondroplasia would choose to continue with those sort of pregnancies. But if the child has homozygous achondroplasia, which means that the child has inherited the FGFR3 variant from both parents, and therefore has homozygous FGFR3 variants, this is very severe. It is often lethal and is very similar to thanatophoric dysplasia type 1. So we would expect, and we would have no problems with parents wanting to terminate a pregnancy where the baby had homozygous achondroplasia. But then again, the situation arises that parents sometimes ask us, look, how are we going to manage an unaffected pregnancy? Our whole house has been adapted for small people. And here we're going to have a child who within, about 5 or 6 years will have outgrown the parents and will be bigger. There's all this thing about parental authority, in a house that's been adapted for small people. How do we manage a child of normal stature. So that might need a little bit of discussion with parents and to try and work that through. I move on now. I don't know how much time I've got left. Probably not much. So I'm moving on to shocks-related dysplasias, and you probably know all about these. So you have Leri-Weill dyschondrosteosis, which is inherited in a pseudo-autosomal dominant manner, and Langer-mesomelic dysplasia that is inherited in a pseudo-autosomal recessive manner. Remember, there is a shocks gene on both the X chromosome and also on the Y chromosome in the pseudo-autosomal region, one, and that there is one obligatory recombination event between the X and the Y in males during meiosis 1. This is very important. So if you have one parent who has Leri-Weill dyschondrosteosis, that's straightforward. There's a 50% chance of their children having Leri-Weill dyschondrosteosis, regardless of the transmitting parent and regardless of the sex of the baby. And I'll explain in a minute why. But if both parents have Leri-Weill dyschondrosteosis, if both parents transmit the shocks variant to the child, who therefore has biallelic shocks variants, then that child will have Langer-mesomelic dysplasia, which is a much more severe form of mesomelic dysplasia with very severe micromelia and with absence of the fibula and also the ulna. And then there's a 1 in 4 risk of an unaffected baby. So 50% risk of Leri-Weill dyschondrosteosis, 25% risk of Langer-mesomelic dysplasia, and a 25% risk of an unaffected baby. And this is just a little cartoon to try and explain the situation. So if you look at this one here, so this is a man that has Leri-Weill dyschondrosteosis, but the mutated variant of shocks is on his Y chromosome. So you would imagine that all his sons would get his Y, therefore they'd all be affected. All his daughters would get his X with the normal shocks and would be unaffected, but that's not true. Here's the flip side. This man also has Leri-Weill dyschondrosteosis, but this time his shocks variant is on his X chromosome, and the shocks variant on the shocks on the Y is normal. And again, here you would think that all his daughters would be affected and all his sons would be affected. And again, that's not true. Because what actually happens is that there is an obligatory recombination event between these genes in the pseudo-autosomal region here. So you end up with the man producing sperm where there's a shocks variant both on the X and on some of his Y-bearing sperm. And that's why it works just like an autosomal dominant disorder, even though the gene is on the X and the Y chromosome. That is why you get the straightforward 50-50 risk of sons and daughters being affected in both of these situations. So this one and this one. So that's just because of the recombination event. So you need to be aware of this. So you can have a man with shocks-related dysplasia who then has a son with shocks-related dysplasia, which is not what you get with X-linked disorder. So this is not really X-linked, it is pseudo-autosomal. So you just need to be aware of that. And then we have, again, these very difficult counseling situations where couples, often couples meet each other in skeletal dysplasia societies and groups. So you might have a man with achondroplasia whose partner has hypochondroplasia. You might have a person with achondroplasia whose partner has spondyloepiphyseal dysplasia congenita, or OI, or Leri-Weill dysplasia, or achondroplasia with one parent and pseudoachondroplasia and another parent, and so on and so forth. And it can, there is any number of combinations of this. And this counseling this for these couples is very difficult. Very, very difficult because there is so little literature out there. So here is an example of what you do when you're facing double heterozygosity for achondroplasia and SCDC. So here one parent has achondroplasia, another parent has SCDC. The offspring recurrence risks are there's a 1/4 risk of achondroplasia, a 1/4 risk of SCDC, a 1/4 risk of double heterozygosity for achondroplasia and SCDC. So a child that has both the conditions, and a 1/4 risk that the child is going to be unaffected. And what is the phenotype? And the phenotype is really bad. So here you have clinical radiological features of both conditions. Child's born with severe limb shortening, very narrow chest. You get high myopia and cleft palate because of the SEDC, which is a call2A1 phenotype. You get compression of the posterior fossa, which you could get with ACH, but becomes worse if you've got SEDC as well. And there's a high risk of cervical myelopathy. Often these babies have chronic restricted pulmonary disease, resulting in death in neonatal period or infancy. So it's not a good outlook. And sadly, I have actually encountered the situation, and it is very, very difficult to counsel for. Here's another example of double heterozygosity for achondroplasia and pseudoachondroplasia, but this time these are not lethal. So here you have one parent with achondroplasia and one parent with pseudoachondroplasia, and the risks again are 1/4 achondroplasia, 1/4 pseudo, 1/4 both, double heterozygosity for both, and 1/4 unaffected. And here you find that the baby at birth looks just like achondroplasia, has the radiology of achondroplasia. Then after 2 years, the radiology and the clinical features of pseudoachondroplasia, the spinal element starts to come in, but later. They do have more problems than just having achondroplasia or pseudoachondroplasia by themselves. So there's a higher risk of foramen magnum stenosis, higher risk of cervical myopathy, and a much earlier onset of lumbar spinal canal stenosis. So often you'd see this occurring in the first 10 years of life, which is very atypical in achondroplasia. And then, of course, you have to remember that a parent with a skeletal dysplasia may have a child. So you may have two normal parents who had a child with skeletal dysplasia. So let's say parents have osteogenesis, a child has osteogenesis imperfecta. Neither parent is affected. At least clinically, they're not affected. But sometimes when you test the parents, if you found a COL1A1 mutation in the child, in the affected child, and you test both parents, you find that one parent has very low level of somatic mosaicism and possibly gonadal mosaicism as well. And so the recurrence risk is not the 1 or 2% figure that you would quote. It's much higher. It may be as high as maybe 10%. So again, you need to know the entities in which you can get gonadal or gonosomal mosaicism, and then adjust your offspring recurrence risks based on that knowledge. And there are a number of conditions which are listed here. So OI, Kanrari, Huneman, X-linked dominant, chondrodysplasia, Ledy-Wild, pseudoachondroplasia, metatropic, and CAN2. So you just need to be aware of these. And then, of course, the problems that arise with counseling for treatable skeletal dysplasias. So there are a number of treatments now available: bisphosphonates for OI, growth hormone for shocks-related dysplasias for Turner's, Ledy-Wild, enzyme replacement treatments for lysosomal storage disorders. Aspartase alpha has had a license in Europe and in United States in 2015 for treating infantile and juvenile hyperphosphatasia. Burosumab has had a license for treating X-linked hypophosphatemic rickets since 2018, and Vazoritide has had a license for treating achondroplasia in Europe since August of last year, and in United States since November of last year. And like I said, in the UK, not yet, maybe next year. And then bone marrow transplantation for autosomal recessive infantile osteopetrosis. Obviously, availability and cost are major issues. So a full year's course of Vazoritide will cost 240,000 pounds, which is way beyond what anybody can afford. But of course, here it is subsidized. It would be subsidized by the NHS. But all of this will means that you have to talk about these things with parents to give them full counseling. So you just need to be aware of potential treatments and how that would affect counseling. So I'd just like to finish by saying that there are many different counseling situations in relation to skeletal dysplasias. Counseling for antenatally diagnosed skeletal dysplasias can be very challenging, and sometimes even something as simple as achondroplasia can be quite challenging to counsel for. Where you have both parents with achondroplasia, both parents with Ledy-Wild, or one parent with one skeletal dysplasia and another parent with another skeletal dysplasia, you have to counsel about double heterozygosity, which can be pretty complicated. And then as time goes by, and in the years to come, we're going to start seeing many more treatments available, and that may influence how your counseling strategies for these families. Thank you very much.
Thank you, Dr. Suri. Just be there. We'll be having the panel discussions and question answers. Yes.
I thank all the speakers for the wonderful presentation. We will now proceed with our panel discussion on importance of genetic testing and counseling in diagnosis and management of musculoskeletal disorders in low resource setting, which will look into significance of genetic testing for accurate diagnosis, treatment, and and follow-up of musculoskeletal disorders, value of genetic counselors for understanding musculoskeletal disorder-related illness in India, need for genetic counselors in bridging the gap between patients, families, and medical professionals in India. Over to our chairpersons now.
I think the speakers are there online. Okay. I think Dr. Amol, the first speaker, is here. He can come over on the dais, please. And the question to you is, there is a question on autism spectrum disorder with related to your, the genome sequencing. You have a mic there? Yeah, okay. Now the question is that in ASD, autism spectrum disorder, can WGS whole exome genome sequencing play a major role in the diagnosis and critical analysis compared to combined recommendation for CMA and WES in Indian patient, in Indian scenario? What do you think?
Hello.
Yeah.
So I think the CMA will definitely play important role in this. So that is a starting point. But if we combine WGS, definitely that can add some additional information as well, because it's a spectrum, and
Yes.
there will be different phenotypes which would be presented clinically. And we may get some additional data if we combine both together. But in Indian context, I think still CMA would be something which is, we should be looking at as a first-line diagnostic test.
Okay. Thank you. Thank you. And in that also, there could be a second question as that which evaluation which you would think as the first line of investigation, chromosomal or in the genomic level? I think maybe the question is like the microarray or genomic level. As
Again,
you said,
it's
both.
good to start, with the chromosomal first, and then, dive into the molecular diagnosis of these diseases. Again, the issue evolves around the cost benefit, access to treatment, availability of the specialist who can definitely analyze the whole genome sequence data and so on and so forth. In ideal situation, if cost is not an issue, access is there. If we have access to the the experts who can
Yeah,
analyze
we have to
data.
remember it's a low resource setting.
Exactly,
That's the
exactly.
panel
So in
discussion.
an ideal
is-
situation, the whole
Right.
genome definitely provide a lot of insights. Of course, there's a dilemma about the variants of unknown significance, and that question is still a burning question.
So do you think the variants of unknown significance should be considered still because we do not have our still genomic data in Indian
challenge
scenario established?
Yes, of course. The challenge with the variants of unknown significance, because when we find certain variants which are rare, we don't have enough data which can link them to the biology or to the pathophysiology. So as these data sets get wider and wider, and that requires bigger effort internationally, to share data so that we can make certain correlations. So unless that happens, the
Is
question
Illumina
regarding-
going to be here for collecting and
we are-
developing
we
and
are doing-
establishing Indian
we are doing a lot of efforts
population data?
internationally. So, for example, in UK, with NHS, we are doing, the 100,000 genome project, which is kind of, the doing whole genome sequencing for 100,000 patients or the people in UK. Just last couple of weeks, we launched project in Singapore where we are sequencing whole genome sequencing for 100,000 Singaporeans. So that is more
Okay.
about, the public genome, kind of, the population genomics.
Okay.
Yeah.
One question is there are always people will come and tell the clinician, okay, if it's autism, there is a panel of autism. Do you think it's enough, suffice?
Again, it depends.
Target for just the panel, and if it is a negative for ASD 90 gene panel, can the clinician be satisfied?
So another challenge in genomic diagnosis that we have a lot of lab developed tests, right? And there are no kind of an IVD, in vitro diagnostic tests, which are undergone kind of, the critical examination by the regulatory agencies. So most of labs are free to develop, use the technology and to develop a lab developed test and can have a gene panel. So we need kind of, the regulatory framework as well to what tests perform on what parameters. So there's a lot of variations with lab developed tests in terms of labs to labs, and there is no clear
Okay.
answer that which test will give you really comprehensive kind of solution. So that's again a challenge.
So I think there the genetic counselor can bridge that gap.
No,
I
absolutely,
think
yes,
they will be
yes,
helpful to the
yes.
clinician.
And as I mentioned that, as the access to this technology increases, whether it's whole genome sequencing, whole exome sequencing, large panels, no technology is 100% kind of a
100%
foolproof,
sure.
and there is a lot of limitations. And again, there will be a lot of issues regarding patient privacy, issues regarding ethical applications, because you will have secondary findings, you'll have various
Yes.
unknown significance. So how do you discuss with patients and families about those issues becomes again important. And that's where the role of genetic counseling comes in.
Yeah.
Because no test will give you the 100% results, which
Yeah,
can satisfy the
so-
need of clinician and patient.
Right. Thank you, Dr. Amol. And I think that is an important message. Is Dr. Suri wants to add on something on this?
Yes, so obviously we've had a lot of experience of the 100,000 Genomes Project. I myself have recruited a number of patients into the 100,000 Genomes Project. And we've had pretty good success rates with the 100,000 Genomes Project, which is now actually available in our diagnostic labs. So we have whole genome sequencing available in our diagnostic labs. But it's not gene agnostic whole genome sequencing. So basically what you do is you do a trio or a duo or a singleton whole genome sequencing, and then you apply certain panels that are of directly relevant to the phenotype in your patient. And in fact, the pickup rate for in my own patients, so I recruited, I think, maybe about 160 patients. And I've had a diagnosis, a primary diagnosis made in 45% of patients. So it's very powerful. And we've also looked at trio versus duo versus singleton. With trios, we've had a pickup in excess of 30%. With duos, in fact, it's not so bad. It comes up to almost around 25%. But then if you do it as a singleton, it goes right down to 10%. So obviously trio is very powerful. The second thing to add is that for autism, just primary autism with nothing else, I think that just doing an array and doing fragile X testing is probably adequate. I think that it is overkill to do whole genome sequencing, trio exome sequencing, because you are very likely to pull up lots and lots of VUSs, which would be very difficult to classify, and it will just waste the lab time, which it's very precious. So I think that unless there is something else, maybe the child has some dysmorphic features, maybe the child has some abnormal neurology, maybe there's something else other than just autism, I would not want to then take the step into exome or genome sequencing. But these are my thoughts, and I think my colleagues believe exactly the same.
Yeah, thank you, Dr. Suri. And I think we have to remember that we are working in the low resource setting. So everything has to be taken into consideration. The next question is to Dr. Datta.
Dr. Datta, thank you very much for an excellent presentation. As I was remarking to Dr. Usha, you have touched upon most of the clinical aspects of musculoskeletal disorders. My question is how to develop and execute a case management plan that includes case preparation and follow-up of specific musculoskeletal disorders. And can you elaborate briefly on that?
So whenever, see, there should be a good pro forma which is available, a clinical pro forma, so that we are taking a proper history as regards to it starts right from the antenatal period, going through the developmental milestones and coming to the current issues that are at hand, followed by a proper dysmorphology review. It always helps there, and then planning the investigations as per the the condition. So if it's a neuromuscular condition, then we may have to consider, various investigations that we discussed. If it's skeletal dysplasias, we'll have to consider X-rays before really proceeding for exome or genome-based sequencing or other relevant investigations as per the case would be. So it should be a proper clinical approach wherein you're going in a stepwise manner to have a clinical diagnosis followed by planning the genetic testing.
Okay, thank you. Yeah, so you have to first finish all that workup. That should be the, so the line of investigation, and then go for the higher genomic test. Yes. Next question from the audience is? cost thing.
The question is, describe on the costs, dangers, and potential advantages and restrictions of genetic testing for musculoskeletal disorders in India.
I think Dr. Datta,
I did not get the question.
the cost-wise,
I will add on after he says.
yeah, that is to Dr. Datta in Indian setting, like the cost-wise,
Right. So,
that's the limitations and dangers.
right. So considering the cost implications here, since we are talking about low resource settings, the better the phenotyping, the more likely you're likely to reach a definitive genetic conclusive diagnosis on genetics. So you can plan, smaller panels in such cases, rather than going for, whole exome. Nowadays, the costs have come down significantly. So generally, if your phenotype is fairly clear, you can limit yourself to a smaller panel, say a clinical exome sometimes. But if your phenotype is not that clear, you may have to upgrade to a whole exome or genome-based sequencing as the case may be. But here, it is very important to reach a clinical diagnosis first and then plan your investigation. Like, for example, if you're seeing a child with dysmorphic features with an intellectual disability, perhaps going for an array before considering an exome, in that case, may be more helpful. So, evaluation, see, it should be case-based approach. Each case will be different. You cannot really have a single algorithm which will work for all the cases. So proper evaluation of each of the cases and then going forward is the best approach to save costs for the patient. Sometimes, people think that why should we go do an X-ray before directly they would ask for an exome sequencing in today's era. So that is dangerous because we really, even for the lab to interpret the results, they should have a phenotype which is available. So phenotyping is the key, I would say.
Dr. Datta, I would just like to add on our experience. So we have been doing muscular dystrophies and again in the rural. So basically with the symptoms of Duchenne as such to pick up like the frequent falls, etc. So they are brought over to the primary health physicians and then they again screen at a level and then they send them to the neurologist. Even with the neurologists, when they put in, we have a proforma, very systematic approach, and they're all suspected Duchenne's or Becker's. So I would just quote the first publication we had around the first 1,000 cases, 961. I would say 800 and odd were only Duchenne's or Becker's. Others again were all negative. So we take it systematically because of course we used to do MPCR a little earlier, but now MLPA. Then negative, we do NGS. Of course, we do the muscular dystrophy panel. And then when again, less than 50% were picked for other muscular dystrophies. And if you see, LGMD2E is so close and we had a very new mutation, but we had that among the 21, 18 had that mutation. So, but in the Indian database or even the ClinVar or we have the DMD.NL LOVD database, it was not quoted. So I would say most of it which was suspected for Duchenne's were other muscular dystrophies. So the counseling becomes very critical because they were suspected for Duchenne. Then we say MPCR negative, MLPA negative, and we were waiting for NGS. And then NGS, again, the panel, muscular dystrophy panel, we picked up. So when it comes to counseling, we have to really tell them it is not Duchenne, it is not life-threatening. So it was like the systematic approach, at least in muscular dystrophies, was very useful for us in the resource setting of the way we work in India as such. I just thought I'd share this experience with you.
Lakshmi, if it's not there in ClinVar or have you put it in?
Yes, now we have, as we publish, we are putting in all our...
No, publication is different. Just forget the publication. In the database, if you think it is a new
Yes, we are
variant
putting it.
or a founder,
Yes.
that's the first thing you should do because
Yes.
it will help the rest
Definitely.
of the community to
Yes.
also focus and do it the correct way.
Yes, we have started doing it from last year.
I have one more point because I have been working in the field of skeletal muscular dystrophy and spinal muscular atrophy quite some time. No? So whatever happens, whatever genetic of late, so many recent therapeutic drugs have come for treatment. So it is more important that I think the diagnosis should be clicked properly so that we can, if at all any therapeutic intervention can be done for those children, that has to be given.
No, it's something.
Hello, can I ask a question? Dr. Suri,
Yes.
how do you take the challenges of penetrance and expressivity of the uh, achondroplasia disorders, the single gene disorders? Penetrance, expressivity of the traits is affected there. What frequency we can see in the achondroplasia is penetrance and expressivity?
So if you have the usual the glycine 380R variant in one copy of FGFR3, penetrance is 100%. So there is you will always get achondroplasia. There's there it will not be incompletely penetrant or non-penetrant. With hypochondroplasia, of course, the problem is that because they are less severely affected, unless and until you do a full skeletal survey, you may not know that the person is affected. And the same may be true for Léri-Weill dyschondrosteosis, particularly in males. So in females, you get the maid-lung deformity of the forearms. But in males, you don't see that. Males are just short, mild mesomelic shortening, and they are quite stocky. But so it's very easy to miss it. But that's not because it's incompletely penetrant or it's non-penetrant. It's just that it's a little bit more difficult to pick up. So for most skeletal dysplasias, I think you're looking at very high penetrance. And for some of the common ones like SCDC, achondroplasia, these are fully penetrant disorders.
All will not have the same kind of penetrance and expressivity, same phenotype, 100%. So that
Yes,
way,
they will. So with achondroplasia, they will. The thing is that maybe in some patients with achondroplasia, there might be slightly more severe radiological findings. For example, you might, in some achondroplasias, if you do a skeletal survey, you might see more severe platyspondyly, whereas in others you tend not to see platyspondyly, but it would still be fully penetrant. So if you have the glycine 380 arginine variant in FGFR3, it is fully penetrant. There's no reason to believe that it will not be penetrant.
now this severity is anything related to variants there in that particular gene?
Yes, so that is particularly true, for example, with the other variants. So whilst 99.9% of patients with achondroplasia will have the GLY380R variant, 0.01% will have something else in the same gene. And those tend to be a bit milder. So I've certainly seen one child that had I think it was a CIS275 SER variant. And that child was, clinically, he didn't look that much like achondroplasia, but his radiology was fairly typical. But he is now an adult and he has had some lymph lengthening surgery done. And so now he looks even less like achondroplasia, but he didn't have the really big head with the dished out face like you get with achondroplasia. So it might be to do that there are sometimes you might get milder mutations that give you a slightly less obvious phenotype, but it's still penetrant. It's still fully penetrant.
Thank you.
Is there any other question from the audience over here? Okay, just give him you have a question? Yeah. Yes.
Hello. Yeah, my question is specifically relates to the economics of whole genome and whole exome sequencing. We know that it's falling faster than Moore's law. So my question is, how long before, like what I mean to say is, every X number of years, both whole genome and say whole exome will get cheaper, but the delta between them will keep reducing. So how long before essentially it does not make sense to go for whole exome sequencing as opposed to whole genome sequencing because the delta is so low? Yeah, so if anybody could add comments on that.
Yes, Dr. Amol.
Okay, so quick comment on that. And I go back to what Data said earlier. And in my presentation as well,
Yes,
I
it
highlighted
was
that.
there.
That the phenotypic presentation is very important. And just because the cost of whole genome sequencing going down, that doesn't mean that we would be able to give a proper solution to the patient, because we need other aspect of the sequencing as well. We need to have a good bioinformatics team. We need to have a good genetic counselors. We need to have experts who can analyze that data. So the cost is not only consideration to choose a test. That is one. So what is important is, can we clinically identify phenotype, and can we have a differential diagnosis to order a targeted test? If answer is yes, that is the logical approach. So that becomes more of a kind of a confirmatory test in terms of genetic analysis rather than exploratory, because the exploratory genetic testing has its own challenges. So the cost is just one factor. So we have to look into the totality of the application of the NGS while giving that kind of a diagnostic solution to the patient. So I would like to hear on the panels as well.
I think here the genetic counselors also become very important, that they have to keep on asking and digging the information, about the clinicals. Majority of the time, the doctors will give only 2 or 3 lines, or just the major one, very huge hepatosplenomegaly, developmental delay, only 2 words. And when the counselor goes into detail or approaches and then you will get enormous information. And the more number of those points, including laboratory investigations, as brain MRI, metabolic acidosis, and your lactate pyruvate ratio, any other thing, dysmorphism, finest to finest congenital anomalies, they don't mention. They think it's going to come in whole exome sequencing. So I think there the counselors are going to be very, very important in having this cost-effective approach, and which tests to be, finally will be helpful, looking at the socioeconomic status of the patient also. So I think we have just the last key home message is, I think key message we can take it from this panel discussion is, it's a case-based approach. There isn't anything like a fixed algorithm for one fix, maybe depending on the system as cytoskeletal or cardio or CNS maybe. But otherwise, everything is a case-based algorithm. Clinical evaluation is the important, genetic evaluation is the important, investigations are the important, and looking at the cost effectiveness and making the patient understand. By doing this test is not the last thing and I will give you the answer 100%, which will be most of the time. And as Dr. Jayashree said, for clinical therapy management, later on the management and the therapy, that is also important. And the last but not the least is the counselor has to be all the time updated with the knowledge, can go back if there is a discovery, can go back and trust that patient that yes, there is this new therapy is available and you can come forward for it, or any other new genomic technology is there and we can go precisely at the diagnosis. So I think that is the last message. And thank you so much. I also thank the organizer for giving us this opportunity to conduct this panel discussion. Thank you so much.
I would like to extend my thanks to the speakers and the chairpersons for today for this wonderful panel discussion. I'd like to ask everyone to please stay back for the group photograph and along with the annual general body meeting, which is to be held after this. I would like to invite Dr. Uma. Yeah. I'd like to request Dr. Datta and Dr. Suri to also please stay back and join us for the group photograph. I would now like to invite upon stage Dr. Uma to commemorate the chairpersons and speakers. Please, Dr. Uma.
So coming to the end of the session 1 of day 2, I would like to request Mr. Prasanna Shirold sir to honor our chairpersons. Dr. Usha Dave ma'am. Dr. Jayashree Ramesh ma'am. Dr. Lakshmi BR ma'am. Thank you, Prasanna. Thank you. I would like to request our chairpersons, Dr. Usha Dave ma'am, Dr. Jayashree ma'am, Dr. Lakshmi Biyar ma'am to honor our speaker, Dr. Amol Zime.
Hi, everyone. Uh, I request you all to come forward. We're going to take a group picture. So, no, they're not there yet. So we're going to give the mementos to the last evening session after the photograph, since they're all on the way yet. They're not here yet. So I request all of us to move forward. I request all the delegates to come on stage, but the senior people will make arrangements in the front. We want you to be visible. So Dr. Monish and Dr. Datta will also be joining us online. Please make your way forward.
Help with the chair. Please stand.
Towards the end. I know.
Dr. Suri, thank you so much for waiting. We are just getting ready.
Best spot.
Taking it again.
Come, come. Dr. Suri, we are just going to take the picture in 1 minute. So sorry for making you wait. Dr. Datar has also joined. Okay, Ria, stand on the ramp, please. Come forward, stand on the ramp. Stand on the ramp. This side also. Sir, come quick, quick, quick. Professor Renu, Narayan sir. Ha, ha, ha. Ha, ha, ha. Aishi, next to you. I'm calling you from that time. Please come front. Don't you want to be visible? Guys, everybody stand profile. All of you turn to your right. All of you. The ones at the back, please turn to your right. Yeah, stop. You all turn to your left. Okay, perfect. The tall person at the back, you're the middle point. You stand straight. Okay. So everybody else seen? Okay, no complaining if you're not visible later on. Yeah, I'm coming. I won't hide anybody this way. Okay. I can't see people at the back there. Ma'am, please come front. Yes, please. Thank you. Okay. For the annual general meeting.
Good afternoon. Let's start the afternoon session on genetic counseling in cardiology, common complex disorders. Genetics can influence the risk for heart diseases in many ways. A genetic variation or mutation in a single gene can affect the likelihood of developing heart disease. Many cardiac disorders can be inherited, including arrhythmias, congenital heart disease, cardiomyopathy, and high blood cholesterol. Coronary artery disease leading to heart attack, stroke, and heart failure can run in families, indicating inherited genetic risk factors. When a family member is diagnosed with heart disease or a heart disorder, other family members are encouraged to undergo screening for risk factors and early stage disease that may not yet produce symptoms. Genetic diagnosis, especially using single gene or NGS tests, are available for inherited cardiovascular diseases. NGS technologies have revolutionized our understanding of the molecular mechanism of cardiovascular diseases, which provides insights on potential therapies. I would like to invite Ms. Reena Trivedi and Ms. Anuradha Sharma, moderators for this session. Reena Trivedi, ma'am, is level 2 genetic counselor and freelance genetic counselor and attached to several hospitals in Ahmedabad, has experience in genetic counseling in prenatal cancer and muscular dystrophies. Anuradha Sharma, madam, level 2 genetic counselor, working as genetic counselor in a lab in Delhi. Over to you, madams.
It gives me great pleasure to meet all of you after a long hiatus. At least it seemed very long. We are meeting after 2 years. COVID really kept us away from each other. It gives me great pleasure in moderating this session and also to introduce all our eminent speakers and chairpersons. I'm here to introduce the chairpersons. So it's welcome to Dr. Amarjeet Bhamar. Sir is a very senior academic person from Punjab University and Patiala. He studied in human genetics. His major interests are in molecular genetics of complex disorders, genetic diseases of children, inherited conditions of the heart and blood vessels, genomic medicine, and genomic applications in global healthcare. His career highlights are, the major one is that he has been guide to many PhD students. He also heads various societies like the Indian Science Congress Association, Indian Society of Human Genetics, Mitochondrial Society of India, ADNET, Indian Immunology Society, Punjab Science Congress, etc. He's also served as the president of the Indian Society of Human Genetics. We welcome you, sir. We are really glad to have you with us.
Welcome Dr. Nallur B. Ramachandra. He is professor and UGC BCR faculty fellow, Department of Studies in Genetics and Genomics, University of Mysore. He did MSc and PhD from University of Mysore. His major area of interest is Drosophila genetics and evolution, plus human genetics, disease, and genomics. The main career highlights: he has 276 research articles, gene sequences, research notes, and chapters in national and international books. He guided around 28 students for PhD, and currently 4 students are working in Drosophila genetics and evolution and human genetic disease and genomics. We welcome you, sir.
Our third chairperson is Dr. Manjappa. He works as an interventional cardiologist and assistant Associate Professor in the Department of Cardiology here at JSS Medical College and Hospital. He holds a postdoctoral degree from Sri Jayadeva Institute of Cardiovascular Sciences, Bangalore. He has done several fellowships in the field of heart failure management. His main interests are preventive cardiology, education and research, coronary and non-coronary endovascular interventions, device implantation and heart failure. His career highlights are his original research articles in peer-reviewed international national journals, and he has also authored many chapters in textbooks. He is involved in many international and national trials and registries. He has received several awards from different social organizations for his contribution to the medical field, and he also supports genetic counselors. We welcome you, sir. Our international speakers are online. In the meantime, I'll request Dr. Bhavar to introduce our first speaker, Dr. Dhavendra Kumar.
Hello, welcome, sir. So it's my pleasure to introduce my old colleague, Dr. Dhavendra Kumar. He has affiliation with the David Weatherall Chair of Medicine at the University of Liverpool and is a consultant physician at the Royal Liverpool University Hospital. He is the director of Center for Drug Safety Sciences. He is also the director for Wilson Center for Personalized Medicine. He is an alumnus and postgraduate and honorary doctorate from the King George Medical University, Lucknow, UP. He had done fellowships in Royal College of Physicians and Pediatric and Child Health. His basic interests are genetic diseases of children, inherited conditions of heart and blood vessels, genomic medicine, and genomic applications in the global healthcare. His career highlights are he's passionate about raising awareness and promoting importance of genomic medicine and genomic applications in global healthcare. He's an international authority in cardiovascular genomic medicine and leads a global network comprising of leading CVGM centers. I'm honored to be with him because our university has also entered into an MOU with him so that we could start this kind of a work at our place also. So without further delay, I request Professor Dhavendra Kumar to give his talk on genetic counselors' role in cardiac emergencies. Dr. Kumar, please.
Thank you for this kind invitation, Professor Bhavar, Dr. Madam Rina Trivedi, and Dr. Annie Hassan. I think I noted that in my introduction, my affiliations were, I think, copied from Professor Sir Munir Ahmed's, bioprofile. I think these belong to him, and I think I'm only affiliated with the Queen Mary University of London, the William Harvey Research Institute, and University of Swansea. And I also have my Genomic Medicine Foundation, for which Sir Munir is the patron. So the topic which I have chosen for this conference is really a new emerging area in cardiovascular genomic medicine. One of the objectives of genomic medicine is how to engage with clinicians in different medical specialties. And I noted this is the theme of this conference. And we have now developed in many what you call the multidisciplinary teams with many other specialties, notably the prenatal and fetal medicine, metabolic diseases, oncology, and cardiovascular MDTs are relatively new. What we have noted that the link from main genetic center and to the medical specialty is really possible through genetic counselor. So in other words, genetic counselors act like a bridge between the core genetics team and the medical specialty, what we are talking about. So, and one of the main area of medical specialty in which we really want to really go into detail is the emergency. The medical treatment starts with acute care of patients, and mostly it is in the emergency room. So what I've done, I've selected a few areas where the role of genetic counseling could be harnessed in managing the acute cardiac emergencies. First of all, I have no conflict of interest. I put that in my slide, and I also acknowledge affiliations with many places, associations.
Hello. Sorry to interrupt you, sir. We cannot able to see your presentation. Can you please share your screen on the Zoom?
Yeah, I think.
And we should start from the first slide, sir.
I think
just open your presentation, come to the Zoom. Yes.
Is it coming now?
Yes, sir. Make it full screen.
Wait a minute. Is that okay now?
Yes, sir. We can go to the first slide, sir.
I thought it was done. I'm sorry about that.
No issue, sir.
Can you hear me now?
Yes, sir. Good to go.
Okay. So just to start from the beginning, the topic of my presentation is the genetic counseling in managing the cardiac emergency. As I explained, the genetic counselors are now very important for the multidisciplinary teams of different medical specialties. And cardiovascular genomic medicine is a new emerging branch. And I have spent a lot of time in this, not only in my own hospital, but other places. So it has become now a normal way of working with the genetics team. And I have no conflict of interest. So if you go through the acute cardiovascular medicine, there are 5 areas which I have selected in which there is a clear role of genetic counselors and clinical genetic team, and mostly the clinical geneticists. Let's start with the blue baby or coronary heart disease. Some of you would have seen a very unwell baby, like I've shown here, very blue baby, and their conditions, which are all complex congenital heart diseases, notably the tetralogy of Fallot, left hypoplastic heart syndrome, and the transposition of great arteries. Most of these are isolated, but there are familial cases as well, and also part of the multisystem syndrome or multisystem developmental dysmorphic syndrome. So the first task, which is of course the task of the pediatric cardiology, cardiologist or the team, is to identify what would be the most likely diagnosis. And many modalities are included, as you might know. And in some cases, there may be indication because by doing the fetal echocardiography, whether it was just incidental finding or based on the previous child born to those parents. In some cases also, there may be some information from the fetal genetic testing as well. Further on, other 2 areas which are important are called abnormal aortic arch, like the supravalvular aortic stenosis. Williams syndrome is a key, which is a microdeletion of long armor chromosome 7, in which the elastin gene is mapped, and the coarctation of aorta, and most importantly, the Turner syndrome, and of course, the interrupted aortic arch. Let me just focus on one condition, which is really the hallmark of cyanotic heart disease. So this baby had phalanstetrology. He was only 3 months old. He was discharged from the hospital. At that time, he was not blue, but there was slight, mother recall, there was slight bluish tinginess in his mouth. But then one day, I think he became very unwell. He was brought to the hospital, and then he was rushed for open heart surgery for phalanstetrology. Nobody realized that he could have a syndrome. It was just because emergency. There was no genetic involvement at all. And when I saw the baby was 8 months old, and the health visitor was very concerned that the child was not developing properly. The speech was very nasal tinge. So I looked at him, and this picture, baby picture, I'm showing with mother's permission. And I thought about the 22q deletion syndrome. As you can see, at that time, fish was very common. Now the fish has gone into history books. But anyway, you can see the beautiful slide. There's a normal chromosome 22 with both areas present. And then the deleted chromosome 22, which is the red part is missing here. So diagnosis was very clear. It was 22q deletion syndrome, and phalanstetrology was part of this condition, in which about 70% children have type of congenital heart anomaly because of TBX family genes are mapped to this area. Now at present, this deleted segment has about 65, around 70 genes present. And most of these genes are for a range of developmental conditions, including autism and the childhood schizophrenia, and most importantly, the immune deficiency because of thymus absent or hypoplastic, and of course the parathyroid involvement disturbing the calcium homeostasis. So it is a syndrome which is multi-system, multidisciplinary, and with a very strong genetic abnormality. So what we have done in our hospital, we have set up a multidisciplinary clinic, what we call the 22 deletion syndrome clinic. And most of the leading clinicians join. And again, as I said earlier, the genetic counselor and the cardiac nurse, they become key people to organize all these periodic clinics. So you can see if this is our patient, and all these things have been done. In this case, we only did the fish, but now as the technology has moved on, we can do other apply other technology. But in this one, the clinical genetics, like myself, genetic counseling, at present, interestingly now, there is no need for clinical genetics to be present in this clinic. Only genetic counselor will go and report back to the clinical geneticist if there were any issues pending or unclear, or there were some new questions asked. In most cases, a genetic counselor or the cardiac genetic counselor in our team is fairly and qualified and knowledgeable to deal with most of the questions. As you can see from this slide, there were many other clinicians involved, including the cleft surgical team, the speech therapy. So it is a beautiful example how you manage, we should manage children with this condition. So this child started with the blue baby, went for pediatric surgeons, came back to us, and now we are dealing with that. At present, not a single child is now left outside, and any child who has got this syndrome, whether the child has got the serious congenital heart disease or not, but they all undergo treatment management through this clinic. So this is just a starting point how genetic counselors are used in our setup. Now, just moving on to the second situation, which is a patient who arrives, who's brought to the casualty emergency room in a very shocked state, almost moribund, almost dying or about to die, and the patient has nothing to say because usually the patient is alone in most cases. And then I'm talking about the aortic rupture and dissection. Those who are present, the cardiologists present in the team and in the audience would know the gravity of this situation. The notable condition is Marfan syndrome, which is an autosomal dominant variable nearly fully penetrant condition. The other condition included our vascular Ehlers-Danlos syndrome and then pure non-syndromal thoracic aorta dilatation dissection. See, these are pictures from a real patient, as you can see from the echocardiogram and the dilated ascending thoracic aorta and dissection. Dissection as indicates, and the blood, the wall of the aorta is split, and the blood trickles, and then the aorta expands, and it may also rupture and cause obstruction. So Marfan syndrome is a multi-system disease, as you know. More important gene is a microfibrillin. But there are clinical criteria based on the clinical picture. You can make a diagnosis, and the cardiovascular complications, the descending aorta are really the hallmark, as you can see from one of these patients. Look at the skeletal picture and the long thumbs and long fingers and all these things. So these are the Gantt criteria, which are the gold standard to make a diagnosis of Marfan syndrome. So that patient, this patient was actually brought to the casualty with aortic dissection and was saved by surgeons. And then in the post-operative room, and one of the registrar noted all features, then he was given the diagnosis of Marfan syndrome. So it is a very important diagnosis, and it is variable. So sometimes you may not have the all picture or criteria meeting, but extensive investigations, including the single gene analysis or the gene panel testing. If you're in doubt, you can go for exome sequencing as well. So the other condition in this group is the vascular Ehlers-Danlos syndrome. As you can see, pure connective tissue disease, like the classic Ehlers-Danlos syndrome. In this case, it is the collagen type 3 involvement, and most of the middle arteries are very fragile, friable, and prone to rupture. You can have a splenic artery rupture, you can have the hepatic artery rupture, you can have the renal artery rupture, including the coronary and as well as the carotid arteries. And these are pictures of a patient who presented with them, as you can see from here, and also the stroke-like picture. So this is a very important condition to keep in mind in a very acutely unwell patient who is brought to the casualty. In most cases, the casualty team would alert us and they contact the genetic counselor. Please come and have a look, and then talking to the family members attending the patient. So the genetic counseling in Marfan and related diseases is now evolving, and it's just now well established. As I said earlier, it is a genetic counselor is a member of the multidisciplinary care team, and they are the one who really right from the family history, liaison, lab, and all those things are done by them. And they also engage in teaching, training other colleagues, nurses, and other healthcare providers. So moving on to other acute condition, and that is heart failure. Although heart failure is mostly because of the ischemic heart disease, like coronary artery disease or hypercholesterolemia-led, but there may be some genetic element like the autosomal dominant familial hypercholesterolemia. But in most cases, about 15 to 20%, we're talking about cardiomyopathies as a cause for heart failure. And in some cases, also the abnormal valve development would also be an underlying cause. But in terms of the cardiomyopathies, of course, it is being a single gene disorder in most cases, and involvement of the genetic team is really from the start. These are some of the conditions which affect the myocardium. I mentioned ischemic heart disease, and then we have the non-ischemic heart muscle disease, in which inherited cardiomyopathies, metabolic heart disease are the hallmark. However, now inflammatory and immunological heart muscle diseases are also coming up. In this context, it's very important to keep in mind about the post-infectious heart muscle disease, what we have seen in the COVID second phase, many patients who so-called recovered, but later on developed the heart muscle disease, actually died because of that. We don't know what is genetic element in these cases, but most importantly, we keep ourselves to the inherited cardiomyopathies in this context. Some of these pictures, as you can see, this is a normal heart, all myocardial gene clusters, the thick filament, medium filament, and the thin filament, and all those pathology pictures. So the most important thing to appreciate is what is the clinical genetics input to acute heart failure. I think that's the point to really look at. So right from beginning, we are introduced to the patient and the family so that we can look after the genetic element. So either a genetic counselor is called or the clinical geneticist like myself would be there. Then we make sure that there is a sufficient material for genetic analysis, like the blood taken and any, or there was a cardiac biopsy done. All this material is sent to the lab for further analysis. And the discussion at an appropriate time is undertaken by us, and that is led by the genetic counselor. So, as I said, I think this is we do have a team management here, and we have, every hospital has in the UK heart failure multidisciplinary team, which is important for diagnosis and choice of genetic testing. In most cases, we go for multi-gene panel testing. Rarely we go for the exome sequencing, but now because of the availability, we are going for clinical exome sequencing that offers much more flexibility in terms of variants, which are the splice site variants, because some of the multi-gene panel might not detect those areas of the genome. So moving on to other area of acute cardiovascular medicine is the cardiac arrest. So sudden cardiac arrest, you might have heard many examples in the newspapers and TV, and this is pictures of all people. I think one of the charitable firms, the foundation, I mean, and they have really put these pictures to highlight the importance. And as the name indicates, if the patient is not brought to the hospital in time or not given the defibrillator, would die. And a large number of these patients, they may have an underlying genetic component. And that's where we get involved as soon as possible in most cases. The important thing to appreciate here is what is the difference between heart failure, heart attack, and the cardiac arrest. It is very both. Most people in the community and also in the medical circle might not be able to differentiate the difference between cardiac arrest and the heart attack. The cardiac arrest, what we're talking about, is an electrical problem, and heart attack is a circulation problem, what's commonly called the myocardial infarction or the coronary artery disease. And that is a complex condition, as you know. It has got a very little monogenic or Mendelian component or high-risk genetic component, except for the familial hypercholesterolemia. But cardiac arrest or the electrical problem of the heart is very important, and that's where I think our involvement is right from beginning in most UK hospitals. So if you divide into different areas, of course, the myocardial disease, which I have covered in the previous section, arrhythmias, and the vascular I have also covered. So the arrhythmia element I'm talking about, that's a pure electrical problem in which many disorders like the long QT syndrome, Brugada syndrome, atrial fibrillation, and the conduction abnormality, and all these things that come in that category. And these are well-known, well-described syndromes in their own right. So this is the large family in which this person with P collapsed, and he was brought to the hospital in the emergency room, and then he was saved by putting the emergency implantable cardioverter device. And later on, clinically and by electrophysiology, he was confirmed to have Brugada syndrome. Then all of the brother sisters were screened later on, and we found that 2 of his sisters also were affected. It just happened that, unfortunately, his daughter, who was only 7, 8 years old at that time, was also diagnosed to have Brugada syndrome, pattern electrocardiogram abnormality. And recently, all this is not shown here, recently, his son is also confirmed to have Brugada syndrome. And Brugada syndrome is very important cause for cardiac arrest. Most of these patients, that they are not doing anything, they are just quietly sitting or sleeping, and they just go into develop cardiac arrest. Unless somebody was not careful and might be mistaken as, oh, this person is sleeping quietly, and that's how they just passed on. In fact, in Japan, which is this condition very common in South Korea, Cambodia, Japan, or that nearby China and North Korea as well. And they really actually wish patient each other you should die quietly like this condition. It is a ion channel disease related to sodium ion channel number 5, but there are other many different types are also described. And the difficulty is that in this condition, there is no medical treatment. You cannot prescribe beta blockers. So instead answer is the implantable cardioverter device. And in this family, my genetic counselor colleague was instrumental to get all the family contacted and obtain information. And then one by one, we were able to evaluate clinically and as well by genotyping. So in short, emergency cardiogenetics in sudden cardiac arrest, unfortunately, we are not the first person to be called because the cardiologists are busy in the intensive care team, and they're very busy in that. But somebody has to be introduced to the family, and if sadly the person has died, which I will deal with separately on sudden death, and all those tissue, blood collection, and the review by the multidisciplinary team. All these things are done with the help of our genetic counselor, who happens to be the key person in overall management and planning. Other thing very important in most of the centers in UK, maybe also in India now, is the use of automated external defibrillator. So all of us, we need to have some kind of training. And these devices are not very expensive and very important to capture in public places like hospitals, clinics, and you might have seen in public places like railway station or airport. But we have to know how does it work, and how we have to identify the situation when this will be much more applicable. So moving on from cardiac arrest to another area of cardiovascular medicine, that is the sportsman athlete heart disease. Now, athletics and sports is a big you can say profession or occupation or hobby in different form. I noted with delight many new sports are coming up in India, apart from just popular cricket and boxing, contact sports, football, and hockey is, of course, are India's main game. And kabaddi is a very important. Kabaddi just like rugby without the football, without the ball. There's no difference if you look at it very closely. Kabaddi is in a small space, and the rugby is played with the ball in a larger space, but intense degree of contact between players. So, and sudden collapse, sudden cardiac arrest in the athletes or sportsmen is not uncommon. And that is a major emergency, as you can see from this slide. I mean, it could be anything like electrical, structural, functional, and all those situations in the cardiac electrical system. And underneath, there's a strong element of genetic heart diseases. As you can see from here, we are taking the example of myocardial diseases like the hypertrophic cardiomyopathy and all those elements, and of course, hypertrophic cardiomyopathy as a main example. This is a very interesting paper. Those who are interested could go and look at it. The point I'm trying to make that it is a genetics that determines the management of that athlete who unfortunately went into that state, and as well as the family members. And on the commercial side, it is the responsibility of the club or the organization, like the Sports Authority of India, to make sure.
May I interrupt, sir, please? We have only 2 more minutes, sir.
Okay. So this is at least hard, which I think because of time, I will not be able to go any further. But this is important for genotyping, as you can see from this slide. One of the important conditions in this group is arrhythmogenic right ventricular cardiomyopathy. And in Italy, sports arena, it is a condition. In fact, most of the Italian clubs, they undertake testing prior to a sports person taken into accepted to play for that club. The postpartum or the cardio obstetrics is a very dangerous area, and many ladies unfortunately die because of, especially after within 2 weeks of giving childbirth. And either there could be a pre-existing undiagnosed cardiomyopathy, there could be unaffected familial cardiomyopathy or arrhythmic syndrome. And one of the arrhythmic syndrome in this is could happen to be the HERG mutation, what we call KCNH2, which is also type 2 of the long QT syndrome. And sadly, I've come across few patients mothers who died quietly within the first 2 weeks of giving birth because they had this mutation. And then I've got 2 children who have got the implant ICD now inserted, and said their mother passed away giving birth to the 3rd child. And father could not manage, and he also committed suicide. So that's a very sad story, but very important to keep an eye on women after birth. So finally, the sudden cardiac death. I mentioned briefly sudden cardiac arrest. So this is an area which has got tremendous medical legal importance. You see many people come on the news item. This is a family in which, as you can see, most of these members who are crossed, they had some form of, in fact, in this generation 3 and this 5, they all died suddenly. And so sudden cardiac death, as I mentioned, is a huge medical legal problem, and that leads to the genotyping issues, and it leads to the family screening. And in this process, the genetic counselor is the key person. Without the genetic counselor input, it is impossible to manage these families. So this is a real family, one of my family in South Wales, which I looked after many members in this family with long QT syndrome. We were unable to establish it type. It's one of the rare type of long QT syndrome. As you know, there are now 13 types of long QT syndrome. It's well known to us. And the molecular autopsy is a key now, I think, very important for the postmortem doctor doing the postmortem to send a piece of spleen to us or blood from the cardiac puncture, and we do the molecular autopsy. Now it is done by multi-gene panel, as you can see. 30% were detected in the Mayo Clinic series, and the figure has now gone up from St. George's in London, I think. It is also duty of the coroner or the medical examiner to make sure that this is correctly diagnosed, certified, and family members are advised. We conducted a research in our hospital, and then we made recommendations to the Lord Chancellor, who is the person in charge of the law for coroner's regulation. And many papers around for molecular autopsy. This is a very important paper. Those who are interested can go and read this paper. It highlights how the whole full layout of the molecular autopsy, right from sample collection and autopsy testing and the information given back. Again, the point I'm trying to make, this is not done, it's only done by genetic counselor in consultation with the coroner team and also our cardiovascular genetic team. So that's a
Please sum up, so we are running out of time.
This is the last slide. As you can see, the role of cardiogenetic counselor is highlighted in this thing. All those areas shown in the red are important. They are the direct responsibility of the cardiogenetic counselor, and many other areas are they also are also involved. So that's the message I wanted to give. Thank you very much. Dhanyavad.
Thank you, sir. Thank you, sir.
Thank you, Dr. Kumar, for taking us through all the journey you have in the cardiac genetics. And we'll have the questions and comments at the end during the panel discussion. Thank you so much.
Okay, thank you. Thank you.
Can we please have Dr. Ramchandra to introduce the next speaker, Dr. Munir?
Hello, good afternoon to all. This year, this month is a remarkable year for geneticists. Gregor Mendel, born 18th, 22 July 20th. The genetics has grown so long today, genomic medicine as well as the genetic counselor are now on currency now. So we will going to celebrate this the 20th July, the 200th birthday celebration of Mendel. So this is a good occasion. I thought as a student of genetics to remind and make you to remember the day. Now. Yeah, sure.
Good afternoon, all. I think we just listened to one of the very comprehensive talks on cardiovascular genetics and the counseling, the role of counseling and all that. I think we are now up to listen to one of very interesting topics by Dr. I'm sorry, I'm not able to see that. I will read from here. Dr. S.J. Patil. I'm very privileged to introduce you. He is affiliated as a senior genetics consultant to Majumdar Shah Medical Center and Narayana Hrudayalaya Hospitals, Bangalore from 2006 to till date. His academics, basically, his basic medical education was from MR Medical College, Gulbarga, and then he went on to do DM Medical Genetics from SG PGIMS Lucknow, and he also did his pediatrics MD from MR Medical College, again Gulbarga. His interests are, his special interests are in genetics of congenital heart diseases and neurogenetics. And his career highlights, he has various national, international publications and in peer-reviewed journals, more than 50, in fact, that's very good. And 2 book chapters to his credits. We are eager to listen to Dr. S.J. Patil. I request you to take over the session, sir.
Thank you, Dr. Manjapa, for that kind introduction. At the outset, I would like to thank Dr. Deepa and Dr. Akhila for giving us this opportunity. You change it from there. So today I'm here to talk about genetic counseling issues in cardiovascular malformations. Now there are different types of cardiac lesions, starting from structural heart defects, valvular heart lesions, cardiomyopathy, heterotaxis, and arrhythmias. And here I would be restricting my talk to genetic counseling issues of structural heart defects, as well as bit of valvular heart lesions and aneurysms. Next slide. Next. So as far as incidence of congenital heart disease is concerned, it is 4 to 8 per 1,000 live births, which accounts for 1/3 of all major congenital anomalies associated with high mortality and morbidity. And 2 to 3 of these congenital heart disease are severe birth defects like single ventricles, conotruncal heart defects, coarctation of aorta, etc. And if we include tiny trivial lesions, bicuspid aortic wall, prenatally diagnosed spontaneous abortion, stillbirths with congenital heart disease, incidence of these congenital heart disease further increases. Next slide. So with a whole lot of new genes about the development of heart, with new genes, transcription factors, biological pathways like Notch signaling pathways, chromatin modifiers, MAPK pathway, BMP pathway. We have a lot of genes involved in the cardiac development. But genotype phenotype correlation is not that easy, because now we know that same gene mutations are known to cause isolated and syndromic congenital heart disease. Some of them can cause even cardiomyopathy as well. So some even have late effects of genes like GATA4 genes causing structural heart lesions, and in the later life presenting as dilated cardiomyopathy. Essentially, genotype-phenotype correlation is not that simple. Next. So as with any other birth defects, the congenital heart disease etiologically is highly heterogeneous. It could be chromosomal, single gene, then the commonest being multifactorial, that is gene and gene environmental interactions causing congenital heart disease. Of late, we have other causes identified through research, that is epigenetic alterations, somatic mutations, microRNAs, and of course, lastly, we have teratogens causing the congenital heart disease. Next slide. So whenever you see a child with congenital heart disease, it is essential to classify them as whether it is an isolated case or a syndromic case. Syndromic congenital heart disease accounts for around 30% of the cases. Not only it helps in genetic counseling, it also helps in choosing the test. Choosing the test, doing pre-test and post-test counseling will become very important and easy and accurate. Next slide. So to begin with, isolated congenital heart disease, which accounts for 70% of the cases, the commonest underlying etiology is believed to be multifactorial, that is gene and gene environmental interactions. And now increasingly, we know that there could be a single gene cause as well as copy number variants. And around 2% are due to pure environmental causes as well as teratogenic causes. Now, the single gene disorders account for 3 to 10% of the cases, mostly autosomal dominant de novo mutations. And wherever the consanguinity is there, the rare autosomal recessive variants have been reported. In a study done by Zaidi et al. In a large cohort of severe sporadic cases of 362 cases, 10% were due to single gene cause. Most of them were dominant de novo mutations. And some of these genes were histone modifying genes. And isolated CHT with positive family history, more likely to be single gene cause, around 30%. As far as CNV is concerned, if it is isolated, overall it accounts for around 3 to 4%. If you take specific cardiac lesions like conotruncal heart disease or coarctation of aorta, there the CNV rates are high, as high as 5 to 10%. Next slide. So as I said, isolated congenital heart disease are increasingly found to be due to single gene cause and copy number variants. But the same genes can cause both isolated and syndromic congenital heart disease, like TBX5 can cause, it is involved in the DGeorge phenotype as well as, sorry, TBX5 is involved in whole TARM as well as isolated congenital heart disease. JAG1 can cause allegedly as well as isolated pulmonary stenosis, making genetic counseling challenging in these cases. So routinely now, currently, no single gene testing is offered in the genetic clinic. No genetic testing is offered. Even if somebody wants to do, we should always discuss about low diagnostic yield, and rarely it will be clinically useful in isolated congenital heart disease. However, there are certain exceptions, like in familial cases, severe sporadic cases. Sometimes genetic testing might be necessary, more relevant as adults with CHD of childbearing age, if they want to know the risk to their offspring, and women with congenital heart disease want to carry the pregnancy, then we want to know the underlying genetic cause, and also to understand the late complications of congenital heart disease. So in these cases, even the isolated congenital heart disease, uh, we can choose to go for genetic testing. Next slide. So these are the different genes which have been reported so far in isolated congenital heart disease. Next slide. So counseling issues in isolated congenital heart disease. Management, of course, it is done by cardiologists and cardiac surgeons. One has to understand, based on the genes, now we have new knowledge of late onset complications in these isolated congenital heart disease who have operated in the childhood. And based on if the genetic etiology is known, then the counseling depends upon the underlying genetic cause. If the genetic cause is not known, based on the family history and pedigree analysis, it has a Mendelian pattern of inheritance. So accordingly, one can counsel the family and look for extended family screening and provide the risk of recurrence. If it doesn't follow classical Mendelian pattern of inheritance, one can offer the empiric risk of recurrence. Next slide. So these are the figures. Risk for the siblings, wherever there is no pattern of inheritance or no genetic cause is known, then one can offer these empiric risk of recurrences, which range from 1 to 6% for different type of cardiac lesions. Next slide. So even if the mother is affected, father is affected, there are empiric risk of, occurrence, risk to the offspring figures are available. Like if mother is affected, it ranges from 2 to 20%, highest being for aortic stenosis. If father is affected, risk to the offspring ranges from 1 to 5%, again, highest being for left-sided cardiac lesions. So overall, this empiric risk in the sibling is 2 to 3%. If there is half sib or other second degree relative is affected, risk is around 1 to 2%. Offspring, if the father is affected, overall it is 2 to 3%. If mother, then one can give the risk of 5 to 6%. Two affected sibs or a sib or a parent, then the risk is 10%. More than two affected first degree relative, most probably it is a dominant disorder. Next. So these are the adults who have been operated at young age, came to our clinic to understand, this girl, 22-year-old, a graduate, was operated with for TOF, has a family history of SIB being affected with VSD. She came 10 years back, that time only fish was available. So we offered chromosomes and fish. She was engaged. She was getting married, wanted to know risk to her offspring. So what would be the risk? Risk would be roughly around 5 to 6% to the offspring. And one has to understand that concurrence rate of recurrent CHD, that is TOF in her same type of cardiac lesion, is around 37%. So the cardiac lesions can be anything. And the other one is an 18-year-old operated in the newborn period. Otherwise doing well with some learning difficulties. We did chromosome microarray, which didn't show any copy number variance, and the no cause was identified in this case. Next slide. So this is the pre-pregnancy genetic counseling we offer for all isolated cases, teratogenic cases, even the syndromic cases with no obvious genetic etiology identified through investigations. One is periconceptional folic acid supplementation, ensuring rubella vaccine is complete before pregnancy, optimal management of non-risk factors like diabetes, epilepsy, avoiding drugs before and during pregnancy if unavoidable, use it with consulting medical professional. Avoid exposure to heavy metals, pollutants, promote healthy habits. And of course, one has to undergo malformation scan between first trimester scan as well as second trimester scan. Second trimester scan should be done along with the fetal echo heart and follow up fetal echo heart around 20 to 24 weeks. Next slide. Next slide. So that was about isolated congenital heart disease. Syndromic congenital heart disease could be again chromosomal single gene and teratogenic cause. Next slide. So these are the figures for underlying chromosomal causes in congenital heart disease. Before molecular cytogenetics, 5 to 2% of the newborns were known to be due to chromosomal causes. In fetuses, it was 30% could be due to chromosomal. Then came fish for 22q. Then we know that 1 to 5% of all live-born children with CHD might be due to underlying DiGeorge syndrome. And recent studies suggest that around 4% of isolated CHD as well as 15% of syndromic CHD could be due to copy number changes, that is microdeletions and microduplications. If you take selected syndromic CHD, then the underlying copy number variants could be as high as 30%. Clinically, they present with extra cardiac malformations. Next slide. So the common trisomy, we all know that the Down syndrome is associated with AV canal defect. Trisomy 13, 18 have congenital heart disease. Next slide. So the commonest cardiac lesion in trisomy 21 is AV canal defect. With good surgical care now, these children survive into adulthood. As in adults, they are at risk, sometimes at risk of mitral valve prolapse and aortic regurgitations. If found to be symptomatic, they need to be screened. In trisomy 18 and 13, the prognosis is poor. Even if they survive, they are associated with severe physical and mental handicaps. So generally, surgery is discouraged in these children with trisomy 18 and 13. Next slide. So Turner syndrome, the other common chromosomal disorder associated with congenital heart disease. Next slide. So the commonest cardiac lesions being left-sided uh, congenital lesions. Up to 20 to 50% of Turner children will have these lesions, and also they are at risk of acquired cardiovascular abnormalities. Next slide. So this shows the problems of heart in congenital ones could be bicuspid aortic valve, coarctation of aorta, VSD, mitral valve dysplasia. Acquired causes could be coronary artery disease, left ventricular hypertrophy, aortic dissections, aortic dilatations. Next slide. So the bicuspid aortic wall is the commonest one, seen in 16%, followed by coarctation of aorta 11%. Even if the initial cardiac evaluation is normal, they need to be screened for aortic root dilatation every 5 to 10 years in children. At transition from adolescent to adults, before pregnancy and throughout the pregnancy, then adults once in 3 to 5 years. And the risk of mortality due to aortic disruption and rupture during pregnancy is 2%, which can be further aggravated by comorbidities and pregnancy-induced hypertension. Next slide. So they need to be screened annually for lipid profile. The other important group of chromosomal disorders causing congenital heart disease are microdeletions and microduplications. We call them micro deletions or microduplications because they are because of their size, which is less than 2 to 4 MB, which cannot be picked up by routine karyotype. We need to order FISH, MLP, or microarray to identify these small deletions and duplications. Next child. So this is the child who presented with, they are all children with congenital heart disease. The first child presented with TOF with characteristic facial features, bulbous nose, puffy eyes, small mouth, slender fingers, and polydactyly. And she was operated with submucosal cleft palate at the age of 1 year. And you can see the cleft palate and cup ears in this the third child. Next slide. So these are all cases of DeGeorge velocardiofacial syndrome caused by 22q micro deletions. Next child. So these are the genetic testing which are used to, earlier we used to do FISH, now we use microarray because not only it gives the diagnosis of the deletion, it also gives the size which can be used for genotype phenotype correlation. And also if there are any overlapping syndromes, simulating syndromes like 10p deletions can present as 22q. So they can be picked up by chromosomal microarray. Next slide. So a common size of deletion is 3 MB. Familial cases are known. Here the size of the deletion is small. So parental FISH or microarray is indicated in all cases because irrespective of clinical features in the parents because of highly variable clinical phenotype. As you can see here, both the mothers are carrier for DeGeorge deletion. However, they are absolutely fine. Their cardiac echo is fine. Only one mother having ear tag, otherwise they're absolutely normal. So the risk of recurrence depends upon whether one of the parent is carrier or not, ranging from 0 to 50%. Next. Next. So the anticipatory guidance in these children include hypocalcemia, they are at risk of learning difficulties. One has to be screened for otolaryngeal abnormalities, which can be seen in as many as 50% of the cases. Psychiatric disorders, as many as 25 to 30% of children can develop schizophrenia or schizoaffective disorder as an adults. The other rare manifestations include renal anomalies, craniosynostosis, CTV, charge-like phenotype, and corneal opacities. Next slide. So there are important guidelines to the intensivist whenever the child is, undergoing surgery or admitted in ICU because perioperative calcium monitoring and supplementation, irrespective of prior history of hypocalcemia, is very important. And irradiated blood products and CMV seronegative blood components, if needed, are given because of underlying immunodeficiency. As many as mild to moderate immunodeficiency can be seen in 50 to 80% of the cases. We call them as partial DiGeorge syndrome. In severe cases where it accounts for 0.5% of the cases, we call them as complete DiGeorge syndromes. In these complete cases, it is where live viral vaccines are contraindicated. Next slide. So prenatal testing, low risk pregnancy, any child who is diagnosed, any fetus who is diagnosed with congenital heart disease should be subjected to genetic testing, especially associated with hypoplastic or absent thymus, polyhydramnios, IUGR, and increased NT. In high risk pregnancy, if that is with the previous child with DeGeorge syndrome, in familial cases, one can do targeted testing followed by malformation scan. Non-familial cases, malformation scan can be reassuring. In some, because of few reports of gonadal mosaicism, one can go for targeted testing. Next
Sir,
slide.
sorry to interrupt, sir. We have only 3 more minutes.
Oh, okay. Single gene disorders, I'll quickly run through. Single gene disorders could be Mendelian and non-Mendelian, which accounts for 5 to 26% of the CHD. They can present as multiple malformations or isolated congenital heart disease. Next slide. So these are the various syndromes, common syndromes with congenital heart disease. Next slide. So Noonan syndrome, again, one of the commonest syndrome with congenital heart disease. Commonest cardiac lesions being pulmonary stenosis and hypertrophic cardiomyopathy. and they are at risk of other problems like short stature, undescended testes, bleeding tendencies, acute leukemia, which need to be screened for. Next slide. These are Noonan-related conditions because they are all caused by genes in the MAPK signaling pathway. Next slide. And they are collectively called as rasopathies. Next slide. This is the pathway. Any gene mutation in this particular pathway will cause Noonan-like phenotype. Next slide. So these are all children with the molecularly proven Noonan syndrome or Noonan-related disorder. Next slide. Next. Next. I'll skip through. Next. Next. Marfan syndrome, I'll skip as Dr. Davendra Kumar has already discussed. Next. 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 So the teratogenic causes of congenital heart disease, mainly neurological disorders and its medications like epilepsy. Next slide. Diabetes is one of the risk, maternal diabetes is one of the risk factors for congenital heart disease as well as cardiomyopathy, which increases 3 to 18 times more risk. So better glycemic control is warranted. Next, fetal valproate syndrome, mother on valproate causing congenital heart disease. Now nobody uses sodium valproate. Next slide. Next. This is 1980s. Mother was on phenobarbital and child is born with typical fetal phenobarbital syndrome. Next slide. Fetal alcohol syndrome, slightly underreported in India. This is a child born to a mother who was an alcoholic, presented to us with learning difficulties and congenital heart disease. Next slide. Next. 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 So this is a child who was operated at 8 months with congenital heart disease. That time we thought it is just an isolated cases. We did karyotype only because she looked a bit dysmorphic. On follow-up at 5 years, she was found to be pancytopenic. So what this case illustrate age-dependent penetrance. So close follow-up is needed in all children with congenital heart disease. The child looks isolated, later on found to be syndromic, that is Fanconi anemia. Next slide. This is a family presented with different manifestation. Mother is just short stature. First child operated with congenital heart disease, presented to us with short stature and mild intellectual disability. Next. Next. And the second baby was born with esophageal fistula, cardiac echo showing PFO left to right shunt. Exome sequencing in the family showed this rare EFTUD2 gene variant, giving us the diagnosis of mandibulofacial dysostosis Guillain-Almeida type. Next. So this case illustrates variable, highly clinically variable family, making genetic counseling challenging. Next. So there are growing number of adults with congenital heart disease which need lot of care. Next. So to summarize, counseling issues in congenital heart disease depends upon whether it is isolated or syndromic. Once you classify them isolated and syndromic, how to choose a genetic test becomes easy, and so as pre-test and post-test counseling. And based on the nature of congenital heart disease, whether it is familial, sporadic, you can counsel the family accordingly, so as prenatal diagnosis can be offered based on the underlying genetic cause is known or not known. If it is not known, provide with folic acid supplementation followed by malformation scan. Thank you.
Thank you, Dr. Patil. I think we'll go for the question and answer at the end of the next upcoming session. I request Dr. Nallur sir to introduce the next speaker.
Thank you. I'm delighted to introduce Dr. Munir Per Mohammed as a senior cardiologist. He is a David Weatherall Chair of Medicine at the University of Liverpool and consultant physician at the Royal Liverpool University Hospital, Director of the Center for Drug Safety Sciences, and also a Director of Wolfson Center for Personalized Medicine. His academic records, their PhD in pharmacology. His research interest is the data-centered and focused on personalized medicine, genomics, clinical pharmacology, and drug safety. And career highlights has various national and international publication peer-reviewed journals, more than 50, and also is author of 2 book chapters to his credits. I invite Dr. Munir to give his talk. His talk is for 25 minutes, sir. Please.
Thank you very much for the introduction. I'll just load up my slide if I can. Can you see my slides okay?
Yes.
Great. Well, thank you very much for the introduction. I am a clinician working in the National Health Service in the UK, and I'm a clinical pharmacologist, not a cardiologist. And this is slightly different in terms of the talks you've heard. It is very much focusing on pharmacogenomics, and it is really looking at, it can affect any specialty, any medical specialty. And so it goes beyond cardiology, it goes into many different specialties and can involve many different disciplines within the healthcare professions. So why do we need pharmacogenomics? Well, there's enormous variability in the way we respond to drugs. This has been shown for a long time in all countries, not just the UK, but also in India and many other countries. If you take all the data available throughout the world, what we find in terms of efficacy, the ability of a product, a medicinal product, to produce a beneficial effect, people have shown that 90% of drugs only work in 30 to 50% of patients, which means that we have a trial and error approach at the moment in the way we use medicines. We try one medicine, it doesn't work, we then try a second medicine, or we give combinations, etc., to find the medicine that works. And that's an inefficient way to be able to use medicines. On the other hand, there are safety issues as well. 6.5% of all admissions to our hospitals in the United Kingdom are related to adverse drug reactions, and similar figures have been found in India, except that the drugs which are doing it are different between the UK and India, reflecting the underlying diseases which are different in India compared to the UK. And the reasons for the variation in drug response can be largely divided into 2 broad categories. The first one is pharmacokinetics, which is what happens to the drug in the body. So the drug, when it's taken orally, is absorbed. It's then distributed through the bloodstream to the many different organ systems. The body gets rid of it through metabolizing it in the liver, and the kidney are the main excretory organ for the getting rid of the drug. Pharmacodynamics is how the drug acts on the body. And there are major proteins which drugs work on, which include ion channels, receptors, enzymes, and nucleic acids. The reason for this variation, which may affect both pharmacokinetics and pharmacodynamics, are shown on the slide as well. It can be related to age. Our renal function declines as we get older. It may be related to polypharmacy, that the fact that you may be on multiple drugs, they interact with each other, and therefore that changes the ability to be able to metabolize a drug, for example. But it's also related to genetic factors. And this is where the pharmacogenomics comes in. And pharmacogenomics is not a new term. but it was preceded by the term pharmacogenetics. And this term was coined by this German pharmacologist called Friedrich Vogel in 1957. And it is study of variation in DNA sequence as related to drug response. The term pharmacogenomics, and both terms are used interchangeably, was coined by Marshall, who's the editor of Nature Biotechnology. And this, now that we can study the whole genome and we can study DNA and RNA, relates to the fact that we can actually look at whole genomes and look at drug response. And since the completion of the Human Genome Project, the numbers of people becoming interested in pharmacogenomics, numbers of publications in pharmacogenomics has greatly increased. And you may say, well, is it really relevant for me? Well, it is relevant for all of us. It's relevant for all of us as individuals, but it's also relevant for all of us as healthcare professionals looking after patients. So this is a study from the United States, where it looked at 7.7 million US veterans, and 99% of those veterans carried at least one actionable pharmacogenomic variant. 2.9 million, that's 37%, started treatment with at least one level A drug. And level A stands for a gene-drug interaction where there's a high level of evidence from well-designed, well-conducted studies that pharmacogenomics makes a difference in terms of clinical outcome, in terms of drug choice, or in terms of drug dose. Okay, so this was in a mostly a European ancestry population in the United States. However, the same thing is also shown in the Indian population. This is a smaller study, but nevertheless based on indigen, it's based on whole genome sequences of 1,029 genomes. And 18 of the 114 clinically actionable pharmacogenomic variants and 34 haplotype variants associated with 67 clinical attestations were found in the Indian population. So basically, pharmacogenomics is common in the Indian population. And what they found was that for 14 different variants, the allele frequencies are different from that of the global population. Again, highlighting that there may be some drugs which work better in the Indian population or work less well or are more likely to cause side effects compared to a European population, for example. And what this particular study showed was that each Indian carries at least 8 actionable pharmacogenomic variants. So let me just take you through some examples. Cytochrome P450-2D6 is perhaps the most widely studied pharmacogene. 25% of the drugs that are used in different formularies are metabolized by this particular enzyme. And 8% of the UK population lack the enzyme, and in fact, similar amounts in India as well. And it's quite complex in terms of what there are differences in genomics in terms of how they affect the cytochrome P450-2D6 activity. So if you look at the world population, about 5 to 10% of individuals do not carry cytochrome P450-2D6 or have mutations which completely destroy the P450-2D6 activity. And then if you give them the routine dose that we use at the moment for 25% of drugs, then you'll get a much higher level of exposure of the drug and more likely to get adverse effects. About 10 to 15% are intermediate metabolizers, and they will get a higher response as well, with exaggerated response, but not as bad as that seen in the poor metabolizers. The majority of people are extensive metabolizers. That is, you give them the standard dose, and they get the expected response, and they get the expected pharmacokinetic curve. But interestingly, with cytochrome P450-2D6, 5 to 10% of individuals throughout the world are ultra-rapid metabolizers. That means they carry more than 2 copies of the gene. Some have 3 copies, and their families, which have been found to have 13 copies of the gene. So if you give them a standard dose, basically it's metabolized much more rapidly, and you get much lower area under the curve, and therefore lack of response. And at the moment, in every country in the world, we just basically ignore cytochrome P450-2D6. That is beginning to change. There are diseases where drugs are being developed where you need to be able to monitor cytochrome P450-2D6 before you put the patient on that particular drug. So if you look Gaucher disease, there's a drug called eliglustat, and the drug label for this says that if you're an extensive metabolizer or intermediate metabolizer, you give 84 milligrams orally twice daily. If you're a poor metabolizer, you have to cut the dose by half, just give once daily. But on the contrary, conversely, there are drugs which are in the national formulary where cytochrome P456 is not measured and which lead to problems. So here's an example, codeine. Codeine will be widely used throughout the world. It's a painkiller. However, 6 to 8% of the population will not have cytochrome P452D6. Codeine is a prodrug. It needs to be metabolized by cytochrome P452D6 to morphine to produce the analgesic effect. So what happens in the 6 to 8% of individuals is that they don't get any analgesic benefits at all from codeine, i.e. codeine doesn't work. And in the UK, it's 6 million UK individuals do not actually produce enzyme cytochrome P452D6, and codeine will be useless in them. And obviously in India, that's a much larger proportion of the Indian population in absolute numbers who will be getting codeine, but won't have any beneficial effect. And if you look at the same paper I mentioned earlier, cytochrome P452D6 from this analysis was one of the major P450 enzymes affected within the Indian population, with a frequency of between 6 to 8%, depending on which Indian population you looked at. So it's important for drug choice, but it's also important for drug dose as well. And Paracelsus, who's a philosopher, polymath from the 15th century in Middle Europe, said poison is in everything and nothing is without poison. The dosage makes it either a poison or a remedy. At that time, he didn't know the role of genetics, but we're finding out that genetics is extremely important in determining the drug dose you require to be able to produce an effect. So I'm going to take you through one example that we worked on, which is warfarin. In the UK, about 1% of the UK population take warfarin, and the similar numbers will be present in India and in other countries as well. The problem with warfarin is that you can't tell what a dose an individual require. Some may require 0.5 milligram a day, some require 20 milligrams a day, and there's a 40-fold variability in dose. And if you get the dose wrong, even though you can monitor INR, which is a laboratory biomarker, you can get problems such as bleeding, such as this calf hematoma in an 82-year-old woman after 6 weeks on warfarin. So in order to understand the pharmacogenomics of warfarin, you need to understand the mechanism of action of warfarin and how it's metabolized. So warfarin is administered as a racemate. So it has S and R warfarin. SR warfarin is the most potent enantiomer. It's metabolized by cytochrome P452C9 to inactive metabolize. Cytochrome P452C9 varies in the population in terms of having low activity variants as well as high activity variants. Warfarin inhibits an enzyme called vitamin K epoxidase complex, which is important in the vitamin K dependent production of clotting factors 2, 7, 9, and 10. Again, vitamin K epoxidase gene varies in terms of polymorphism, and therefore you have people with low activity VCOC1 as well as high activity VCOC1. And therefore you can then determine whether somebody may require lower doses depending on the genotype. We did a genome-wide association study. For those of you who are familiar with genome-wide association study, what you have is chromosome numbers on the x-axis and the minus log 10 p-value on the y-axis. Typically in a genome-wide association study, because you're looking at millions of different variants, the p-value to determine GWAS significance is 5 times 10 to the minus 8. So here you can see that we've got two hits, cytochrome P452C9, the enzyme which metabolizes warfarin, and vitamin K epoxidase complex, which is an enzyme inhibited by warfarin. And the p-value here is 10 to the minus 30 and 10 to the minus 50. And if you look at the total contribution to warfarin dose requirements, it is about 42% the genetics was responsible for 42% of the dose requirement. Clearly, there are other factors as well, such as age. As we get older, we require lower warfarin. As we get heavier, we require higher doses of warfarin. And people may be taking drugs as well which interact with warfarin. And when you've got this kind of data, what do you do with it? Well, you can develop an algorithm which allows you to be able to dose. But then people will say, what does that algorithm mean? So what you have to do then is to do a randomized control trial, which is what we did. Just incidentally, before I show you the randomized control trial, in the Indian population, the VCOC1 gene, those are the polymorphisms which can affect warfarin dose requirements, are pretty common in the Indian population. And the STAR3 gene, which is the low activity variant, 10% of activity, is present in 10% of the Indian population. So this is the randomized control that we did. We did this in the UK and Sweden. And what we did was to get patients who were being started on warfarin to have a genetic test. We used a point of care test, which provided us with results in 2 hours in the clinic on 3 alleles in the 2 genes I've just talked about. When we got the results on those 3 alleles, they were input into a algorithm on the web, which then told us what the dose should be. And we then randomized, we compared those people who were randomized to genotype dosing compared to those who were standard dosing. In standard dosing in the UK and in Sweden, we give 10 milligrams on day 1, 5 milligrams on day 2, and 5 milligrams on day 3. However, in the genotyped arm, we could give different doses depending on the genetics. It could be 6, 4, 2, for example. And what we did was to look at the primary outcome measure at 3 months, which is time within therapeutic range. And if you look at the control arm, we got very good results. 60% of people were within this 2 to 3 range in terms of therapeutic INR. That's fantastic control because it was a clinical trial. Normally in clinical practice, it's much lower than that. But despite this very good control in the control arm, we actually got much better control in the genotyped arm at 7% difference. And 7% difference, we know from the literature, makes a clinically important difference in terms of reduction in numbers of bleeds, reduction in terms of numbers of strokes as well. Pharmacogenomics is also important for drug safety, area which has really been important with regard to drug safety in the human genome is the HLA locus. This is present on the short arm of chromosome 6. It is the most polymorphic region of the human genome with 3 different areas, HLA-BC, HLA-DRTQ-DP, which is class 2, and in between class 1 and class 2 is the class 3, which includes tumor necrosis factor and so on. It's associated with more than 100 diseases. But also data now accruing has shown that it is associated with severe adverse drug reactions. This is a patient with toxic epidermal necrosis related to having been given a drug such as carbamazepine. And there are many examples of this, how HLA can help. And the most important one, I guess, is with a drug called abacavir. It's at least one of the first ones. And work which was undertaken in Australia, in the United States, and by ourselves was able to show a very strong association with this particular HLA, which is B*5701. We asked a simple question, would it be cost effective to be able to implement B*5701 genotyping in HIV clinics in the UK before people went on to abacavir hypersensitivity? And our modeling showed that it would be cost effective. What happened then was that HIV clinics utilized our data and were able to persuade the healthcare managers in the different NHS hospitals to be able to fund the genotyping of HLA-B*5701. Before genotyping, the frequency of abacavir hypersensitivity was about 5 to 7%. Since 2006, that was 2 years after we published this, we've been genotyping everybody who goes on to abacavir before they go on abacavir. And the net effect of that has been that this has decreased the incidence of abacavir hypersensitivity to almost negligible levels. I hardly ever see abacavir hypersensitivity now. And this particular allele is present in about 4% Indian population, which is similar to the UK population, about 4 to 5% of the UK population. And since the beginning of the century, a large number of HLA alleles have been identified which have been predisposed to serious adverse drug reactions with the number of drugs you can see here. They're present in class 1, in HLA-A, HLA-B, HLA-C, in class 2 antigens as well. And what we've developed is an HLA gene panel, which people can use before they put people on drugs and so on. So if we look at where we're going with pharmacogenetics, is that we've been very good at identifying novel genetic associations, but we've been less good in terms of applying and implementing this into clinical practice. And there's increasing interest on how you can implement pharmacogenomics into clinical practice, which is really mainstreaming of genomic medicine into healthcare. And there's increasing interest again, and this is data from PubMed, which shows the number of people being interested in pharmacogenomics implementation has increased over the last 5 years or so. And there are many efforts on implementing pharmacogenomics. Most of them are centered on individual hospitals. In the United States, for example, the Mayo, Harvard, Brigham General Hospital, Vanderbilt Hospital, etc., have started to implement pharmacogenomics. Qatar is looking at this in terms of individual hospitals or whole health systems. And in the National Health System, in the UK, National Health Service in the UK, we have an integrated healthcare system and so we are thinking about how we can do large-scale whole population implementation. We've done a pilot, for example, in this particular gene, which is dihydropyrimidine dehydrogenase. It's an enzyme that detoxifies 5-fluorouracil, which is a chemotherapy drug used in about 15% of cancers. A deficiency of DPD can cause bone marrow suppression and death if somebody's given 5-fluorouracil at the conventional dose. So genetic testing was introduced into the NHS in 2020, and so far we are now doing 40,000 tests per annum in the UK for DPD testing before people go on to 5-FU or capecitabine. But we only at the moment test for 4 variants which are derived from European populations. What we don't test for are variants which are derived from maybe Indian populations, from African populations, from Chinese populations, etc. And so there's a project going on at the moment to identify these rare variants which may be present in different ethnic groups, so we can widen the panel testing that we do for DPD so that we don't exacerbate health inequalities. So in order to help implementation, I chaired a working group for the Royal College of Physicians and the British Pharmacological Society. The Royal College of Physicians represents 26 medical specialties, including clinical genetics. And what we did was to really look at what the state of the art was with regard to pharmacogenomics and how we can actually implement this into the UK Health Service and really try to persuade the UK Health Service to be able to implement this. This report is available free on the web, and I've put down a short URL that you can utilize to be able to get access to it. Now, we've come out with several recommendations. These are all on the slide, and I won't go through each of those. But basically what we said was the pharmacogenomics is important. There's quite a lot of good evidence out there for clinical utility. We need to introduce this throughout the whole of the National Health Service in a way that doesn't exacerbate health inequalities or provide a postcode lottery. We need to be agile in terms of the fact that pharmacogenomic knowledge is increasing all the time, and we will need to make this a system which is dynamic. Unfortunately, many people do not know much about pharmacogenomics, so you will need to have a very good education training package and supporting for clinicians and as the service is rolled out. And patients are going to be central to this, but there should be more research in this area, and obviously making sure that people understand what pharmacogenomics is about, what the advantages are, but also what the limitations are. And clearly, where we said and highlighted the report that this is for the patients and the public. What we do at the moment as a standard approach for the patients, and this is a cartoon we did as a lay summary for the public, was that people are prescribed medicines, then basically the medicine may work on them or may not work in them at all. And therefore, then they have to go to second medicine if they're not given the right drug. But actually, with the pharmacogenomic approach, they have a pharmacogenomic test, so they get the right medicine the first time, and therefore at the right dose, and therefore they get much better outcomes. The ultimate goal actually is to make pharmacogenomics a reality for everybody in the NHS. But it's important that although you've been talking about genetic counselling, and genetic counselling could be sort of taken in a broader context of the genetic specialty, this really pharmacogenomics is relevant for all medical specialties. It doesn't need geneticists to be involved. It doesn't need genetic counselors to be involved. It is relevant for everybody who prescribes a medicine. And we've said in this report that genetic pharmacogenetic tests should be treated in the same way as we do use liver or renal function tests at the moment, because there's nothing different about this apart from the fact that you're looking at a different part of the body system. So I'll just finish here. Pharmacogenomics has a long history. We all carry pharmacogenomic variation in our genomes, but unfortunately, at the moment, we largely ignore pharmacogenomics despite the increasing knowledge of pharmacogenomics since the completion of the Human Genome Project. With the increasing availability of genotyping technologies, we now need to implement a clinical practice. We need to use pharmacogenomic variation in the same way as we use other factors such as drug interactions, renal function, etc. Pharmacogenomics, as with other forms of genomics, at the moment very much is focused on European ancestry population. If you look at the world literature, we need to make sure that we capture different populations across the world so we capture the diversity of our population. So I just want to thank all the people who work with me, and thank you very much for your attention. So I'll stop sharing.
Thank you very much, sir. You helped us visualize the future, sir. But we have miles to go before we sleep. Let me request all of you to join us in the panel discussion now. Can we request Dr. Patil to join the others on the stage, please? The topic of our panel discussion is genetic counseling referrals in cardiological disorders in India versus UK. What is the way forward? I request Dr. Bhavar to start the panel discussion, please.
Thank you so much, ma'am. I'll just initiate the things with two questions to Dr. Kumar. Number one, Dr. Kumar, you have a large experience of working with various cardiac patients in the UK regarding genetic counseling in various cardiac emergencies. I would just like to ask you, what's your carry home message and how effective you were in preventing those in other family members of the same patients? And number two, as ma'am said, we need to have India versus UK. So the second is, you are well versed with the Indian scenario because you keep coming to India almost every year. So depending upon your experiences in India, what kind of a genetic test for various cardiac disorders you would like to order or offer, which could be, I would say, cost effective and giving us more information on the disease. So your take on this, sir.
Thank you, Professor Bauer, and members of the panel. The situation is now improving and expanding, not only in India, but many other low and middle income countries. So yes, I'm associated with India mainly because of my origin here. And I know many colleagues who are working, and the status of clinical genetics, medical genetics, and also genomic research, and now genetic counseling is fast changing, which is a very positive sign. However, there are still many areas of which is, I think, not new for any science, from the concept to take it to the specialist area and then to the general public. And India has a good track record now in the information technology. We are leader, and it was a time which was hardly known to us, but we have made huge progress. So this is going to also apply in many other areas. So let me just take the first question here. So first of all, there is no need to evaluate every pregnancy in a specialized manner. Pregnancy is a normal physiological event in any woman's life. It should not be treated in a very medicalized manner. However, it is our responsibility to select carefully the pregnancy that needs to be evaluated. I'm aware that there is a rapid introduction of investigations which are available. For example, let's just take the blood, mother's blood, any pregnant, irrespective of the background, and that's at 10 weeks, 11 weeks, and then later on at 15, 16 weeks, so-called the maternal blood investigations. With a view to find whether there could be a fetal abnormality of any type. And that is not a good way to approach any pregnancy. Coming to the fetal echo, what is recommended? The fetal echocardiography is a very specialized imaging method. In the UK, only very few centers are actually authorized or recommended for this kind of specialist service. So we have got pediatric cardiologists who are expert in fetal echo. We've got people in the fetal medicine also experts. So we have to select a pregnancy very carefully based on the previous occurrence of a congenital heart disease in the child, or the family history. Dr. Patil explained in detail about the structural abnormalities, and I also used one or two examples. So the short answer is that there is no need for fetal echo on a regular basis in pregnancy, as I said, 22 weeks. We need to carefully select the pregnancy that needs to be monitored with this sophisticated investigation.
Thank you, sir.
I think that's, sorry?
Yes, sir. Yes, sir. Can we ask the same thing to Dr. Patil, sir, in the Indian scenario? If the fetus is detected with cardiac structural defects, sir, how do you all do the counseling in your setup?
Postnatally or prenatally, you're asking?
So when the fetus is detected, sir, prenatally.
Okay. One is you have to, select the pregnancies which need to be looked for cardiac anomalies. One is, as Sir said, based on the family history, previous child, or any known risk factors like history of maternal diabetes. In those cases, fetal echo definitely is helpful. Routinely, we don't ask pregnant ladies to undergo fetal echo, like, unless there is a proper indication. Like if there is any associated four-chamber view ultrasound showing some sort of abnormalities, then you ask for initial echo at around 18 to 20 weeks, followed by the follow-up echo at around 22 to 24 weeks.
Right, sir. Dr. Manjappa, can you please reply to the next question, sir? For syndromic babies, do you suggest that all be screened for cardiac function and for non-cyanotic cardiac defects? What is the counseling and the way forward, sir, according to your setup?
Again, it is prenatal or this is postnatal you were talking about?
Postnatal, sir.
Basically, I just want to go back to that.
I'll take this question.
Sure,
Syndromic CHDs.
Correct.
I think if the syndrome has high chance of congenital heart disease, say like Down syndrome, 50% are known to have congenital heart disease. Definitely, there will be a high threshold to you ask for cardiac evaluation, irrespective of clinical finding, right? Turner syndrome, all children will be screened for cardiac irrespective of clinical signs and symptoms. Whereas if you take Fragile X syndrome, I will have very low threshold to refer it for cardiac evaluation, unless you find clinical findings like some murmur sound, chest pain, something like that. So it depends upon the syndrome to syndrome where you subject the child for acyanotic like septal defects.
Right.
I also agree with him. In most of the syndromes, at least majority of the syndromes are also associated with one or the other kind of cardiac involvement, maybe at different stages. It is worthwhile to subject all these syndromic babies to at least cardiac evaluation and make sure that there are no cardiac defects. If there are any associated defects, eventually these kids will receive the necessary or appropriate therapy. That is one thing. And the second thing, as Dr. S.J. Patil was telling previously, we all know that, generally we don't subject anybody for any pregnant woman, normally all pregnant women, to fetal echocardiography. This is basically, so whenever we are taking history of any pregnant woman, it is extremely important to make a pedigree. You not only concentrate on the proband's generation, the previous generation, and also the offsprings. That 3-generation history taking is extremely important. That will give you a lot of clues. That is one thing. And we also know that during pregnancy, during the obstetrics evaluation, our radiologist would have done what is called as anomaly scanning at around 18 to 20 weeks of gestation. I think that is that time, most of the radiologists are well equipped now to pick up the gross, cardiac abnormalities that could be there in the fetus. That is the stage when they recommend that, this patient or this child requires, or this woman requires a fetal echocardiography, and subsequently it can be subjected to. And when it comes to, because we are talking about Indian scenario versus UK scenario, one thing I'm proud and I am happy to say that in India, unlike United Kingdom or any other developed countries or any other Western countries, the cost of echocardiogram, even for that matter, fetal echocardiogram, is how much? $20 to $30. It's around 2,000 to 3,000 rupees. That's fantastic. Even for a regular echocardiogram, we hardly charge around $10, around 750 to 1,000 rupees. That is very much affordable to most of the Indian population, given that currently most of these patients are, actually, they are supported financially by the government and all these things. So even if there is slightest doubt regarding indication for fetal echocardiography, it is worthwhile to be doing in India, because there is a lot of expertise available. Nearly in every taluka level, a cardiologist is available now. And nearly in most of the districts, nearly 10 to 15 cardiologists are practicing. So that is one good thing about India. I think it should be generously asked if there is any evidence of fetal malformation. That's my take on that one. I think there are a couple of questions.
One second, can I just say? See, the question you have asked is technically something which obstetrician does. Obstetrician sees the fetal ultrasound, TIFA, or a radiologist does it, and it goes to an obstetrician. The radiologist never gives the report, or it may be given to a brother, sister, anybody. It's the obstetrician who sees it. So it is the obstetrician's call about whether they do a fetal, and then it may go to a clinical geneticist, and then the clinical am I right?
Yes,
that's the
correct.
protocol in India. So it is not that directly it can come to a cardiologist, correct? So the obstetrician is involved at the first level. Then if she finds that there's something, so do we intervene? Do we need to do more tests, or do we send it to a clinical geneticist who decides whether this is isolated syndromic? And then they take a call that should we refer to a fetal or pediatric cardiologist who can tell about the outcome and plan for delivery and so on. So that's the protocol. So if you see the Indian scenario, I think it's like that. I don't know. What do you say, Dr. Patil?
Yeah, it's kind of same thing as you said. I totally agree, madam. Ideally, obstetrician are the first one to come across the ultrasound report, family history. But sometimes if there is a previous child, they go to cardiologist, and then from there they come back to obstetrician. Whatever it, at the end of the day, it is patient should get benefited, correct information in the right time. Timing is very important. Some they come up late in the gestation, say around 8 months. That time sometimes it is very difficult. Even to prepare them for a delivery, at a tertiary care center. Yeah, Dr. Manjappa, you want to add?
I agree. Of course, those the links are, although they are very well described, they are not often followed in India. That we know. So most often, a woman would have undergone an anomaly scan during 18 or 19 weeks of gestation, and then they directly the radiologist or someone would have suggested, there is something wrong. You please go and visit a cardiologist. So directly we get often not from the gynecologist, but other way around also. So there is no hard and fast rule. These things quite happen, but definitely that is the way. Yeah, I understand.
Counselor.
Correct.
That was my point.
That is
I
the
was
way it
coming
should
to
come.
you.
That is the way it should come. I agree with
No,
you.
no, no. Where do you think in this scenario a
Ah.
genetic counselor fits in? Should a genetic counselor, would it be beneficial if there's attached to the obstetric clinic, a cardiac clinic, or a radiology?
I think all
It's all
specialties.
three. Yeah,
They
I mean,
can.
all three. We cannot just fix.
Genetic counselor, so where do
If you
No,
open
see,
positions, they are
basically,
there.
genetic counselor's responsibility or the work is not that, all 6 or 8 hours during which time they are in the hospital or like they are completely tied up. No, that I am telling. I mean, see, for example, if there is such cases, there are, for example, if I get to see around 80 patients a day, hardly one patient or two patient, I might require the help of a genetic counselor. In that scenario, there is nothing wrong in actually having this genetic counseling as a common bridge between all three.
You can
So that's
pool
what
the
I-
patients. Yeah, definitely you can pool the patients.
He's busy
Yes.
every day.
Yeah, correct. I mean, they can be a bridge. I totally agree with Dr. Manjappa. And, they can be a bridge between all the three specialities and work together. And wherever the referral comes from OBG or cardiologist or clinical geneticist, they can be a bridge point where they are in a position to give time and make the patient understand every points. That's very important. That's where the role of genetic counselor, giving enough time and talking to them clearly and clearing all their doubts and then referring to different specialties as and when needed.
So can we then assume that we have a new position open for a genetic counselor in your clinic?
Actually, I think Dr. Kumar wants to say something, and I just add one more question for Dr. Kumar, and that is, really, can we detect CHD in the fetus? What's your experience, India versus UK? So both the things you can answer, sir.
Thank you very much. I think let me just clarify. I think this question about the protocol. I think there's no doubt. I think majority of these cases are picked up by the obstetrician, whether the obstetrician is a fetal medicine expert or the general obstetrician, and so that is number one. And if the mother was known to the pediatric cardiology team because she had a previous child affected or there's a family history, and which then I think pediatric cardiologist would be involved. And so then I think I mentioned the word has been coined by Dr. Patel as well. The genetic counsel role is a bridge between different specialties. That could be, of course, the obstetrician, pediatric cardiologist, and the imaging department, and of course, clinical genetic team. That's how we function. And we have got, maybe we are in a better position. We have a dedicated genetic counselor in almost all centers for prenatal genetic counselor. They work with the fetal medicine team, and they come to know who's going for fetal echo very in advance. I mean, as soon as a decision is made, this pregnancy would be monitored by fetal echocardiogram. We'll come to know, and then we look at our record if there was anything known to us. So that's how we function. I think in a large hospital in India, I mean, I know from my little experience in Apollo Hospital in Delhi, and they integrate with the clinical genetics team almost on daily basis, and the genetic counselor also attends their meetings. So I think that's a way. It is developing the climate, the culture. But eventually, I think I gave a few examples. In each example, I coined the word bridge. Genetic counselor is a very important bridge, and then can disseminate information. Eventually, it is a family that matters. Eventually, and I'm against, even though there is affordability or relatively cost has come down, it is a good news from Indian setting, but I'm against doing it for the sake of affordability. Because if you stigmatize a child or pregnancy, the child has got, say, a very small ventricular septal defect. The child goes to school and all those things, I think the career progression, all those is teaching, which many things are there. we are not, it is not fair for the family, for the mother to know, and unnecessarily anxiety and all those things may follow. I think that's what I think. It's a dynamic process, and many things people challenge from ethics point of view. But I think given the each scenario, local scenario, within India, there is a lot of variation. So I think the professionals like us, we need to be guided by the science and the clinical medical practice.
So, sir, what are your suggestions to integrate genetic counseling in normal cardiology practice in India?
Yes, I think that's a very good question. I mentioned briefly that we have got all hospitals have got two types of the cardiogenetic multidisciplinary teams. All hospitals in the UK, and mainly the large teaching hospitals. Number one for the structural abnormalities in which the congenital heart disease will come. Second is about the arrhythmia team. And so genetic counselor is a key member of that team, happens to be same genetic counselor for both teams. But we do not get involved in normal cardiology practice. It is a cardiologist who will decide which patient or which family would need our intervention. They will bring it to the MDT meeting, and then we have a joint discussion. So normal cardiology practice remains the domain of the cardiology people, whether they are general cardiology in the district hospital or large teaching hospital like the University Hospital in my place in Cardiff or Liverpool. So I think the short answer is that it is not necessary for genetic counseling to get involved in normal cardiology practice. It is only for selected families, selected patients.
Thank you, sir. So, Dr. Patil and Dr. Manjappa, how do you think you can do that? Implement the same thing to integrate genetic counseling in cardiology practice in your setup here?
Yeah. I just would like to give you some few anecdotes. From last couple of years, we have been doing what is called as heart failure clinic. There are more than 800 patients who are enlisted for heart failure. Although, as Dr. Devendra Kumar initially mentioned, so only around 15 to 20% belong to what is that called as idiopathic dilated cardiomyopathy, which could be one of those, the conventional cardiomyopathies. It could be hypertrophic cardiomyopathy, for example, arrhythmogenic cardiomyopathy, or your other sets of cardiomyopathies. So these are the patients. Although there are other scenarios where structural heart disease giving rise to ischemic dilated cardiomyopathy, diabetic cardiomyopathy, thyroid cardiomyopathy, some storage disorders. All those things are having genetic component, but these hypertrophic cardiomyopathy, ARC, and all these things have having very high yield of probable genetic this one. See, for example, if you subject a patient with hypertrophic cardiomyopathy, the possibility of we coming out with a positive genetic testing report is up to around 30 to 40%. So that is very good. So in fact, these are the patients who have very high risk of sudden cardiac death and all these things. So this good number of patients, when we screen so many patients, when we put them on treatment, there are a big chunk of patients who will be requiring genetic counseling, and probably some of them will be requiring genetic testing and all. So what I feel is, see, for example, as an auxiliary, if I have the help of genetic counselor during my routine cardiology practice, yes, I agree with Dr. Devendra Kumar, for at least those small number of patients, we require that. And this can be passed on to, and those critical illnesses, if we can pick up and treat properly, we will do a wonderful job to the patient in saving their lives. Because identifying a proper patient and putting an ICD is one of the wonderful things that any cardiologist will do, very satisfying. I think that is the role is there, but as said by Dr. Devendra Kumar, we have to be very careful. We have to be very choosy, because it not only costs money, it will also give rise to a lot of anxiety to the patient, to the family, and also all in all whole support system. So that's my take on this one.
Yeah, could I just, I think, comment here, if you don't mind, please? I think the message is that in most of the UK centers, when a referral comes from, say, the family doctor or from other colleague in cardiology, it is reviewed by the cardiac specialist first. In most cases, they are the one who will talk to genetic counselor, and that is, you can say, okay, this is the first stage when genetic counselor could be maybe consulted but not involved. Yeah, that depends on the cardiac nurse whether he or she chooses to talk to us. Sometimes they talk to us because they want to know, did we know the family beforehand? That helps them also to decide whether to put that family and that patient into the specialist service like the heart failure service or the arrhythmia service, or in the case of children, and because those who are getting a bit older, and what we call the adult congenital heart disease service. There's a new service we have developed for patients who have survived the congenital heart disease and now become adult. So there is a third kind of service. All these services require cardiogenic input.
Yeah, genetic counselor has a major role here, collecting the family data. Regarding the cardiology here, as well the CHD, the consanguinity is very high in South India, especially Karnataka and Andhra is very high. That's also the counselor play a major role, collecting the family data, classifying that also. I hope Dr. Patil will have cases with the more of consanguinity marriages also.
Yes, we do see a lot of families with congenital heart disease having background history of consanguinity, very high, especially Karnataka and Andhra Pradesh, as Dr. Ramchandra said. As high as, starting from 30 to 60%. Yeah. That is the rate of consanguinity where, genetic counselor. I want to tell all the young genetic counselors here, you should learn how to be part of a team, You should know how to, find a place among the different specialties. That is where I think somewhere that thing is not happening. So once you find a place, work with the team, try to be physician assisted rather than independent counselor. Once you know how to be in a team and work for the physicians, how to communicate the patients based on the clinical scenario, that is what is important.
And also the CHD subtypes with our data, the VSD is more prominent in India, especially in South India, compared to other cases. That also helps for the counselor to streamline, and they can take up that also. That's more important compared to the Western data. We have our own data. Even consanguinity is about 45%. Consanguinity in a 400 family we screen for 5 years in Mysore and surrounding. That gives more information where the genetic counselor play a major role in these cases. I'll go to the Dr. Munir. Excellent talk implementing the pharmacogenomics. You have done a lot of analysis on that. With reference to India, we have. Do you think that the population basis pharmacogenomic is sufficient, or individual genotypic pharmacogenomic is needed?
Thank you for the question. Yeah, so if you look at the literature, most of the studies which have been undertaken in pharmacogenomics, in whichever specialty you look at, have mostly been in European ancestry populations. So there's not been that much work in pharmacogenomics in India. There has been some work, let's say, on warfarin, some on the statins, and a lot on anti-TB drugs, for example, because of the high prevalence of TB. So certainly more work needs to be undertaken. However, what one can also do is to utilize the information that's available in the literature in other populations. So if you're the variant in question or the variants in question are the same frequency in the Indian population as they are in the European population or another population, then, and there's good evidence of clinical utility, you don't necessarily need to replicate those clinical studies. You can actually incorporate them within your decision-making in order to be able to serve the Indian patients better. And as I said before, what we're trying to do with pharmacogenomics is go away from the kind of one dose fits all strategy, which we use at the moment in medicine, or the trial and error approach in deciding which drug you give to the patient. We're going to much more precision prescribing, if you like, whereby one can actually identify the right drug at the right time for the right dose for the right patient to get the right outcomes.
Yes, susceptibility as well as resistance variant will vary from individual to individual. So in that case, unless we have saturation studies in population basis, and in India, I'm talking about the Indian population basis, we cannot extend any of the Western data to Indian population unless we have saturation studies of the pharmacogenomics here.
It depends what you mean by saturation studies. Basically, that what you need is people have tried randomized controlled trials, and I showed you an example of warfarin and randomized controlled trial. So that showed that genotyping in people going on warfarin led to better dosing decisions. With clopidogrel, which is on the slide at the moment, that's also been shown in randomized controlled trials that if you genotype and then you decide on whether clopidogrel is given or another antiplatelet is given, you can actually show the fact that things work better when you decide on use of clopidogrel based on the individual genotype. So these have been incorporated into randomized controlled trials. And obviously, at the moment, if you do randomized controlled trials on particular drugs, they may be done in very many different populations. And we use data from different populations to be able to extrapolate to our own population. So it depends what you mean by saturation studies. So and the important thing is that you are getting more and more data now in the population of what the frequency is of a particular genetic marker. So, for example, I mentioned the warfarin markers, vitamin K epoxyhydrolysis complex. The variants are very common in the Indian population as they are in the European population. So that means that the warfarin will have similar dose requirements in the Indian population as it does in the European populations. Obviously, you need to take into account environmental factors and diet, which differs between UK and India. But there are some variants, for example, which are present in the Indian population, which are not present in the European population, and vice versa. And one of those is with the gene dihydropyrimidine dehydrogenase, which is used to prevent toxicity from the anti-cancer drug 5-fluorouracil. And as I said, we need to be able to do some studies in those situations to identify the Indian-specific variants as well as the European-specific variants so that we can actually look at it across all populations. So in the UK, 13% of the population in the UK is non-white. So, at the moment, most of the genetic testing is focused on white individuals, but not on the non-white individuals. And we are working very hard to be able to change that so we can actually capture the genetic diversity that's present in the UK population, so we can actually make sure that genomics benefits all populations rather than just one population.
I was wondering that the India, more than 4,000 cats communities are there, and they are very endemic. And it's very early to generalize that also we need more saturation studies. That's what I mean.
Yeah, so and absolutely, I understand that the genetic diversity is amazing in India, and obviously, as I said, some of the studies in terms of genomics are just starting in terms of the whole genome sequencing. But as that data increases, including the Indian Genome Project, then you'll be able to look at the different castes and different populations in India and identify the variability in pharmacogenomics between one population in India and another population in India, and therefore be able to use that information to be able to see how you can incorporate pharmacogenomics and so on. But I agree, the much more genomic sequencing needs to be undertaken in the different populations in India to be able to identify the variation. And for example, what I've been trying to do at the moment is work in the UK, but also been working in sub-Saharan Africa. I was born in my grandparents came from India, but I was born in Uganda. And I've been working in Uganda to be able to see what the differences are in the Black African population compared to the UK population. So we can then sort of start to think about how, you know, pharmacogenomics differs in one population to another, and how the implementation pathways also differ, because that will be important in terms of sorting out the pharmacogenomics into the normal clinical pathway.
Yeah,
Excuse me, in the clinic,
Munir,
excuse me, in the clinical pathway, do you think companion diagnostics would be the recommendation from your side, or a pharmacogenomic panel? So should we do companion diagnosis for warfarin or clopidogrel, or calcineurin inhibitors, or DPYD for oncology? Is that what your recommendation would be? Or we go for a larger panel of CYP2s, D6, C9, 19 for hypertension, diabetes, and so on?
Yeah, that's a really important question. Thank you for asking that question. So it depends what the situation is. So warfarin, you need to give the drug quickly because the patient comes in acute, you know, it may be pulmonary embolus, for example. And so you need to give the patient that information quickly. In that case, we often are thinking of using a point of care test. I showed you the point of care test that we used in the trial, which gave the results in 2 hours. We refined that. We can now get results on the point of care test in 45 minutes. There are other point of care tests which have been developed for other diseases where you need the drug prescription very quickly. However, for the majority of individuals, what we're suggesting is a panel approach, which means that you identify the gene-drug gene pairs which are relevant for your population. And obviously the drug-gene pairs will differ between UK and India because of different disease prevalences. And therefore, then you incorporate that gene panel because it's cheaper to actually do several variants than actually do in one variant at a time overall. And you can actually then you know, go from the strategy, which is a reactive, which is when you do one gene when a patient needs a drug, to a preemptive approach. And that's where we need to be, where you can actually incorporate the genetic information into the patient's record, so that as a patient gets one gene, one drug at the, you know, when they present to you, later on, if they get, when they're getting older, they need another drug, you've already got that information, so you don't need to keep on doing the test. And that's what we're advocating in our report at the moment, is that we go for panel testing for the majority population, but where point of care test is needed, we can do point of care tests. Obviously in the future, it may be that whole genome sequencing becomes so cheap that everybody can access it. For example, I know there's a company that's working on $100 genome, whole genome sequence at the moment. So, you know, eventually it'll become so cheap that everybody has a whole genome sequence, in which case we can actually derive the pharmacogenomic information from those whole genome sequences. But at the moment, we're not quite there. So what we need to do is to do the next best thing, which is a panel approach.
Yeah,
So if
Dr.
we
Munir,
do,
this is
and
very
then what would we do? Like if we have CYP2D6, so would we give patients, like we do for G6PD, a list of drugs they need to be aware of? Is that what you think is
absolutely. Absolutely. And that's exactly right. And that's exactly what I do for G6PD. That was the first pharmacogenetic test I did as a junior doctor. And, you know, I tell them that, you know, they have got a deficiency of G6PD. And so they're to be aware of that particular drug. And as I said, 25% of the drugs in the British formulary, and it's a similar figure in the Indian formulary, are metabolized by CYP2D6.
Yeah. Yeah, you know, I've talked about that because that's something, my son is an ultra metabolizer for CYP2D6.
Okay, yeah, and exactly. So, you know, it affects everybody, I'm afraid.
Yeah, Dr. Munir, this is a very practical problem that we face as a practicing cardiologist. We all know that currently, you know, all valve replacement, especially when they're given a mechanical prosthetic valve, there are no NOACs that can be prescribed because warfarin or coumarin derivatives are the only thing that we can prescribe, and probably we have to continue for the rest of their life till they are alive. So we all know that at least a significant number of patients after valve replacement, we come to know that they are non-responders to warfarin. However, whatever the amount of warfarin dose you give, they will not show adequate or time in therapeutic range of their INR values are very low. And most of the times they will come back with recurrent, you know, prosthetic valve thrombosis and all, which is deadly. Most often it can kill the patients. Now, my question is, how feasible it is economically as well as, although there are no recommendation, off-label recommendation, how feasible it for all these patients before undergoing a valve replacement, can we subject them for, say, warfarin response? and then take up for surgery, because if they don't turn out to be warfarin responders, then it will be very difficult for us to manage post-surgery.
Okay, yeah, so that's an important question. Thank you. So if person's not responding to warfarin, and you've given that to them, the first thing I do is to make sure they're taking the warfarin, actually, because a lot of the patients' eyes of see, and I don't take the drugs as they're prescribed. So adherence is a big issue to be able to sort out, first of all. For those people with mechanical heart valves, obviously the DOACs, direct oral anticoagulants, are contraindicated, but so warfarin is still used. And we've shown, and many other people have shown, that if you do prospective genotyping for warfarin pharmacogenetics, that is cost effective. Because depending on the cost of the test, but the cost of the test is a small part actually, it is actually a cost effective thing to do, and because it reduces the long-term complications. And in the UK, it was cost effective, etc., in terms of the UK model for cost effectiveness. Clearly, the issue does come in some people, and rarely, that you may have people who are very resistant to warfarin because they have a rare mutation in the VCOC1. Those kind of individuals have been identified in the literature. That is very uncommon. That would, that would require you to be able to do sequencing of the VCOC1, which is not the panel-based approach, to identify those rare variants in VCOC1. And clearly, if you have that kind of individual who is taking warfarin, and does not have the variants, but may have a rare variant, then obviously it is a clinical decision on what anticoagulant you give. And often in that situation, I know that in the UK, we have got some patients, then we have had to, resort to other types of anticoagulants, not the DOACs, or to give low molecular heparin, for example.
Thank you, sir. Dr. Dhavendra Kumar, sir, any closing remarks before we end the panel discussion?
Thank you. Yeah, it has been quite a rewarding experience, especially we all talking about how to enhance and empower the genetic counselors in India, using two specialized areas of cardiogenetic and then personalized prescribing, as you know, the personalized medicine, and is of course part of the purpose of genomics-led future medicine and genomic healthcare. So I think the message across, as I think Dr. Patil and other people on panel also mentioned, that genetic counselors, of course, they are independent practitioners, then that's what we need, like all of us. But I think given the complexity and the rapid development in science and technology, we need to work together. And a genetic counselor have a very powerful role in the genomic medicine and to work with the team. In fact, they could be the not only the coordinator, but they could be the leader of the team. In my sort of in the UK, if you go around, many major areas of medicine, the cancer genetics in the UK and in the Western country is a beautiful example. The cancer genetic practice is exclusively done, 90% is done by genetic counselor, 90%. And then the prenatal is done a significant proportion, and metabolic genetic counseling is done by them. So there are many examples. I sent a message today here as a closing remark that whatever you are doing, you have made the right decision. And I am grateful to Dr. Annie Hassan and her colleagues to set up the Board of Genetic Counseling. Still, we need to work how to get the government official recognition. We have made some progress. But nevertheless, I think we have to develop the profession. Once the profession is developed and practice integrated with other medical specialties, it's a matter of time. The profession, the regulator, everybody will acknowledge, and the genetic counseling will become a very firm profession in India with the help of other medical specialties. It's a matter of time. It's going to happen. It's already happening. We have seen that even by today, I mean, the fact that you chose these topics on the program, that means you are aware of the need of genetic counselor to get involved in these areas. So I think I'm ready. Thank you very much for that.
Thank you,
And I
sir.
hope it's been helpful. Thank you.
Thank you, sir. Dr. Bhanwar, your last comment, sir.
I agree with Dr. Kumar that we have to strengthen the role of genetic counselors at least in our Indian scenario, because we have to change the mindset over here that we have to work in conjunction with the clinicians, not under them. So that mindset has to change, that we don't have to assist them, but we have to work in conjunction with them. So I would just say that. And secondly, I personally feel that the genetic counseling services, especially in the cardiac area, needs to be developed pan-India. And depending upon the population stratification which we have in our country, we have to really evaluate different tests for different areas. Because the tests which can be there in South India, they might not be workable in the Northern Indian population groups as such. So that population stratification role we have to take into account. And I'm thankful to Dr. Annie for asking me to come here, because I don't work in genetic counseling area as such, but the 2 days conference over here has enlightened me a lot. And now going back, I will start the services in my area. Thank you so much.
Thank you so much, sir. We are very grateful to Dr. Dhavendra Kumar, Sir Munir, Dr. Manjappa, Dr. Ramachandra, Dr. Bhavar, and of course, Dr. Patil for participating in this enlightening panel discussion. Please be seated. Dr. Hema Malini, can we have you here, please? We are going to distribute the certificates
One
and
last thing,
appreciation.
Dr.
Yes, sir.
Yeah. See, we don't want counselor to work under us. Let me be very clear. They have to be physician assisted because they have to grow with us. They have to understand the nuances of, the patient care, how, starting from their body language, how to learn to speak among the team, So that's where I feel like they need to assist and learn from us as a young genetic counselor. Once they grow, they are, they can be a leader for all of us. That's how it should be. And they should never work under us. That's the last thing we want.
Yeah, I also agree with him, sir. Considering the way the genetic counseling has picked up in last 1 decade or so. So just imagine 10 or 20 years back, all these things were unheard of. Now, probably 1 decade later, we might be in a position that, every hospital or every outpatient clinic is run along with the genetic counseling just beside me. I think in that scenario, it is always best to have a very good relation, very good rapport with the clinician. That is extremely important. See, most often, few times we have witnessed this one. See, it is extremely difficult to approach a genetic counselor. Rather, they feel, all these genetics, although, for a practicing cardiologist also, for me, it is extremely difficult to remember all these, genes or whatever, your aneuploidy, euploidy, this ploidy, very, very difficult. Okay. Same. So when you are actually, you are not only, so I will be extremely good at picking up all these things. And at the same time, you should also be generous enough to discuss all these things with your consultant and make a, rather, a good way forward rather than, getting into friction with them. That is extremely important. If that is done, I think, this field is going to grow very rapidly.
If I would love to add here, I think the cardiology session so far, the panel discussion has been most beneficial for us GC so far, because you've all expressed that, if we have good genetic counselors who know and who are able to work well with a team collaboratively, you're very okay to have them as a part of your team. And it's our responsibility to train these genetic counselors. And please, my request is create a position in your departments for genetic counselors, and we'll soon have people for you.
My opinion here, clinicians, genetic counselor, as well as basic scientists, they are needed, biochemists or genetists, but they need a to bring the whole scenario together, and nurses and law persons to make the whole genetic counselor affect properly in the country, holistically. And every major hospital have at least dozens of genetic counselors in the first level. Then they integrating with all the holistically, that's very, very important. Then we can increase that also. That is our motto with genetic counselor, very, very essential now in the interest of the patients, interest of the family, in the interest of the country and the diversity, whatever we have. This is my, but don't ignore basic scientists here. The genetics or, biochemists or molecular biologists, they are the one giving all the information for the genetic counselor as well as the clinicians. So that also has to be strengthened in a whole group, in a holistically. Thank you.
Yes, Professor Kumar, please tell.
Yeah, this is a message through us, through all people today present in the audience, to communicate with your the health providers, the politicians, the officials, that in terms of basic health economics, having a genetic counselor is far cheaper than having a fully trained super specialist doctor with an MDM or DNB. I'm not saying that we need everybody, but I think that given that the enormous size of the Indian population, 1.3 billion people we're talking about, do you know what's the criteria in the UK for having a genetic counselor? 1 in every 250,000 population. If you say, okay, fine, never mind UK criteria. If you say 1 in million, how many you would need in India? You can work it out.
We are 18,800 short.
Exactly, you're right. I mean, Dr. Enigerson is part of the Hugo Genetic Counseling training subcommittee. I'm fortunately chair of the Hugo Education Committee, and they're working precisely on the manpower issue. And I think the Hugo as a global body, and is going to, through WHO, we are going to communicate with all countries, including the mostly low and middle income countries, India. Fortunately, just for information, the famous person from India who is in WHO, chief scientist, Professor Sominathan, and she is also advocating the need for genomic manpower in healthcare. So I think time is very right. What we need to do, we need to present to society that the genetic counselors are very valuable, working with the many medical specialties as a clearly defined professional. Thank you.
Thank you, Professor Kumar. I request Dr. Hema Malini to please proceed.
Thank you for such a wonderful, interactive and informative session. Now I invite and request Dr. Vijayalakshmi, ma'am, to honor our speaker, Dr. S.J. Patil.
Professor Kumar and Sir Munir, we just request you to be online for 2 minutes. We'll just arrange for a quick photo.
And our chairpersons. Professor Dr. Amarjit Singh. Professor Dr. N.B. Ramchandra, sir. Dr. Manjappa M. Thank you. Madam. Madam.
Vijayalakshmi ma'am, please stay back. We're just taking a quick photo. We also have the moderators. Banwar sir, please. So Professor Kumar and Sir Munir, for us, you're all in one frame. Stand, Reena. Reena, stand up. Anuradha, just come in.
Thank you, ma'am.
Thank you so much. Thank you so much, Professor Kumar. As always, you've always been so supportive. Thank you, Sir Munir, for your amazing lecture and for your question and answers session. It was really, really, we learned a lot from it. Thank you so much. Have a great day.
Thank you.
Thank you. Bye, sir.
Bye.
Thank you. Okay. Thank you.
Everyone, now we have 1.5 hours of time ahead of you. So coming to the fun part. So we have arranged for games in the basement. So now everybody who participates today, right? Today is just the beginning. Tomorrow we have a final game. We're going to have a treasure hunt that's going to span the entire JSS campus. So anybody who wins in today's game will directly enter level 2 of treasure hunt. And there are cash prizes organized by our sponsors. So you have 1.5 hours, rush to the basement, and all the questions are science related. So, I mean, brush up your basics, by the way. So please enjoy your tea break also. And please come back here sharp at what time? 6. Please be here by 5:55. Yeah. We don't want to miss the next important session on oncology.
One and all. So according to Indian Standard Time, so both the offline delegates along with online delegates. So myself is Manjunath. I'm faculty department of anatomy here JSS Medical College, and I'm also be happy to be a part of organizing committee in the 7th annual international BGCI 2022. So without wasting our precious time, we'll be move on with one more very interactive session and interesting session on genetic counseling of oncology. So the general term, what we can say about cancer. So as we know, it is abnormal growth, high nucleus and cytoplasmic ratio. So some of the common cancers will be passed through the family with the genes. Those are breast cancer, lung cancer. So some of the common, mainly in the males of prostate cancer, uterine cancer, breast cancer. Most complicated one is pancreatic cancer. So I'm also very excited to looking forward to hear the advanced techniques and genetic counseling in oncology. So I would like to call upon the moderators of this session, Prachi Inamdar. The madam is a senior genetic counselor, Newburgh Center of Genomic Medicine, Bengaluru. And one more moderator, Sutopa Singha, Associate Genetic Counselor, Lilac Insights, Kolkata, West Bengal. So kindly hand over the session, ma'am. Thank you.
Hello, good evening, and a very warm welcome to yet another interesting session of the conference, Genetic Counseling in Oncology. In this session, we have experts talking about somatic and germline oncology, precision medicine, and also the targeted therapies. We've also got you covered with a very interesting panel discussion in the end on ethical issues and dilemmas faced in cancer genetic counseling. With that brief information, I would like to welcome our chairpersons, and I would like to introduce your chairpersons to you all. Very warm welcome. Hello. Good evening, everyone. Myself, Sutopa. I'm a genetic counselor from Lilac Insight. So to start with the session, I would like to introduce you to our first chairperson, Dr. Kiran PK. He is a consultant medical oncologist from JSS Medical College, Mysore. He has done his academics from MBBS from JSS Medical College, Mysore only. And he's an MD in general medicine from SN Medical College, UP. And he's a DNB medical oncologist from National Board of Examination. So he has interest in breast cancer and gynecological malignancy and sarcomas. We welcome you, sir. Can you please come on the dais? For our next chairperson, Prachi is going to introduce to you. Our next chairperson is Dr. Vijaya Lakshmi Kodati. She's a very renowned obstetrician and a gynecologist. She practices at Vasavi Hospital, Hyderabad. She completed her MBBS and PhD in genetics from Osmania Medical College, Hyderabad. She has her MRCOG from Royal College of Obstetricians and Gynecologists, London. Her expertise are premarital counseling, infertility treatment, and treatment of complex pregnancies. We welcome you, ma'am. Oh, she is also a member of examination committee of BGCI. Yes, welcome, ma'am. For the next chairperson, we have Dr. Dil Afroz. She is a professor and chair advance from Human Genetics, Sher-e Kashmir Institute Medical Science. After obtaining her doctorate from Jamia Millia Islamia, she has joined the Department of Immunology and Molecular Medicine from SKIMS. Okay, so Dr. Dil Afroz, she is also a vice president of Indian Immunology Society and has been registered as a basic clinical graduate from post-graduation and mentor as well. She has number of awards and honors as well, and she is visiting a professor at Division of Oncology is University of Linköping in Sweden, and a Department of Anatomy Science and Neurobiology in University of Louisiana School of Medicine, USA. Ma'am, she's joining from online, so she will be there. Yes, thank you.
Yeah, I'm here. Can you hear me?
I would request Dr. Kiran to please introduce our first speaker for the session. Thank you.
Very good evening to all. So this is a session regarding genetic counseling in oncology, mainly breast and ovarian cancer, hereditary syndromes. First, I'd like to introduce our first speaker, Dr. Jane Holdsworth. Dr. Jane Holdsworth has had a long-standing interest in identifying genomic alterations in human cancer specimens to understand their role in development of the cancer, establish biological and clinical relevance, and further develop for use as biomarkers in the clinical diagnostics for the routine care of cancer patients. After fellowship at Caltech, Dr. Holdsworth pursued research at MSKCC for 20 years, reaching associate attendant geneticist and associate laboratory member, and then joined a small diagnostic company where she led the scientific R&D effort to bring novel genomic findings to the clinical for both solid and hematological neoplasms across a variety of molecular genomic findings to the clinic for both technologies, and some with NIH-funded SBR grants. This experience, together with lead involvement in the growth of pharma business of integrative pathology services at the company, she re-entered academia at ICANN School of Medicine at Mount Sinai in the pathology, molecular, and cell-based medicine department, where she directs the molecular pathology clinical laboratory, integrates testing across clinical laboratory disciplines within the molecular pathology division as vice chair, and works directly with clinicians and interventionalists to improve testing capabilities. Other academic activities include Assistant Director of the Molecular Genetics Pathology Fellowship Program and Reviewer and Chairman on NIH study sections. So I heartily welcome Dr. Jane for this session. Over to you. Thanks.
Hello, everybody. Give me 1 second while I share my screen. I think you should be able to, no, not yet. 1 second. There. It's a Saturday morning here in the US of a holiday weekend. We're going to have fireworks on Monday, and I'm very happy to be able to present and say hello to my dear friends there. And I would love to be able to see you and be there in person for next year. We'll have to try and make it happen. So what I'd like to talk about today is not so much about precision medicine per se, but how we in the somatic world may need your services as a genetic counselor, and how and when should we recognize that we need one. I'm actually, after looking at the program, I saw it was pretty heavy on some of the solid tumors. And there's been an emerging role, especially in the last 5 years or so, of in the hematologic malignancies, the recognition of the role of germline in a familial setting for predisposition. So I wanted to focus specifically on acute myelogenous leukemia, or AML, and then go into a few cases and causes of incidental findings when we perform somatic molecular profiling and their implications or lack thereof. So I always like to think of when think of where molecular profiling is going to occur during the continuum of care of the patients who have cancer. I think you're all going to hear a lot about this aspect, but in my world, we're mostly focusing on how we can impact, give a diagnosis, prognose, meaning what is their outcome? Is it good? Is it poor? Or in theranostically, can we define a drug that that patient could be treated with? As you may or may not know, we receive a whole variety of specimens to be able to be tested. Obviously, some of them are a little easier than others, whether it's peripheral blood or bone marrow. We get tissues in a formalin fixed, paraffin embedded manner, which are a little bit more difficult. But then we receive others, such as a core biopsy, that are very small, and even smaller again, fine needle aspirates. And we're asked, and we often find ourselves becoming scavengers to get enough material in order to perform the comprehensive molecular profiling that's needed for these different aspects of cancer patient care. As I said, I wanted to focus on AML, and this first representation just shows you how complex molecular profiling is in this disease. Because of its accessibility and historically speaking, AML has been broken down into mostly based on rearrangements to begin with as the primary alteration. And I've shown you some here over on the top right, where you may recognize some of those translocations that are important. But with the advent of molecular a number of years ago now, we've also been able to define some of the other types of alterations. There's a couple of points that I wanted to make about this slide, that there are some of these alterations that can be used for diagnosis. And in the 2016 World Health Organization classification of AML, there are subgroups now as a definition that are defined by these alterations. And you can see some of them are based on the rearrangements and some of them are based on the actual genes themselves. You may recognize this one if you're in the oncology world, especially dealing with hematologics, as the main, this would be subcategorized then as APL. The other thing to note is that some of the alterations, and one of them is, for example, here with NRAS and KRAS, these are not unique to a specific subtype of AML or a classification of AML. They can be seen across the subtypes. So there are very few that are actually used for diagnosis. In prognosis, unfortunately, unlike solid tumors, the field is lacking a little bit. It still relies predominantly on chemotherapeutics. But in this case, we have identified, and there are now some targeted therapies that, because of the acute nature of this disease, we actually do not do comprehensive profiling in the beginning. We actually choose different methodologies in the laboratory in order to be able to deliver a result to the clinician within 3 to 5 days of diagnosis. So clearly, even targeted NGS with large panels cannot be performed to this extreme timeline. And in fact, for some of these in our lab, we have a turnaround time of 24 to 48 hours for the clinicians in order to be able to add some of these drugs to their initial treatment. What's mostly used, the comprehensive profiling in this disease, is for risk. Do they have a favorable outcome, an intermediate outcome, or a poor outcome? Again, you will see a combination of genomic abnormalities detected by FISH or in karyotype, and some others that are in there as detected by comprehensive profiling. For those of you who have an interest in this, I would strongly urge you to go and look at, it is US-centric though, the National Comprehensive Cancer Network guidelines. They are free. You can log in. You just have to set up an account with them. There's no cost. And there are some recommendations in there now for hereditary screening and some of the other oncologic conditions that you will hear about today. They're quite useful and they are actually updated every year. So in this comprehensive screening in molecular profiling, in order to be able to classify the patient as favorable, intermediate, or poor, certain uncertain significant variants are often detected, potentially of germline origin. And I want to illustrate this in two cases. The first one, a 59-year-old man who had no significant prior medical history presents to the clinic with newly diagnosed AML. The AML on bone marrow biopsy had displayed 22% blasts and a normal karyotype. They sent the specimen out for sequencing for a targeted myeloid panel, able to detect the mutations for somatic profiling. And I've put here in the red box the sole abnormality that was found in this patient. So given that, based on the risk classification, this patient would be considered as an intermediate risk. However, in this case, due to other clinical reasons, the patient was actually considered high risk and or poor risk. And the patient would then be targeted, as for a lot of these patients who fell in that poor risk category that I showed you on the prior slide, for allogeneic stem cell transplant. The routine therapy that these patients would receive anyway is standard induction. But if they showed one of those other abnormalities that I showed you that were done within 3 to 5 days, then they would add in that additional drug. In this patient's case, they did not, so they received the standard induction. They started to search for a donor for this stem cell transplant, and the patient had a sister who had no evidence of any disease, no pancytopenia or anything. When they sequenced that patient, and that sister was a match in terms of HLA with genotyping and serology. But when they sequenced the patient's blood, it was found that the sister's blood, it was found the sister bore the same DDX41 mutation. So that's pretty much convincing evidence that it's a germline variant. The question comes now, DDX41, there's data emerging now that this gene that wasn't known more than a few years ago to be involved in familial AML, actually there's a growing body of evidence, and this has become now one of the most frequent genes involved in a familial setting for AML. Most of the patients, and this has been borne out in several studies, had a normal karyotype, such as we had with this patient. They are often have not only a germline DDX41 mutation, but they can often have a somatic mutation as well. And in fact, in this figure here, the alterations that you see in this gene, if it's a germline setting, it tends to be spread across the whole gene, whereas somatic is a little bit more localized. Our patient only showed this one germline variant, not a co-occurring somatic. There tends to be a family history, but only in about 25% of cases. But about half of the patients had a personal history of pancytopenia. Our patient had neither of these two, no family history and no pancytopenia history. So what to do? This is where the variant is that was detected in our patient that we're discussing. It was not found in any database or any literature, and we needed to figure out what was the functional impact. So error number one in this case, we did not engage, the clinicians did not engage a genetic counselor. So hence my title, we need one. We did not reach out to people like Julie, who is going to give a talk later on. What was significant in this case was the fact that there had been some recent publications indicating that there were patients who had had a very poor outcome or reemergence of a leukemia if the donor cells bore a germline variant in this gene. And I've shown you two of the papers that reported this. So in this particular case, then, we went further on to look at the variant itself. It's not in our databases. There were two papers that just indicated that people with, that's not a good outcome for somebody with a germline DDX41 variant. As shown in this figure here, the amino acid is highly conserved across species. And in fact, all the prediction algorithms suggested that it would be pathogenic and deleterious. So in fact, in this case, for this patient, they made a decision not to use the sister who would have been a very good match for the transplant, but instead did a double umbilical cord transplant. So I think, and is doing well, by the way, I think this case illustrates that we, or I, as somatic molecular pathologists, need to be very clear in reporting out even variants that we may not be sure of as somatic versus germline, that it's really imperative that we report them out. Most likely we would report them as variants of uncertain significance. It's important that it goes on the report. The other thing it highlights is the importance of the clinician in order to take a personal history to know what it is. It was never done before, but it is more so now. The third thing is that it illustrates the fact that we're not just talking about the impact of germline variants here on risk of developing a disease. We're actually talking about, in this particular case, how it impacts the treatment of the patient. So a complete switch was done as to who would be the donor. And I think it also indicates very clearly how we should have engaged a genetic counselor sooner. And now it turns out, again, from the NCCN guidelines, that there are a large number of genes, and I'm not going to go through them all, both associated with familial cancer syndromes, and you'll be familiar with some of these, germline variants associated with bone marrow failure syndromes, such as Fanconi's anemia, and then simply involved with predisposition or risk of developing AML. And that list is growing, and I'm not going to go through all of those. But I would urge you to consider these and looking up some of these as you go on and progress if you're interested in the oncology setting. I wanted to give a second case, 70-year-old male with quite a significant medical history, showed pancytopenia, again diagnosed with AML, and again had a normal karyotype. The patient underwent comprehensive molecular profiling, and I've shown you the list of results here for the 4 variants that were found for somatic mutation detection. The patient was given induction therapy, and sorry, I have to move this one for 1 second. He was deemed intermediate risk, and in fact, because they did not have any therapeutic targets, the patient was given induction therapy, responded well. Sequencing again after treatment revealed that this DNMT3A variant was still present. Again, no genetic counselor was engaged. So the question then was, this patient then went on azacitidine as maintenance therapy. It turns out that 18 months later, the patient relapsed. I'm showing you here now the sequencing of that was obtained for the relapse sample. Clinically, the patient was not deemed a viable transplant and chose to have non-intensive approach moving forward. And unfortunately, the patient passed away sometime later. But what I think is informative here is that if you look at the variants that are detected, you'll see that, and I pasted the original one on the bottom here for comparative purposes, that this DNMT3A variant, it occurs, let's see if I can see it. This DNMT3A variant is exactly the same, never went. So the question comes whether or not this is a germline variant. But we do see reemergence of the TET2 variant with the appearance of another TET2 variant, and we see another RAS family member variant associated with relapse of the disease. A different profile, a different set of variants than what we found in the original sample. I have to say one thing that some of you may be familiar with is that the clinicians will sometimes order slightly different panels for somatic testing. So we have to be careful when we are reviewing these to ensure that the same genes, or ensure that either the same genes, the same exons, the same areas that are being sequenced of the genome are the same, or at the very least take that into account if it is not. So let's go and look up our various oncology databases that we use, one of which is OncoKB, recently FDA approved out of Memorial Sloan Kettering Cancer Center. And actually down at the bottom here, this reports the variants that they have found in their patients. And you'll see right at the bottom that there is a variant at that same residue as is in our patient, but it's not the same amino acid change. Knowing your databases, OncoKB coming out of Memorial, when they perform their sequencing, they actually perform a matched blood that would allow you to remove the germline variants in their reporting of somatic only. Not present here. Another database that we use for looking up somatic variants is COSMIC, though less rigorously annotated and curated. And in this case, I've shown this variant that we found. And you can see now at this position that, yes, the 7702 and L was found as identified by the arrow here. And in fact, if you look at some of the other databases, ClinVar, there were 2 reports of conflicting pathogenicity. Another database that we use for germline is Nomad, where there's often well over 200,000 alleles sequenced, and they found 7 with this variant. So the question remained, is it germline? Is it somatic? Why didn't the clinician engage a counselor? And I think the reasoning behind this, one of the reasons, is that the gene itself is not recognized in this familial setting to have an impact in AML. And in fact, what was beginning to emerge at that time were these studies that are describing clonal hematopoiesis. That means expansion of cells involved in the heme system in the peripheral blood that are increased and associated with age. There are a variety of studies now that have shown that you can find a large number of individuals who have these clonal proliferations of myeloid cells, in particular in the blood. And in fact, the most common genes I've listed down the bottom, and you can see from these color pie charts, are DNMT3A, TET2, and ASXL1. They're all epigenetic regulators, and these are occurring in the somatic setting. They are not germline. And that could be why they were found in some of those large Nomad databases, in that, patients who were apparently normal or healthy had underlying clonal hematopoiesis. What does that mean? It's over the years now, we found out that these patients who have these underlying proliferations of clones that are showing mutations, they can acquire mutations associated with proliferation. And these alterations are like your DNMT3A, the TET2, ASXL1. In the background, you would also have other clones, but they have variants and in genes that are not really associated with clonal proliferation per se. Then, with the acquisition of additional mutations, such as the RUNX1, and they're listed on the right there, these are more associated with the appearance or contribution to malignancy and transformation. So these patients who are showing this evidence of clonal hematopoiesis in a somatic setting have an increased risk of developing a hematologic, in particular myeloid malignancy. And there's been a whole series now of discoveries in this field, and we begin to define certain aspects of this. As the aging of the patients, you see more and more of these clonal proliferations. There have been some definitions now as to when we need to call them, with variant allelic frequencies of greater than 2%. These sorts of alterations associated with risk of malignancy, but they're not germline, and in fact, they're not showing any other clinical evidence or hematologic evidence of any dysplasia or any condition. When they start to show some dysplastic
Jane,
changes,
you have
yes.
3 minutes to wrap up the session.
Thank you. So in this case, so not only do you have mutations, but these are actually, you can also find copy number alterations in clonal hematopoiesis. And the patients who have these actually have a much greater risk of developing hematologic malignancies. It turns out that other studies have also shown that you can have increased numbers in patients with solid tumors. And this gives you an example now of the type of mutation report that is being given out for a patient with bladder cancer. And in fact, also the variants that are found in the blood associated with clonal hematopoiesis are also reported out. So in the case that I was showing you, what we believe is that DNMT3A, which is occurring at about a frequency that you may consider to be a germline variant, is in fact a somatic event associated with clonal hematopoiesis. So therefore, I think that this shows you overall how that we have to have a very tight interaction between the diagnostician, pathologist, the clinician, and also learning when to call in our genetic counselors to help us tease through these upcoming and new emerging alterations that we see in hematologic malignancies. And with that, I thank you for your attention. And this is my team. There was we try to have a picnic every year in Central Park. And in fact, this year we had to move it inside. And I haven't quite got those pictures ready yet to put in here. So once again, thank you very much. And thank you again for the invitation.
Thank you, Jane. Dr. Kiran, I would request you to introduce our next speaker, please. Thank you.
Thank you, Jane. That was a very informative and interesting talk. So you showed the importance of the molecular profiling in patients and also in the donors in AML cases. So that is very important, where we need to involve genetic counselors before the transplant. As we all know that recurrences are more common in AML cases in spite of having allogenic transplants. We need to involve it. It will be a teamwork. It will be a complete teamwork. And any questions?
So we'll have the question answer session at the end.
Okay.
Yeah.
Okay. So shall I go for the next speaker? So the next speaker for the session is Ms. Tanya. Tanya graduated from University of Pittsburgh genetic counseling program and has been a genetic counselor at Baylor College of Medicine since 2004. She is currently an associate professor at Baylor College of Medicine and a manager for adult genetic service, overseeing clinics in multiple settings. She provides genetic counseling to patients with general genetic indications as well as individuals with a personal or family history of cancer. In addition, she is a member of the executive committee of the Genetic Counseling Master's Degree Program and a course director and rotation coordinator for the program. She also done consulting work with Pangenomics, a company with provided genetic counseling, testing, and education in India. So I heartily welcome Tanya. Over to you.
Hello, I'm Tanya Ebley, and I'm a genetic counselor and associate professor at Baylor College of Medicine in Houston, Texas. I was asked to speak with you today about ethical, legal, and social implications in cancer genetic counseling. I've always enjoyed the puzzle of risk assessment and of trying to help patients by identifying hereditary cancer syndromes. But I also believe in the importance of seeing my patients as more than the sum of their history and diagnosis. Taking the time to reflect on the various psychosocial and ethical issues that they may be facing helps me to better serve my patients, and I'm pleased to have the opportunity to share some of my experience with you today. Unfortunately, cancer is very common. According to India Against Cancer, roughly 9 to 10% of individuals in India will develop cancer by 75 years of age. The most common cancers, as seen in this table, have the potential to be detected and treated early, significantly reducing the associated morbidity and mortality of these cancers when we know that the patient is at an increased risk. It has been estimated that up to 10% of cancers may be hereditary. Genetic testing can help us to identify those individuals who may benefit from increased or early surveillance, or in some cases, from a prophylactic surgery. With careful review of a patient's personal and family history, genetics providers can assess a patient's risk to have a hereditary cancer syndrome and guide the individual towards appropriate surveillance and management. I probably don't need to convince this group of the benefits of genetic counseling and testing, but I've listed just a small sampling of the many articles published that provide evidence that having a cancer genetics program helps to prevent cancer and save lives. In addition to the health benefits, studies have also shown benefits to behavioral and psychological health following genetic counseling. However, while I would like to argue that the benefits of genetic counseling and testing outweigh the risks, it is important to take into consideration the ethical, legal, and social implications of genetic counseling in the oncology setting. The American College of Obstetrics and Gynecology advises us that many genetic test results may cause stigmatization, family discord, and psychological distress, and should be performed with caution and with the highest standard of informed consent. Now, I acknowledge that this is strong language, and I don't say this to warn healthcare providers away from genetic testing. Rather, I want to stress the importance of thinking about ethical and social considerations that may be relevant to our patients so we can help them mitigate risks. Some ethical, legal, and social implications of cancer genetic counseling include testing of minors, concerns about privacy, confidentiality, and discrimination, questions about duty to warn and an individual's right not to know, issues of reproductive decision-making, and informed consent. In the next few slides, I'm going to give some examples of some of these issues as they arise in a fictional cancer genetic case. We'll also talk about how ethical and legal issues extend beyond the patient and their family to society at large. First, we have Mrs. Patel. She is a 38-year-old woman who was recently diagnosed with breast cancer. Noting her young age at diagnosis, her physician sends her to a genetics clinic for further evaluation. Her husband accompanies her to that visit. Now, while the patient is an active participant in the genetic counseling discussions, when it comes time to discuss genetic testing options, the patient seems uncertain and maybe even a little reluctant to pursue testing. Her husband, however, seems to see things differently and encourages her to give consent for breast cancer panel, emphasizing her responsibility to their 2 young daughters to try to obtain information that will better inform about their future risk. In this instance, the genetics provider may be worried or concerned about coercion. We can ask ourselves, if the patient suggested genetic testing, is this really voluntary informed consent? In this case, there are a few possible ethical issues at play. One thing to consider is autonomy. Autonomy is the right of competent adults to make informed decisions about their own medical care, free from coercion and based on their own values and beliefs. Another ethical consideration is informed consent. Informed consent is the process by which a patient learns about and understands the purpose, benefit, and potential risks of a medical option, and then agrees to proceed with that option. It is important to remember that informed consent is more than just a signed document. In this situation, the healthcare provider can ensure that the patient has the relevant information to make an informed choice in keeping with their own values and needs. The healthcare provider can also support the patient's autonomy, but this does not necessarily mean we are taking a passive role in the decision-making process. Oftentimes, I will give the patient examples. I might say something like, some people choose this option because of X, Y, and Z reasons, while other people choose the opposite approach for these other options. This can help to normalize both options. Sometimes we as healthcare providers might also recognize the need for other types of services, such as counseling, and refer as needed. Okay, getting back to our example case, Mrs. Patel leaves the initial appointment, saying she is not ready to make a decision regarding genetic testing and needs more time to digest the information. Unfortunately, a year later, she learns that she also has ovarian cancer. She comes back to you and says that now that she's had more time to consider her options, she feels ready to proceed with genetic testing. Her report shows that she has a pathogenic variant in the BRCA1 gene. This result is disclosed to the patient at a follow-up appointment. The patient's husband calls later that day. He says he was sorry to miss the visit today and has not talked with his wife yet because he does not want to upset her. He believes her result was likely positive, and he would like for their daughters to be tested for the pathogenic variant that was identified in his wife. His daughters are 8 and 10 years old. Each of the daughters has a 50% chance to have the pathogenic variant identified in Mrs. Patel. I can empathize with his concern, but this is a difficult question. Will you test the daughters? First, let's think about what ethical considerations might be relevant here. One is autonomy. Only now the focus is on the future autonomy of the 2 daughters. Currently, they're minors. Generally, we don't test minors for adult onset genetic conditions, so we can preserve their future autonomy. The idea is that when they reach adulthood, we want them to have the right to decide if they want the information that genetic testing can provide. We are protecting their right not to know, if that is their choice. Another consideration is confidentiality. Has Mrs. Patel given consent for the provider to share her result with her husband? Returning now to the question of testing a minor, The American Academy of Pediatrics and the American College of Medical Genetics and Genomics both recommend that we defer genetic testing for late onset conditions until adulthood. In the case of testing for a BRCA BRCA mutation, surveillance and management recommendations would not be relevant until the daughters reach adulthood, even if they are found to have the pathogenic variant. If management would change, for example, if Mrs. Patel had familial adenomatous polyposis or another condition with risks for disease that manifest in childhood, then genetic testing for the children could be indicated. Okay, now let's imagine things turned out differently. Let's say Mrs. Patel did not get ovarian cancer. Instead, she recovered from her breast cancer and has been cancer-free for 10 years. That sounds pretty good. Now she is 48 years old and has not had genetic testing. Her oldest daughter, Angela, is now 20 years old and comes to you seeking genetic testing because of her family history of having a mother with breast cancer. What concerns might be relevant now? If the daughter tests positive, does her mother automatically know her mutation status? Well, it's possible that the daughter inherited the pathogenic variant from her father. It's also possible that the pathogenic variant is de novo. But assuming the paternal family history is negative, I would have a high degree of suspicion that the daughter inherited the pathogenic variant from Mrs. Patel. If that is the case, does mom have a right not to know her mutation status? Many would argue that she does have that right not to know. But on the other hand, we also need to think about the duty to warn her of her risk. We know that individuals with a BRCA mutation, there's an increased risk for contralateral breast cancer and for ovarian cancer. If we think beyond the mother, there may also be other extended family members who are at risk. Informing them while preserving Mrs. Patel's right not to know might be challenging or impossible. Unfortunately, when it comes to many ethical issues, there isn't one right answer or one clear good choice. As our story continues, more time has passed, and Angela is now thinking about family planning. She is considering preconception and prenatal testing options for the known BRCA1 pathogenic variants. Another thing to think about is that if you were to do prenatal testing for a pathogenic variant in BRCA1, you would be testing the fetus for an adult onset condition. In some ways, this is very similar to testing a minor for an adult onset condition. As you think about offering her prenatal testing, you might consider whether the decision would differ depending on whether the patient planned to terminate the pregnancy based on the outcome of the results. Also, what if the couple planned to make a different decision if the fetus was an affected female versus an affected male? Here, we have to be careful to make sure we are not violating any sex selection laws. In this fictional case of the Patel family, I've thrown in lots of different issues that may arise, but there are still others that I have not touched on. Frequently, I am asked about matters of privacy and confidentiality. Genetic test results are private and confidential, and healthcare providers have a responsibility to their patients to respect this. However, when the genetic test results are part of a medical record, especially an electronic medical record, there is a chance that the results can be seen by other healthcare providers. In some ways, this can be a good thing, as those providers can use the information to better meet the needs of the patient. More often, though, the concern patients share is about how their insurance company might access and use their genetic information. Also, we want to make sure that only providers who actually need the genetic information for the care of the patient for that particular indication can access it. In the United States, a law commonly referred to as GINA was passed in 2008. This Genetic Information Non-Discrimination Act provides protection from discrimination with regards to employers and to group health insurance plans, but it does not offer protection in terms of discrimination from life insurance or disability insurance or other types of insurance companies. If you are interested in learning more about this law, information is available at ginahelp.org. In this fictional example, a pathogenic variant was identified in the family. However, in some families, the variant detected is classified as a variant of uncertain significance, often referred to as a VUS. This means that a variant was detected in the patient's sample, but there is not currently enough evidence to determine if the variant is pathogenic or benign. Over time, though, these variants are sometimes reclassified as the laboratory gathers additional information or as criteria for variant classification is updated. As this reclassification is becoming more common, an issue moving into the forefront is the question of responsibility of the provider to disclose updates to the patient and how long that responsibility lasts. As this issue develops, I hope we will come to better understand how long the responsibility falls with the provider to reach out to patients who have not been under their care, perhaps for years, if the provider receives an update. Likewise, how should variant reclassifications be handled when the patient is deceased? The most recent legal guidance I have received suggests that the deceased patient's next of kin, so closest family member, should be contacted and asked to contact the genetics provider for information about the patient's health care. But exact processes and policies are still evolving. It might be helpful to look into whether your institution has such a policy, and if not, to work with your administration to develop a process before the next time you're faced with receiving a reclassified result for a deceased patient. For those of you who don't practice in cancer genetics clinic, you may still encounter legal or ethical issues related to hereditary cancer syndromes. For example, if you order whole exome sequencing to diagnose the cause of a patient's connective tissue disorder, you may receive unexpected incidental findings related to a hereditary cancer syndrome. Here, even if the individual having whole exome sequencing is a minor, they may sometimes receive incidental findings related to an adult onset condition. Obviously, this contradicts what I said earlier about not testing minors. Thorough pre-test genetic counseling and informed consent can help prepare patients for possible outcomes of testing and help them to make the best possible decisions for their situation. Another thing to keep in mind is that a number of genes that are associated with adult onset hereditary cancer syndromes can also be associated with congenital or pediatric onset conditions when mutations are present in the homozygous or compound heterozygous state. One such example is the ATM gene, which is associated with an increased risk for a variety of cancers, such as breast, pancreatic, and ovarian cancer, when one pathogenic variant is present. However, having two pathogenic variants in the ATM gene is associated with ataxia telangiectasia. Thus, carriers of mutations in ATM and other genes with similar risk for autosomal recessive conditions should be informed of the reproductive implications and their options for testing. I've focused a lot on ethical issues related to an individual or their family, but there are also larger societal issues. As with many things, there is unequal access to genomic care. Some patients may not be able to access genetic counseling or testing due to financial constraints. In some instances, financial assistance programs, sometimes offered by laboratories or less common by support organizations, may help bridge the gap. Likewise, the somewhat limited number of providers and the location of providers may limit access to care. I'm encouraged by the growth I see in the number of genetic health professionals around the world, but I believe we still need more genomic healthcare providers. Another step in the right direction has been the adoption of varied healthcare delivery models, especially genetic counseling via telephone and by virtual video visits. Direct-to-consumer genetic testing, through which an individual orders genetic testing directly from a laboratory without the involvement of a genetic counselor or physician, may also someday play a greater role in helping to bring genetic testing to more individuals. However, currently not all laboratories offer the same quality of testing, and it can be difficult for individuals to assess the quality, accuracy, and appropriateness of testing offered by direct-to-consumer genetic testing laboratories. Also, the results can be complicated, and in some instances may lead to a false sense of security or reassurance, or to unnecessary anxiety. In summary, when talking about ethical issues, often there is more gray than black or white. I actually think this may be a good thing because it allows space for us to have more than one right answer. When thinking specifically about ethical issues related to genetic testing, some issues to consider are autonomy, confidentiality, and privacy, informed consent, duty to warn, and the right not to know. I also encourage you to reflect on how you might handle questions related to testing of minors and prenatal or preconception testing. Finally, we will all likely be faced with issues of justice and allocation of resources. I believe we can serve our patients well by being transparent and informing patients of their options, by educating patients so they can make the best possible decisions based on their own values and beliefs, and by protecting patient privacy and confidentiality. Also, we as genomic professionals can serve as a strong source of support and advocacy, and can think of creative ways to bring genetic and genomic care to a wider range of individuals. Thank you so much for your time and attention today. When it comes to ethics, there are often more questions than answers, but you are welcome to reach out to me if you have questions, and I will do my best to give you some answers. I can be reached at tebley@bcm.edu. I hope you enjoy the rest of the conference.
Thanks, Tanya, for very informative and important aspect of genetic counseling about the ethical and legal aspects. It was a very comprehensive talk. Thanks for that. We'll have more discussion during the panel discussion about these aspects. Our next speaker is Ms. Alice.
Thank you. I think I'll do it from here. I'll keep it. Thanks. Good evening, ladies and gentlemen, and all the geneticists and the genetic counselors here. I feel so excited being here with all of you all today. And so many things are there to talk to you all, to exchange the ideas and views about the main title of our conference, Genetic Counseling Across Various Medical Specialties. And now we have come to the oncology session here, where I think the role of the genetic counselors is established undoubtedly. This is one place where the oncologists have to take the help of the genetic counselors. That's what the first slide Jane has put up, I think. And the other areas have to be innovated gradually. This was invited, the clinicians will say, invite the genetic counselors. We need them. We need them. Anyway, that's a very nice place, but the subject is a bit difficult over here. It depends on what mindset you have. Sorry about that. I would like to introduce the third speaker now, Miss Alice Coulson. She is a genetic counselor in cancer at Guy's Hospital, London, United Kingdom. Her academics, she has done her BS in Human Biology from Loughborough University, MS in Genomic Counseling from the University of Manchester. Her interests are in cancer genetic counseling, genetics education and training, regularly delivering teaching sessions and healthcare professionals, and developing an online education resource called Nucleus. We welcome Ms. Alice Coulson to give her presentation today. Are you here?
So, hello everyone. Thank you so much for the opportunity to give this talk to you today, all the way from London in England. My name is Alice Coulson. I'm one of the genetic counsellors specialising in cancer genetics from Guy's Hospital in England. And I know this is a session focusing on oncology care. So today I'm going to talk to you about our hereditary breast and ovarian cancer family service. So I'm going to focus in on what this service is. I'm going to talk a bit about how genetic counsellors are useful in this service, and then by default how we are useful in many other similar services to this, and also some lessons that we've learned from this service that I hope will be helpful. And I'm pre-recording this talk, so I'm very happy to have any questions by email, and my email address will be at the end. So our clinic, I'm going to have referred to it as HBOC, so HBOC. That just stands for hereditary breast and ovarian cancer, so it just means this clinic that we're talking about. And we are referred a wide range of patients in this service. So the list of kind of gene mutations that we accept at the moment is here, but it's an ever-growing list. And you know, we have lots of people on here who need our care. So these genes, you will probably be familiar with them. They confer an increased risk of primarily breast or ovarian cancer, sometimes other cancers as well. So our aim is to provide personalised care for all of these patients with the ability to access all the options that they might need, provide them with psychosocial support, opportunities to take part in research, lots of different things. So we do see a wide range of people in this clinic. Just to give you an overview of who these patients then see when they come to the service. So we have a really brilliant group of healthcare professionals from a wide range of backgrounds, all with some knowledge and specialty to bring to these gene mutation carriers. So we have a urology team because we offer prostate screening for men with an increased risk, for example, with BRCA2 gene mutations. We have a breast and plastics team to think about any risk-reducing breast surgery and reconstruction that some, female mutation carriers may want to take us up on. We also have a research team who can help us recruit to any relevant research studies. We have an oncologist because some of our patients do have a cancer diagnosis in this service, so it's really useful to get their input on patients' prognosis, what their treatment options are, and where our recommendations fit into that. We also have a really brilliant team of clinical psychologists who provide tailored psychological support for patients who do come with a wide range of concerns or emotions or experiences. We also have a gynae oncology team who can help us and talk to patients about risk-reducing ovarian surgery if that's indicated based on their risk, or any kind of other research studies that are looking into gynecological related interventions. And obviously we have a genetics team. So we're the lead team in this service. We coordinate the clinic. We have a coordinator who works to bring these teams together, schedule the patients. And generally patients do have a choice over who they see. So if they do feel ready to talk about, for example, their risk-reducing breast options, they can have a chat with them. The same with gynecology or psychology if they wanted some support. Ultimately, we do also have a say in who they see. So if there's no clinical need for that, so say a patient doesn't have an increased risk of breast cancer with that particular gene, then we also do guide them as to who is most appropriate. So it's a collaborative work really to see which teams these patients visit. So just an idea of the patient pathway really. So a patient may come to us to have their genetic testing, or they may have been seen in another centre, either in the UK or they've moved from abroad. So whoever sees them to talk about that result will then request a referral into the HBOC clinic. That patient is then registered. So we have a big database of these mutation carriers, and their details are added so that we can keep them up to date, keep an eye on who it is we know has these mutations. It's a really useful resource. Patients who are then offered a triage call, so they have a conversation with one of the genetic counsellors. It's very quick. We fill out a form and we basically introduce the service. We explain what we can offer. We get a sense of what their priorities are, and then we arrange, if they want to see the other teams, then they can. And if that happens, then they have an appointment with us. Often that's face-to-face with us at Guy's Hospital. And on the day, they're able to meet, they're able to meet us, they're able to meet the breast team, the gynae team, psychology, whoever they want to on the same day. So it's always a really busy, exciting clinic. So the patients will have their own room for the morning or the afternoon, and then the different teams sort of come in and out and see them. We then follow that up with a letter and any kind of onward referrals. We also have a multidisciplinary meeting, an MDM, every lunchtime with that clinic, where we talk through each patient that we're seeing that day. So they get that multidisciplinary input, particularly if there's sort of questions around their care, maybe around any difficult psychosocial issues. So it's a really comprehensive service that they receive. So I guess this is probably something that you all know already, but patients in these scenarios with these gene mutations often have a lot to consider, and that's dependent on the gene, but they have a lot of things to be thinking about. So for example, we know there's these increased risks of breast and ovarian cancer with BRCA1 and 2 mutations, so they want to think about their annual breast screening. They might want to think about risk-reducing surgery, prostate screening for men. They might want to think about risk-reducing ovarian surgery, and we don't currently offer any ovarian screening in the UK. So these are really important discussions to have. We also have other genes that we look after. So particularly for TP53 gene mutation carriers, there's very high risks of cancer there. So we can help talk to them about that. And we do see children who have that mutation in our clinic. We offer things like whole body MRI scans. So the HBOC clinic is responsible for coordinating that, asking all the sort of pre-screening questions and fielding the results, and other genes that we see as well, where they might have different breast cancer risks and different options. And then at the bottom, the things that we always think about and patients always have to consider with any kind of genetic condition, whether it's cancer related or not, is that real kind of psychological well-being, their family planning options, their communication, and their practical arrangements if they are going ahead with screening or surgery or going through treatment. So already in this slide, a huge amount for them to think about, and a lot more as well. So that's why we try and coordinate this care together to give them the best possible outcomes. So this is just a picture of us. We obviously haven't been able to do lots of team face-to-face meetings and team photos because of COVID, but there's quite a few of us smiling in that photo. So I hope that gives you a sense of this being a very, very friendly team. And this is us meeting at one of our lunchtime discussions where we've talked about the patients we've seen during that day. So really great team, lots and lots of us, and a really positive experience. So I just wanted to highlight, this is really a lifelong journey for a lot of these patients, as I'm sure you're all aware. And there's going to be many points at which they're going to need support, or they might need contact from us. So this is just an example really of a journey. So quite a common scenario that we probably all see. We might meet a young woman at the age of 21 to test her for a familial BRCA1 gene mutation. So we find that she carries that, and we refer her into this clinic, and she has a triage call where she agrees she'd quite like an appointment with us in the HBOC clinic just to talk about this result, have a think about the risks again, what are the implications, and understand the timeline. At the age of 25 in the UK, we contact our carriers again to do something called a CAN risk assessment, so a personalised risk assessment, to see what is the best age for them to start their breast screening. And that's normally between the ages of 25 to 30, and with everybody starting by the time they're 30. So we'll do that assessment for her then. She might then contact us again a bit later on to talk about risk-reducing breast surgery, and she could see our breast and our plastics team. She might then get in touch in a few years' time if she's thinking about having a family and she wants to talk about her family planning options or the impact for her children. And then we will contact them again about the age of 40, for example, with BRCA1, talk about risk-reducing ovarian surgery, so we might see her again. And, for example, maybe she shared some quite difficult thoughts and feelings, so she could then continue on with 6 psychology sessions. So just, I guess, an example here of how we really hope to offer lifelong care, a lifelong point of contact. People often get in touch with questions about screening, questions about things they've read in the media, if they've got a question about taking a contraceptive pill, for example. And we try to be that kind of open door policy, have that open door policy where people can come and talk to us at any time without having to get re-referred or anything like that. And just an example of how we kind of use this register to contact people and develop new ways of screening and looking after them. So, for example, we've had some new updated TP53 management guidelines. So before we weren't able to offer a whole lot really for these patients, but now we're able to offer these whole body and brain MRIs every year. We offer annual breast MRI screening for women, as well, risk-reducing mastectomies. Things like H. pylori eradication for the gastric cancer risk, dermatology reviews, symptom awareness, this kind of thing. So this has been a new change for us, and actually we've been able to use the HPOC Clinic to identify all those patients who were registered with one of these gene mutations, to get in touch with them and let them know that new options are available, and that's been a really positive experience. But it does mean establishing quite complicated pathways. So we just have lots of documents and protocols just to make sure that things are, running in the way that they should. We also do trying to do a lot of outreach work with our patients who are registered with the service. So, for example, we run kind of patient update days. They used to be face-to-face, so we used to get people to come and see us in the clinic, but obviously with COVID, that's changed, unfortunately. So we've been able to offer them virtually, where we have talks from all the different themes, and we have a series of breakout sessions people can join. So, for example, last time round, we had a breakout room with some cancer charities. We had a breakout room for people who were thinking about having risk-reducing surgery. So just a chance actually for people to meet each other and, talk in a more informal setting than a clinic appointment. And on the right, we do send regular newsletters as well. So if there's been new changes in the team, for example, here, breast screening guidance or prostate screening guidance, we find this is a really good way to update people. So patients get a copy of this when they attend, and we also post them out to keep people updated. We also recruit for research studies. So in the UK, we have a research study going on at the moment called Protector. So we know that risk-reducing removal of the ovaries and the fallopian tubes is a really good way to reduce a person's risk of ovarian cancer. But some research has told us that actually if we remove the fallopian tubes even earlier, there may be a benefit to risk reduction and a benefit to quality of life, because that doesn't put people into early menopause. So we have been recruiting some of our BRCA carriers in particular, if they've been interested in having an early removal of their fallopian tubes and then a delayed removal of their ovaries through this research study. So it's been a real privilege to be part of contributing to research, and this kind of multidisciplinary team working means that patients can be approached on the day. We have a really good connection with our research team, so it works really well. So I just wanted to talk through some lessons I've learned, really, and we've learned as a team about what it's like to be a genetic counsellor in this scenario. So before this, I hadn't really done much kind of post-test work. I'd done a lot of supporting patients after a result, talking to them about the implications, checking on their well-being, that kind of thing. But we don't always get to see what happens when we refer people on, when we get them off to their screening or off to their surgery. And actually, I think I've noticed a lot of similarities in the way that we counsel and we support in this clinic with, how we support in the pre-test setting. So lesson one is the importance of getting that pre-test counselling right, and then using that to understand and help decision making after the result when people are coming forward for these decisions, for example, about surgery. So motivations and values are important, and they can impact decisions and reactions. That's not rocket science, that's something we all know. And as genetic counsellors, we want to understand that more. Why do they want to make this decision? What's their process? Have they considered what the alternatives are? Do they have any blind spots that they maybe haven't thought about? Even something as simple as, have they been able to get time off work? Is it going to be feasible with childcare? That kind of thing. Ultimately, to reduce the risk of them having post-decision regret. So we often think about that with decision regret after a genetic test, but these same things still apply when people are considering having risk-reducing surgery, for example. So in this clinic, we might challenge them. Is it the right time to go ahead? Who's going to support them? What will change if they go ahead? Maybe what won't? And I think, as with pre-test genetic counselling, managing expectations is so important. So as we manage the expectations of what genetic testing can and can't tell us, we then also have a role in explaining some patients may not be eligible for all management options. Some patients might have a slightly different trajectory to the standard procedure, or maybe what they've heard or seen in other family members. So that's really important. And HBOOK is a really good opportunity to do this, because it gives us a chance to have a period of discussion with them on the same day that they're meeting these surgical teams and making these decisions. So I've just put this Egan skilled helper model here because that's something we find quite helpful in our team, the kind of 3 stages of decision making. So I'll let you look that up if you're interested. But essentially what we do is we assess the current scenario they're in, so the decision that they're making. What's their story? What are the blind spots they're missing? What is their leverage or motivation? How can we help them make the right decision using that? We then think about their preferred scenario. What are the possibilities? What is their agenda? What's important, and their commitment? And then we come to a best fit plan at the end with all of that in mind. So having considered the pros and the cons, the blind spots, the possibilities, what is the best plan for that patient? And that's how we make it really personalised. So just 2 examples of that where that's been really important. So we met a 40-year-old lady with a PALB2 mutation. So she does have an increased risk of breast cancer over her lifetime, and she wanted to have risk-reducing mastectomies. But as her BMI was over 35, unfortunately, our team declined her breast surgery at this time, because having a high BMI can lead to more adverse outcomes after surgery. It was very unexpected that the patient was, declining this surgery. She hadn't expected that at all. She'd been told kind of through her pre-test counselling that it would be an option, and understandably, it was a very sensitive topic as well. So, we learned this lesson of setting our expectations being incredibly important, taking a sensitive approach to prevent this distress as much as possible. Another example is a BRCA1 mutation carrier who wanted to consider risk-reducing mastectomies, but her and her husband were looking to start a family, and she hadn't thought that actually if she had risk-reducing surgery, she wouldn't be able to breastfeed. So that was a kind of blind spot for her, and actually, identifying that meant she chose not to go ahead with surgery at the time. And that was difficult, but ultimately she weighed up the fact that she probably had a lower risk at her age. She had access to her screening from 30, and she really wanted to breastfeed. So we need to think about this wider context and set those expectations and incorporate that into our counselling. Lesson 2 is a really example of multidisciplinary working. So we saw a 29-year-old with a RAD51C gene mutation. So we think probably a 10% lifetime risk of ovarian cancer. This risk of breast cancer is, I think, the evidence is still emerging. But when I spoke to the patient, we weren't offering her anything at the moment. She's still really young. There's no screening that we can offer. She was very, very disappointed when she spoke to me. She had high cancer anxiety. She was very angry at not being offered screening, especially because her family members in Spain had different advice. So I found it quite hard to contain that session actually, and to kind of build that rapport after I had given her the news that she wasn't hoping for. So I went and spoke to my psychologist colleague. We explained my concerns. I explained what I had a sense of what was going on. And the next month, actually, she then spoke to psychology. And it had turned out all these things had happened that I hadn't been able to talk to her about because, unfortunately, that it hadn't happened in that appointment. So it turns out her relationship had broken down because of this genetic result, and she felt she wasn't good enough. Her mood was low, and she had limited support in the UK and had previously had suicidal thoughts. So actually what our psychology colleagues are able to do is really safely discuss risk, assess the plan, contact the GP or contact liaison psychologists. So it was a really, really helpful collaboration in that setting. And finally, the lesson 3 is this real impact that our testing has on treatment. So our ability to carry out rapid genetic testing now means we're able to offer things in a much better timeline for patients. So an example is a lady I saw, Sarah, diagnosed with triple negative breast cancer. She was referred immediately to genetics. and we offered her a rapid appointment in our sort of general genetics routine clinics within a week. So she was motivated for testing. So these arrows are passing through the process. So motivated for testing, she wanted to go ahead, gave consent, and we found a BRCA1 mutation. Because we got that result really quickly within 4 weeks while she was still having her chemotherapy. While she was quite shocked to hear about it, she wanted to really think about her options for surgery because that was coming up. And actually, now we'd identified the mutation, if she wanted to, she could choose to have bilateral mastectomies as opposed to maybe a wide local excision or a unilateral mastectomy that she may have been offered otherwise. So she came and spoke to us in HBlock actually to get a second opinion and to kind of understand this genetic result. Her local hospital couldn't offer her reconstruction with that surgery, but we were able to at Guy's at the time. So she actually ended up transferring her care so she could have the surgery that she wanted, the outcome that she wanted, and we reduced her needing to have any further surgeries in the future. So this is just one example of where it works really well, and actually these multidisciplinary clinics can have a big impact on somebody's treatment and outcome. So just a few sort of positive comments that we've had. It's really nice to get feedback, and I personally, this is one of the highlights of my job. This is a really, truly brilliant service to be part of. So people generally enjoy the MDT approach and they feel confident in their decisions and reassured, and they give feedback that we're approachable and kind, which is always nice to hear. So I think this MDT working just helps patients feel a bit more supported. They know that if we have any questions in the genetic session, we can always wait and they can ask the breast team, we can contact the gynae team, that is always available to them. So it's been a really good experience. And so I guess just a few summary thoughts of what we've learned. So genetic counselling can be valuable even once we have a genetic result, even once we're past the stage of giving the result and facilitating all of that, we still have a lot of value. And our skills are transferable. These decision-making, emotional support, setting expectations, addressing sensitive topics, it all is actually really applicable to the things that we're doing. And often our advice can be quite generalised for mutation carriers, but this really needs to be personalised. Patients have really unique circumstances. It doesn't mean they're always eligible for the things that everybody is saying that they are. So that kind of personalised approach and setting expectations from the start is really important. And it goes without saying, we all know this, but this collaborative, multidisciplinary working where we're able to helps deliver really brilliant patient-centred care. So thank you so much for listening. As I said, it's been a real privilege to present our clinic here today. My email address is at the bottom there, so I'll be very happy to take any questions. And I hope you all enjoy the conference. Thanks very much.
Thank you, Ms. Allison. That was really very interesting that you shared your wonderful experiences at one of the most prestigious hospitals in London as a genetic counselor for the cancer patients. Thank you so much. I request you to join us for the panel discussion at the after two more speakers and to take more questions. I think you will have quite a few questions from here. Thank you again. Now I request the next speaker, Ms. Julie Gold. She is a genetic counselor and a co-director of the Cancer Genetic Counseling Program at the Icahn School of Medicine at Mount Sinai's Department of Genetics and Genomic Sciences. She is BS in Human Development from Cornell University, MS in Genetic Counseling from Icahn School of Medicine at Mount Sinai. Her interests are cancer genetic counseling. Yes, Ms. Julie Gold, please go ahead. Thank you.
Okay, just getting my screen set up. Can someone confirm you can see it okay?
Yes, okay, we can see this too. Yeah.
Okay, thank you. So thank you very much for the invitation today. My talk is entitled Implications of Somatic Testing on Germline Analysis. You got some introduction to this earlier today, so I'm happy to build on this, especially from my perspective as a genetic counselor and the time that I am interacting with these patients. This is just a disclosure that has nothing to do with this presentation. So first, just to give some introduction, we are all probably very familiar, but I'm going to be talking about this a lot. So I just want to make sure that we're on the same page. So we're going to be talking about cancer formation and sporadic versus hereditary cancer a lot in terms of the two-hit hypothesis. So this is the concept of tumor suppressor genes. Everyone starts out with two working copies of their genes, one from their mother and one from their father. And then in sporadic cancer, these acquired mutations can two acquired mutations occur in the same cell, then that's when the tumor can form. Whereas in hereditary cancer, someone starts out with a mutation inherited from a parent in one copy of their gene, and that would be in all of the cells of their body. So they still need an acquired mutation, but they are one step further along in that process to cancer formation. So one thing that I wanted to reiterate is that all cells, including cancer cells, have mutations. And when we look at tumor sequencing, we are typically expecting to see variants, but that does not mean that the patient was born with those variants. It could come out of either of those needs. Okay, so this is kind of my introduction to germline versus somatic mutations. So germline mutations are inherited from a parent and replicated in every cell of the body and then can be passed on to offspring, known as that hereditary concept. Whereas somatic mutations are not inherited from a parent. They develop over the lifetime and are typically only in an affected area of the body and not therefore passed on to offspring. Germline testing is typically done on a blood or saliva sample. When a patient is referred for cancer genetic counseling, typically we are ordering that kind of germline genetic testing and looking for hereditary cancer risk. Whereas somatic testing is done on a tumor specimen, and in our center, at least, it is typically oncologists that are ordering that type of somatic testing. And the goal of that testing is majority for what we kind of heard about before, treatment options for that patient, as well as prognosis and diagnosis for that patient. So kind of different goals of the testing, but they can overlap. So in terms of germline mutations, they would be in every cell of the body and can be in the tumor cell as well. So a somatic test samples a tumor and can show mutations that may or may not be only somatic, or they may be germline in origin as well. So that's my introduction. Now I'm going to go into a few kind of pearls and concepts when looking at a somatic report and how it may impact the germline genetic testing strategy or kind of risk assessment. So the first concept is that the gene that we are looking at really matters. So this is a very colorful graph, which is from a study that basically just determined mutations that were first identified in a tumor or somatic mutations. And if they ended up being germline in origin, which is the blue in the graph, versus somatic or tumor only in origin, and that is the orange. So looking at this, they are ordered from like the most germline to the least germline. And we can see that there are some genes that are much more commonly germline in origin when we see them in a tumor or somatic sample or report. And there are other genes that are rarely germline origin when we see them in a somatic or tumor report. So importantly, BRCA1 and 2 are towards the top of that graph. So a lot of the time when we see a BRCA mutation in a tumor, it actually is a germline mutation and probably should be worked up to figure out if that is the case. Whereas other genes towards the bottom, like for example, TP53 and APC and PTEN, we see in a lot of tumor samples, and they are very, very rarely germline in origin and probably do not need to be worked up unless the patient has or the family has features that are suggestive of those typically very clear syndromes. And then something of note is clinical information may or may not be helpful in terms of determining if a mutation is actually germline in origin that's found on a somatic test. So many patients with germline mutations will actually not meet the clinical criteria that we have set out for germline testing. So their family and personal history may not be all that striking. So these are two studies. One showed about 35% of people with germline mutations actually met the clinical criteria for such testing. And another study showed about 80% do meet that clinical criteria. Sorry, the first one was 35% do not meet that clinical criteria. So it is still the majority meeting clinical criteria, but there are a good chunk of people who do not. And then the next bullet is about the tissue type. So we found in one study that 40% of the mutations were actually consistent with the cancer type. So for example, seeing a BRCA mutation or a BRCA mutation in a breast cancer would be consistent, whereas seeing a BRCA mutation in a lung cancer might be inconsistent with the tissue type. And then the last concept I want to mention in terms of genes is that we always have to look at if the gene is even associated with germline risks, if there is a known association, because remember the goals of testing are different. So there are genes on these somatic or tumor panels that really don't mean much, at least right now in the germline. So it's probably not clinically useful to confirm if they are germline changes if we don't know what that means for a patient. And germline testing may not even be clinically available. So I have a few case examples that I will go throughout this presentation, and you'll see that I kind of ignore some of the genes or variants that come up on some of the somatic reports, and that's typically because they were not concerning to begin with for one of these many reasons. So the next concept that I want to make sure everyone understands and how they use it in this scenario is allele fraction. So this is the percentage of alleles that actually have a variant or have a mutation when we're on a next generation sequencing test. So in theory, we should be able to use this number to assess if a variant is likely to be germline, because we know most of these variants are inherited in this autosomal dominant fashion where 50% of the alleles should have the variant if it was inherited from one parent or the other. I will go through some case examples where that is the case or potentially is not the case. And a lot of this comes down to the tumor characteristics in the sample. So sometimes the quality or the quantity of the tumor or the exact sample that was used for the somatic testing may impact this variant allele fraction or the VAF. Some laboratories automatically report that variant allele fraction. Some report it if a provider asks. So I have a couple of reports. Some of them automatically show that number and some of them do not. So this is our first case example. It is a patient who was diagnosed with metastatic prostate cancer at age 76. This was an Eastern European Jewish family, and the family history included a grandfather with pancreatic cancer, and the patient had no information about their paternal family history. So already a few red flags that we're seeing in the history. And then when we looked at the somatic report, it showed a mutation in the BRCA2 gene. This is a lab that doesn't automatically report that allele fraction or frequency, but I listed it below because I did call the laboratory and ask for that information. And it was 47%, so pretty close to that 50-50 that we should be seeing for a germline mutation. Looking closer at the specific variant that was identified, this is one of the specific founder mutations that we see in the Ashkenazi Jewish population. So definitely raises our suspicion there. So it's always helpful to look up a variant and see if it's something that's been reported in the germline, if it's commonly reported germline mutation. You can see in terms of this tumor test on the right, it notes some of the therapies that may be available to the patient based on this result, because that's really the goal of doing the somatic testing. Importantly, we always, as genetic counselors, take a full family history and personal history and order genetic testing based on that in addition to somatic results. And we would never just order based on the somatic results. And I will get to some of the limitations of somatic testing. So in this case, we ordered a more comprehensive panel related to the patient's personal history of prostate cancer, as well as family history of pancreatic cancer. So that included the BRCA2 gene as well as other genes. And the patient was just found to have confirmed that same BRCA2 mutation in their germline sample. So nothing else was identified, and this kind of worked exactly how it should have in terms of the variant allele fraction or frequency, where it was around 50% in the tumor, and we did find that it was a germline mutation. So this is another case example with a patient who was diagnosed with colon cancer at age 33 years old. We have universal tumor screening for Lynch syndrome that occurs on the tumor specimens. So that showed a loss of expression of the MLH1 and PMS2 proteins in the tumor. So a concern for Lynch syndrome, but not diagnostic of Lynch syndrome. In terms of the family history, this was quite a large family with a lot of siblings, a lot of aunts and uncles, and no family history of cancer until we got to great aunts and uncles on mother's side, where there was some colon cancer, but not at strikingly young ages. So overall, this patient's clinical picture was obviously concerning, but it didn't strike us as a Lynch family just looking at the family history. This is the patient's somatic testing result or tumor testing result, which showed 2 mutations in the MLH1 gene. So that would be consistent with the immunohistochemistry abnormal proteins. And this kind of shows the 2 hits that we could see in a tumor that lead us to the cancer formation, going back to that first slide that I showed you. In the variant column, you can see the VAF, or the variant allele fraction, is listed. So one of these variants is at 22%. The other one is at exactly 50%. So in theory, that raises our suspicion, and it should be a germline mutation, just given the age, the clinical picture, and that allele fraction. Obviously, we continued to order testing based on the whole picture in the family, not just based on these results. And the germline results actually did not show an MLH1 mutation. The patient had a variant of uncertain significance in the MSH2 gene that actually has now since been reclassified as a negative or benign variant. So nothing of note there. And the patient does not have an MLH1 mutation, and specifically does not have that one that was at a 50% allele fraction. So in this case, this is where we're seeing the 2 hits in the tumor, but there wasn't that first germline hit. That explains the cancer formation. So this patient does not have Lynch syndrome, does not need any extra monitoring like they have Lynch syndrome. And then importantly, that big family does not need further workup for Lynch syndrome unless they are closely related to those other relatives with colon cancer. But especially this patient's siblings, like especially the females, did not need to consider like prophylactic surgeries or colonoscopies every 1 to 2 years. They should still be monitored based on their family history of colon cancer, though. So this is, again, the basically from a study that showed the variants that ended up being germline versus somatic and where those allele fractions fall. So you can see the germline ones do hover around that 50%, but there is quite a wide range of ones that ended up being germline. And then I think even more importantly are the somatic ones. A lot of them are hovering around 50% and do not end up being germline. So we really cannot use allele fraction as the only thing or the main thing that we're considering in these cases. Okay, so my next concept is the technological and reporting considerations and limitations. So one concept that I wanted to make clear is that somatic and germline laboratories are using different evidence for their classification. So again, this is all based on the goals of the test. Somatic is to determine treatment options typically, germline is to determine inherited cancer risk. So somatic testing classification is involved in is there an approved therapy available? There's those somatic databases that give us some information. The variant frequencies are important in those cases. The germline information accounts for family history information like clinical information, segregation in the family, is it de novo in that person? There is definitely some overlap, but we can get to different classifications because the evidence is weighed differently for people for the different tests. So this is a study that showed that kind of determined the same variant and if there was discrepancy in the classification compared to a germline test result, so the laboratory's interpretation, or ClinVar, a database for germline interpretation. So for somatic VUSs, or variants of uncertain significance, between 22 and 32% of them had discrepant classifications in the germline in any which direction of getting to pathogenic or benign. And then in the positive results, or the pathogenic variants in the somatic testing, 13 to 5% had discrepant classifications. So at the diagram at the bottom, it shows the types of variants that tend to have those discrepancies in classification, but basically we cannot use a somatic report to get our germline classification. We have to either order a germline test or do our own research about a particular variant to figure out if it's even worthwhile to order a germline test, because if you know a variant is going to be benign in the germline, it may not be worth clinically to confirm if it is a germline variant. So this is basically about the limitations of tumor testing. Just like any test, including germline tests, have limitations, tumor testing does miss some variants. So one study showed that about 8% of pathogenic germline variants were not picked up in tumor testing. And another study showed it was about 10%. The table at the bottom showed the reasons that usually come down to technical limitations, including the methodology or the coverage. So tumor tests do not have the same ability to pick up like small deletions, even large deletions. There also can be allele dropout in tumors. And then important to reiterate is looking at if the gene was even part of the tumor test of concern, because sometimes it is not. And then variant classifications can be different, and that may depend on the tumor reporting, the tumor lab's protocol. So if they're not going to tell you about variants that are benign or even VUSs, then it may not show up on that report until you do some digging. So this is another case example of a patient who was diagnosed with colon cancer at 35 and had a history of polyposis, including adenomas and inflammatory polyps. This was another Jewish family, but not as relevant to this case. In terms of family history, this patient's sister had polyps. The father had colon cancer and multiple polyps. The grandfather had colon cancer, and then the nephew, which is that sister who had polyps son, also started having polyps already at a very young age. So this is obviously a very concerning history to begin with. Then we look at the somatic report. So this showed that there was a mutation in the BMPR1A gene. Again, not going to go into a lot of detail about the other variants that were identified. I will explain what BMPR1A is in a second, just to give you some more information, but it would be consistent with that history. And then I highlighted at the bottom of this slide something really important about this test. So this test did have a tumor sample as well as a blood sample. So they are able to filter out which variants seem to be germline versus not. And the reporting protocol of this lab was to not report germline variants on the somatic test. So anything that we're seeing in the tumor would be the second hit. It wouldn't be that germline mutation. So this already kind of changed our suspicion of it, that we're probably not actually looking in the germline for that mutation that we're seeing on this report, but a different mutation in the BMPR1A gene. So the BMPR1A gene is associated with juvenile polyposis syndrome, which is associated with multiple juvenile polyps, as well as a higher risk for mostly gastrointestinal cancer. So very consistent with this family history. And then we did germline genetic testing, which identified a full gene deletion in the BMPR1A gene. So that somatic variant that we saw above is the second hit. Importantly, this is kind of showing the limitations of the genetic testing in a couple of ways. So one is it wouldn't have been reported on the somatic test anyway, but then we also know large deletions are a limitation of somatic testing and may have not been reported or shown up on the somatic test anyway. Okay, so my last concept and my last case example is about incidental findings on somatic testing. So this is a patient who was diagnosed with an astrocytoma. Family history included breast cancer, abdominal cancer, and colon cancer at later ages, so wasn't all that striking. The somatic report included 2 TP53 variants as well as a CHEK2 variant. Looking at the CHEK2 variant, that is a common founder mutation, and the allele fraction, again, is around 50%. So we were suspicious of that being germline. Looking at the 2 TP53 variants, you can also see that one of these allele fractions is close to 50%. So definitely something that we potentially are concerned about. Just to reiterate, CHEK2 is associated with a moderate risk for breast cancer, colon cancer, thyroid, prostate, and potentially other cancers, whereas the TP53 gene is associated with Li-Fraumeni syndrome, so a very high risk of cancer, almost 100% in most people. It is associated with brain cancer, so we were specifically concerned about this patient. And then the end of the slide shows that radiation sensitivity. So this patient's treatment for the brain tumor was set to include radiation. And if the patient had a germline TP53 mutation and therefore Li-Fraumeni syndrome, they may change that plan because of the risk of secondary cancers from the radiation. So this was obviously really important to the team and the family to figure out. The germline results, not so unsurprisingly, found that CHEK2 mutation, so that same founder mutation, and did not identify the patient has Li-Fraumeni syndrome or a TP53 mutation. The lab nicely set out and specifically reported on the 3 variants that we were concerned about and if they were detected in the germline sample or not. So that was a really helpful, just second, you know that the lab really looked. So this is someone who I would say the CHEK2 mutation probably has nothing to do with why they developed that brain tumor. It's more of an incidental finding. It's not going to impact this patient's treatment or, but it will impact their surveillance for future cancer risk. But I don't think it's related. Whereas the TP53 mutation, if that was germline, that probably wouldn't have been incidental for their tumor formation. So here's my little summary of the concepts that we went over today, and I'll be available during the panel and after to take any questions.
Thank you, Ms. Gold, for highlighting the germline versus somatic mutations with good examples and some of the pitfalls in the tests that are conducted And we should keep that in mind when clinicians are treating and when the counselors are counseling the patients. We will like to have you in the panel discussion for more discussion about this after the next speaker's talk is over. Thank you, Gold. Yeah. Shall we go to the last speaker? That is, yeah, I would like to invite Dr. Aparna Dhar. She is the head of the Department of Medical Genomics and Genetic Counseling at SRL Diagnostics. She is the lead of a hereditary and precision oncology clinic at Fortis Memorial and Research Institute, Gurgaon. And her academics are MSc, MPhil, Medical Genetics from University of Glasgow, PhD Mayo Clinic, School of Medicine, clinical certification in cancer genomics and precision oncology from Harvard Medical School, MA USA, fellowship in medical genetics and clinical and molecular genetics. Good. Interests are in cancer genetics, especially gynecological malignancies, telemedicine, and educational aspects of genetic counseling. Here is Dr. Aparna Dhar. Please invite you for your talk.
Oh, I'm here. I'm here. All right. Good evening, everyone. No, I'm here. All right. Good evening, everybody. And thank you, organizers, for having me here today and giving me a very interesting topic to talk about. I think as genetic counselors, as a field, as a team, we have evolved. And for the next 10, 15 minutes, I'm going to shed light as to how our role as genetic counselors in cancer oncology has evolved, and more from an Indian perspective. So this is just a little bit what I have learned in the last 5.5 years in India, and just going to share my thoughts with you. So you see, it's not moving. I am pressing. Can you just control the slides and I could just say next? Would that be okay? Okay, perfect. All right, so when we are talking about cancer genetics and genetic counseling in cancer in particular, we obviously know the goal, we know what our role is as genetic counselor with cancer genetics. So let's understand what is the goal that comes for us as genetic counselors in an oncology clinic. And one of the key goals over here is that it's our role and it's one of our key responsibilities to actually identify individuals and families who are at a potential risk or have a genetic predisposition of inheriting a gene that could increase their risk to cancer. And the whole purpose of doing this is you obviously want to promote awareness, early detection, and cancer prevention. And this has been the very, I don't want to use the word traditional approach, but this is actually the framework. This is our base on which we do cancer genetic counseling. And keeping this in mind, our oncologists, our OBGYNs, general practitioners, when a patient walks in and they, are talking about family history, if any one of these red flags gets identified, they get routed to our clinic. And when they get routed to our clinic, we start the process. In India, the trend, unfortunately, is that when that VUS report comes, that positive report comes, and you get the patient then, and you have to start from post-test counseling, and the pre-test is not even done. But hypothetically, let's assume that irrespective, it's pre-test or post-test, what I like to do in my session is, my clinic, is that I divide any session, pre or post, into 3 parts. This is in my head. First part is interpretation. Why has the patient come to me? Does the patient understand why he or she has been asked to meet me? What are their goals and expectations from me in this particular clinic? Once I've got that understanding, and obviously you're drawing a family tree, you're having a conversation, you're rapport building with your patient, they're getting comfortable with you, you're getting comfortable with them, and you'll realize that when that comfort level is there, the more information you start getting. You come to know of distant relatives, what started off as no family history, this is the first case, and then suddenly you hear about a maternal grandmother's brothers, somebody who had, there's a very strong family history over there and a second degree relative. So having those conversations, you start getting all that information in your head. Around that time, you're observing the family. In a pre-test setting, I'm seeing what are the family dynamics? How is this patient feeling about the fact that they have to come and visit me? Are they anxious? Are they nervous? Are they feeling guilty that they're subjecting their family through this? In a post-test, because that's what we usually tend to see more often, I'm trying to understand, is there a change in language, a change in dynamics in the family? Sometimes you see that very supportive male husband telling that, I'm here for my wife. And when she comes in for pre-test and when the post-test happens and it's a positive report, you suddenly see that very loving, warm husband has suddenly become, oh, my children are at risk. She's given my children a BRCA mutation. So it's through these pre-test, post-test, you're observing, you're analyzing. Once you've got all this information, you've done your interpretation, you start the second part, which is education. In pre-test, you're obviously, if a patient does qualify for genetic testing, you've got to tell them why they qualify for genetic testing. Once you explain that, you're explaining the pattern of inheritance, as we've heard from our earlier speakers. It's not just, talking about autosomal dominant. You have to be talking about those incidental findings, which could have an autosomal recessive disorder. You will be talking about the possible results, positive, negative. Please don't shy away from VUS. It makes your life so much more simpler. If in the pre-test you've spoken about a VUS, you're talking about these VUSs to them. You're telling them if they get any of these results, what are the implications to them, to their family? And while doing this, you're laying out the pros, the cons of genetic testing in the most autonomous way possible. And the third part is counseling. That's what sets us apart as a complete discipline versus our other, medical counterparts, is this counseling aspect, the psychological support that we give, the emotional support that we give. And while our hands are tied in certain areas, we can use our skill set of actually routing our patient to maybe an oncopsychologist because it's beyond our purview. So all these assessments have to be done in pre-test, post-test. And while we're doing all of this, this is just a very quick, recap of what I just said. You are taking detailed history, you're taking information. You may be in a cancer clinic, but you don't just limit it to cancer. You're going to be talking about everything under the sun. You're going to ask if there's learning disabilities, if there's neurological, there's some sort of neurological disorder in the family. And obviously no one's going to understand words like ataxia. So you're going to use phenotypes and explain them in basic, simple languages. You're going to hear a very common thing. Oh, my grandmother passed away, but she was in the village. Okay, she was in the village. How did she pass away? Have you heard stories that before her passing away, did you suddenly see her stomach bloating up? Did she suddenly lose a lot of weight? So you start doing what we call an autopsy to kind of understand as to how did somebody pass away, especially when you have a suspicion in your mind. You take all that complex medical information and you disseminate it to a patient in very basic, simple terms. You use basic layman terms, and this is where it becomes important in rapport building. Like a lot of my patients come from the IT background, so I try and use words like algorithm and explain to them as to how, genes have these algorithms, and if that doesn't work well and there's a syntax error. So you just kind of accommodate and you start explaining in a basic language that they'd understand. And while you're doing all of this, the purpose is that you have to be autonomous. You have to give the good, the bad, the ugly of all this testing so they can make independent decisions about healthcare and about their reproductive options. And you're doing all of this being extremely sensitive to their personal religious beliefs and their traditions. What you're not going to be doing is telling them what decision to make, that you have to get testing, you have to do it right now, telling somebody to continue or end a pregnancy, telling a couple, please don't have children because you have a mutation in your family, and telling or not whether they should go for testing for any particular disorder. You have to be very, very autonomous. Now, why do I think genetic counselors are very unique, and why has our role evolved? So these are us as genetic counselors. We have this unique understanding, and especially those of us who practice in oncology, of understanding those complex cancer pathways. all those pathways, we understand the crosstalk of those pathways. We know what signals they're telling one another. And that's pretty complicated stuff. In addition to that, because we understand this, we understand somatic aberrations, we understand genes, what is important. We know sometimes we don't want a point mutation, we want to know a fusion partner. Because we have that understanding, we also have clarity in understanding what technology do we want to use. Do we just want to do a basic FISH? Do I want to do an RT-PCR? Do I want to do next generation sequencing? Do I want to do MLPA? We're able to call out the shortcomings in some of these molecular tests. So we have all this stuff, which is rather complicated, but kudos to all of us, we actually understand this. Sorry. And because we understand all of this, we can take all this complicated information and make it really simple. And the person that we're making it simple for is not just our patient. It is for that medical oncologist who's going to call you and say that I have this 30-page somatic report with me and I can't make head or tail of what I'm supposed to do. So you have to sit and highlight and say, this is your oncogenic driver mutation. This is your passenger mutation. This gene is absolutely insignificant. Don't even look at it. That is a kind of information and power you have. And you can take all that information and make it simple for that medical oncologist. You can, thank you. You can do the same for your radiation oncologist. If there's a TP53, we know that it's contraindicated. So if it's contraindicated, it becomes your role as a genetic counselor to call it out and to inform your radiation oncologist. We have comprehensive germline panels. It's no more just 50 gene, 20 gene hereditary panels. We're doing 150, 300 gene panels. And you get some bizarre genes over there that come positive. And there's some paper somewhere that says it's associated with HBOC. Your surgical oncologist sees this and says, all right, let's do prophylactic mastectomy. You really cannot be recommending that because there's not enough evidence. So it becomes your role to actually explain that, yes, while this is associated with HBOC, or there's still some data around it, this is not the maintenance or the management that is recommended. And this is all that we do. So technically, if you look at it, all roads lead to one, which is us as a genetics team. So how have we evolved when we are doing all of this stuff? I think the reason that we as a department, we as healthcare providers have actually evolved is because we have all this great unique skill set, this tool set with us that actually allows us to, implement that in our clinic. So these are just some of the lessons that I feel I have learned in the last couple of years, and I'm just going to be sharing that with you. So the first lesson I've learned is that family history and age is actually a very poor red flag.
Recording stopped.
Oh, okay. Is actually a very, very poor red flag. And the reason being, if we just look at the Indian diaspora, right, we're usually following the NCCN or the ACMG guidelines. If I look at my Indian community, and I'm going to be talking about ovarian cancer patients where we know germline testing has become so common upfront because of therapeutic implications, and all of us see it in our clinics. Now, this was a very nice study that came out from the Tata Memorial Group in Mumbai. And they just went ahead, irrespective of a patient's age, family history, upfront gave germline testing for BRCA mutations. And if you look at it over here, around 20% of these patients had no family history, but tested positive for a germline mutation. It is this cohort of patients that we are technically losing out, who could be benefiting from a cancer genetics clinic and from cascade screening and all the benefits that come with genetic testing. And this is something that is getting lost. So today in our cancer genetics clinic back in Delhi, what we do is that irrespective of your age, irrespective of your family history, be it breast, we're seeing it with our colon cancer patients. When a patient gets diagnosed with colon cancer, immediately it's sent in for MSI testing by PCR because immunotherapy is a treatment option. And when MSI is when there's MSI instability is high, the patient gets routed to us only then for testing. So all these are different changes that we're starting to see. So for us, I think as at least, from an Indian perspective, we need to look a little bit beyond family history and age of onset. Now, we've had brilliant speakers already talking about incidental findings. So I'm actually just going to share a case study with you. This was a patient of mine with ovarian cancer. She had high-grade serous. She was diagnosed at 59, no family history. 59, high-grade serous. We didn't send her in for germline testing. She got treated. She was fine. She went to remission. She had a recurrence at the age of 62. And at this point, we sent it in for somatic testing. In somatic testing, we found a BRCA1 mutation. And when you look at this, we found a BRCA1, which was 63%, and a TP53, which was 59%. And because these two showed suspicion of being hereditary, we did Sanger sequencing using blood and got confirmed that she actually had a BRCA1 mutation. The lesson we learned over here was that while we usually send patients to the cancer genetics clinic, if there is a germline mutation, if there's a possibility of a family history, that's when they get sent to you from a germline setup. But honestly, if you think about it, today in our clinics, we're even proactively doing it for somatic testing, just because of, for lack of a better word, I'll say the fear of having something like this pop up and then explaining to my already very upset, anxious patient who's had a recurrence, who can't believe it that her cancer has come back, and she followed all the medical advice to the T, and then suddenly breaking this news to her that this is a germline mutation did not bode well. So if not for every case, at least for those cases where the genes involved in the DNA damage repair pathway, that's your breast, ovarian, prostate, and pancreatic cancers, I do very strongly encourage that we start, even for somatic testing, get a genetic counselor on board. Preempt it, inform your patient. If it doesn't come, well and good, but if it is there, trust me, your patient and your oncologist will thank you. Right. So now that we have, all this testing happening and we're seeing an overlap between germline and somatic, and we're so used to, these cancers, pancreatic, prostate, breast, ovarian, colorectal. And what's interesting, in my data set, I'm starting to see lung cancer, EGFR T790M. Very common in lung cancer patients, adenocarcinoma, the NSCLC subtype. But interestingly enough, there are so many case studies that are coming out. And I'm actually seeing this in a family history where non-smokers at a very young age, under 50, getting diagnosed with lung cancer, coming from from the hills, and very clean environment, at least that's what we think. Healthy lifestyle, non-smokers, don't chew tobacco, and are coming positive with lung cancer, male, female. And there are a lot of studies that are being done that are showing that there could be an underlying genetic condition. So that means that for us as genetic counselors, don't disregard that patient who says, my uncle, my mother, my someone passed away with lung cancer. You could have this. In fact, EGFR T790M is a mutation that we're actually seeing in triple negative breast cancer patients too. So be on the lookout for this sort of information. It's no more just HBOC, Lynch syndrome. All this is changing. And that's because we're profiling. So it's changing. And these are just some of the ECMO case studies that are coming out. Right. A lot of our patients are getting diagnosed at a very young age. And we're all talking about, we're patient advocates, right? We want to do what's right for our patient. And a very important thing that we're missing out on is oncofertility, egg preservation. None of us are talking, or it's not very commonly discussed with our patients, the option of actually, freezing, cryopreserving their oocyte. And to make matters worse, for those who have a BRCA1 mutation, they have a premature ovarian insufficiency. They have a predisposition to that, which means is that their ovarian reserve depletes, which also means that it's very difficult for us to isolate those mature oocytes. And these are information that has to be informed to our patients. It is information that an OBGYN needs to be sensitized about, that this is a BRCA1 mutation. When they undergo chemotherapy, they're going to have possibly the worst and the most adverse reactions on a DNA, on a molecular, the pharmacogenomics of it is very, very complicated and is unfortunately very harsh. But in addition to that, these are also the negatives that go with a BRCA1. And this is something your patient has to be counseled about. We do offer PGTM. I know it's a very controversial topic. I know it's an adult onset cancer. I'm somebody who's not in favor, but fortunately or unfortunately, we have to talk about it because it's not our views. We have to be autonomous. It is their view. It's the patient's choice. And in cases like this, if a patient is opting for that, please inform them that does not mean that your child will never have cancer. It just means that the hereditary part is removed. There is a chance of somatic, the general population risk that they will be carrying. So this has to be handled with a lot of sensitivity. And if I start talking on this, I'm going to take all the entire evening. Tackling VUSs, another key concern. Now, in our clinic, this is usually the format that I do use. This is just what we use in our practice. And that is if we do have a patient with a VUS and there's a very strong family history and this suspicious VUS is something that does look like it's going to be pathogenic. In cases like this, we do take it to our molecular tumor boards. We do have detailed conversations around it. We get bioinformaticians involved just to understand that in some very rare cases, we do treat them as pathogenic. And I'm going to show you a case for that. In some cases, we do put them on active follow-up and treat it like a positive case without giving them the option of prophylactic. I need 2 more minutes. Without giving them the option of being prophylactic. And then there's some of those, it really doesn't make a difference. We just counsel our patients to kind of ignore the VUS and just continue with the standard of care. Now, this is a patient. These are 3 sisters who came to my clinic. One sister was diagnosed with breast cancer at 25. She got treated. She had a recurrence at 45, triple negative. She got a BRCA VUS. Now, the purpose of doing this test was less to do with hereditary because these 3 sisters did not tell each other they had cancer, and I couldn't tell the 3 of them that they were coming and visiting me. So we were doing testing more from understanding if they could be a candidate for a PARP inhibitor. Then the second sister was diagnosed with breast cancer. She was platinum sensitive, triple negative. We again wanted to see if we could give her a PARP inhibitor. She comes back with a BRCA, it was a BRCA1. Sorry, I realized the 1 is missing. It was a BRCA1. Again, VUS. Third sister, she was treated with breast cancer in her 30s, and then she had ovarian cancer, 2 primaries. Same BRCA mutation. And in a case like this, we took it to our molecular tumor board and we were very perplexed because we didn't know what to do. We couldn't get these 3 sisters in for co-segregation studies because that meant there was a major breach of confidentiality. What was interesting is the mother accompanied all these sisters on their visits, to our clinic, but we had to pretend like we didn't know her from Adam. So in a case like this, because we had presented this to the tumor board, we actually treated this as a pathogenic mutation, and our patients did have a phenomenal response. And we also had help from Ambry Genetics US. I would give them a shout out because they had similar cases where it looked like it was a pathogenic. So we had that literature to support us, but this was treated as pathogenic. Our patients were treated. So again, you see the role of a genetic counselor is with these VUSs becomes very important. And this is my last slide. This is where we are today. It's a collaborative approach. Genetic counselors are there whether people like it or they don't like it. We are an integral part of the oncology setup. I absolutely love it today that when we have conferences, you see you have panel discussions. There's always a geneticist or a genetic counselor who's a part of it. In our hospital, for example, we're in those molecular tumor boards fighting with our oncologists and putting our points across, especially when we don't agree with them. So there is an acceptance and our role is evolving. And while it's evolving, I have to say our responsibilities are increasing too. So tread carefully. But this was a message that one of my oncologist colleagues had sent it across. And I thought I would leave you with this, which is a genetic counselor is like air conditioning. When you do not have it, you do not realize you're missing it. But when you have it, you cannot live without it. So on that note, thank you very much for your patient listening.
Thank you, Dr. Aparna, for your illustrative, exciting talk on a very sort of a subject, which is really, anyway, that's good. Now, I think, do we open up for the panel discussion? Would you like to say that?
Yes, so we will now proceed with the panel discussion. Dr. Aparna, you also please take a seat down there. Yes, thank you. Yeah. Yeah. Thank you all the speakers for very insightful, informative talks. So in the panel discussion, we have the speakers, Dr. Dil Afroz, we have our chairpersons, everybody is here. So basically, we all have highlighted the importance of testing, genetic testing, as the testing is increasing, and we are getting a lot of asymptomatic and young women who are getting tested nowadays. And it's like a cascade of testing once the familial mutation is identified. So I would really like to ask what all should what all are the considerations that we should be making while counseling these young asymptomatic women, especially in case of familial BRCA variants. Yeah, anyone can start. We can start with you, Tanya.
So the question is, what are some of the things we should be considering when testing asymptomatic individuals who have a family history of a variant? Is that right?
Right, correct.
Okay. So we need to first make sure that the patient understands her risk. It will kind of depend upon whom it is that the variant was identified in. I also think that it's very important that we don't just say, okay, we have a familial variant, let's test for that. We want to still take a very thorough personal and family history. I had, for example, a patient who came to me because he had an aunt with a pathogenic variant in BRCA2, but in taking the family history, we saw that there were also some colon cancers in his family. And ultimately, I ended up ordering a panel for him rather than known familial mutation testing. And we didn't find the BRCA mutation that had been seen in his family member, but we did find that he had Lynch syndrome. So I think that that's one of the points that I would want you to take home. You know, don't just go after that obvious low-hanging fruit. Still consider the rest of the history. I'll leave it to my co-speakers to add some other considerations.
Just to add on that, I completely agree. And then I think another thing that I start out with the patient is obviously with education of what this is and what ages, screenings, and preventative strategies might be indicated for the patient, and then really talk through when it makes sense to test, if they're going to be tested. Because we definitely see patients who have a known family variant, but maybe are below the age that screenings would start, and maybe they still want that information and that should be available to them. But just kind of understanding, because a lot of patients, once they realize that, may not want the testing at that time, because then they would be sitting on potentially a positive result, thinking they're at a higher risk for cancer and really not taking any of those preventative or management strategies at that point. So that's always something that comes into play. And also assessing potentially reproductive plans, so that if they would incorporate that information into their reproductive planning, that may also be a reason. One, I guess, interesting tidbit is we see sometimes patients who are identified during their pregnancy and coming in for familial testing, and something especially with BRCA that I talk to patients, if they're not going to change their pregnancy management based on the decision or the testing options, is that maybe they choose to wait until after pregnancy to learn their own status, just because breast, ovarian screening and prevention is not really as possible during pregnancy and breastfeeding. So it's sometimes similar to testing like someone below the age of actionability, and it may not be something they want emotionally at that point.
Yes, thank you.
Tanya, as you mentioned that in minorities, genetic testing is not recommended. Even NCCN recommends the same in less than 18 years. And what are the challenges you face when you say a minority where parents are having this mutation positive and then they want to go for the testing? What are the legal and ethical issues you face?
I'm not sure if I could hear all of that. It was a little bit quiet. The legal and ethical issues of offering BRCA testing. I'm sorry.
To a minor.
To a minor. Yeah. So, when it comes to offering testing to a minor, if they're not going to, if there's no screening or preventative management that you would do at their current age, we usually recommend deferring testing until they reach adulthood so that they can make their own decision about that testing. although I have seen certain exceptions. So for example, I think I mentioned this in my talk, sometimes if a child's having whole exome sequencing, that can be an incidental or secondary finding that comes out from that result, kind of, unintentionally, although we know it's certainly a chance that they can get such a result. And because I know that these things can happen, even though in a perfect world we recommend not testing minors for adult onset disorders, I think then we're left to deal with it and think about how can we best help that child. And it comes down to some degree of transparency, not necessarily hiding it, but also making sure that information is being given to the child in an age-appropriate manner and maybe doled out, in some schedule that the parent feels comfortable with and that works for the child based on their own maturity level. But in general, if the child won't have symptoms themselves and they're coming just specifically maybe for testing for that known mutation, then we don't recommend testing the individual until they reach adulthood and can make their own decision.
Thank you, Tanya. So we have one of our genetic counselor. So she has some questions for you, if she can ask. Hi, just taking off from the discussion currently, my question is that, okay, just taking off from the discussion currently that was going on, I'd like to discuss a case that actually I was thrown into a situation like such. I had a patient and they were 16, 17, so it's very close to, they have a conscious mind, they're making other decisions in their lives, and they had a say. They were not symptomatic, but they wanted to have a say in wanting to get tested or not. And so in the scenario, the parents were there, the child was there, and there was this argument going on right in front of me. And so how to handle a situation like such? I was quite divided in that situation myself about whether to stick with the legality of things or like what are the options I can offer. So what have you done in situations like such?
Oh, that's a great question. And certainly I think, we've probably all met 25-year-olds who maybe act like they're 16 or 17, and 17-year-olds who act like they're 30. So I think, certainly age is not the only marker of maturity or understanding. So I think that when a situation comes up like that, as with most ethical issues, there's not a black and white perfect answer or perfect age. I'll be curious to see what my co-speakers have to say about this too, but I would say that the main thing is to fall back on our counseling and have a thorough discussion with the individual and their parents, if the parents are also part of this conversation, about, what is your understanding about this? Why do you want the testing? How will you use this information now? And in the setting of knowing that they understand the implications of this testing, which go beyond just screening. It also comes into their, their own self-image. And here also things like what life insurance they might be eligible for if it's positive. But if they understand all of those implications, then my answer about testing might be different than if I feel like, they don't know why it's important to do now, or they don't really understand the implications, or they can't express any particular reason for doing the testing. That might lead me down a different path. How might the others here respond?
I just wanted to say, if there is no bar of for age for any other test, why then for a genetic test?
Mm-hmm.
Because ultimately it is information about your health. So if there is no bar for testing, why for a genetic test? Why take it?
I think that's a great question, especially in the current world of genetics where sometimes people do get these results as incidental findings. But in some ways, genetic testing is so different than other types of tests. If you were to test my glucose right now, I'd have a result for this moment that I can act on in this moment, and it's really not going to affect my life 10 years from now. But if you were to test me for BRCA2 when I was 16, that result might not have any impact on my life then as a 16-year-old. But now, many years later, it could have an impact on my risk. And today I might do screening that I wouldn't have done or surgery that I wouldn't have done back when I was 16. So I think that's where genetic testing differs from other tests that give us information for in the moment.
Could it be because it is still in the infancy and we're still trying to understand it, its implications, say 10 years or 20 years or 15 years down the line? Whereas if you are comparing it with, say, a glucose test, it may have implications later on, but right now there's something that you have there to address it.
Mm-hmm. I think that's a piece of it. We know that we don't know everything in genetics, and I fully expect it to keep evolving. But sometimes even where we feel confident that we do know the risk, for example, with the BRCA1 gene, it still doesn't change the fact that what we know won't impact the individual necessarily in a positive way as a child, even though they can use it later in adulthood. And I think it's hard. I mean, you have that power differential in many instances. When you're testing a minor, they're not making that decision for themselves necessarily. They have somebody else making that decision for them. And so they're not saying, I want this information or I don't want it. Now, I'm a parent too, and I know that there's lots of things that I don't give my kids a choice about. If I want them to eat their vegetables or something, for example, that's good for them right now, and I want them to do that right now. But if I were to tell them, I want to know your genetic testing status for when you're an adult, even though I'm not going to do anything about it right now, that's taking away some autonomy from them that I don't need to take.
Sorry.
I was going to add that the autonomy thing, I think, is the main thing in question here. Like, we all have patients who, as adults, choose not to know information or not to get genetic testing for various reasons. And I think we can't assume that a parent's opinion about their child potentially wanting this information or not is going to apply to the child as well.
That we're actually talking about BRCA1, BRCA2, but if you look at something like
just to add to that, we as an institution we have a lot of discussions in the transition from sick care to health care, and we tend to be reactive to certain physical phenotype, if you want to call it, whether it's a pathologic finding or an abnormal blood glucose, versus as part of your routine healthcare, should you, whether or not this type of testing should be implemented and the impact that would have. That's, I think, what we'd like to be able to do in the future. But the other side of the coin is who's going to pay for that. There's not, getting reimbursement for, I just want to see what mutations I have, is not really feasible in the routine healthcare setting at the current time.
Sorry, I just wanted to add that we've been talking about BRCA1, BRCA2, which is usually adult onset, but then you've also got the RET mutation, for example. In cases like that, we would test a child because we do know that, there is a pediatric implication over there. So I think genetic testing, yes, we are very cautious about age because we have seen that even those as young, and I'm talking about the Indian scenario right now, that somebody even as young as 25 who's asymptomatic, strong family history, has a very difficult time accepting a BRCA1 mutation. So, while we say that if you can vote and you can get married and you can make all these decisions at a young age, if you're not happy with your partner, you change your partner. If you don't like your government, you vote for another one, but you cannot change your genetics. So I personally feel that while we give that option to our patients, but we have to be very careful as to what gene that is that we're actually testing for. And it may not be a one size fits all. I think so. Yeah.
As a clinician, one more point for Jane, when you're talking about DNMT3 mutation, it not only has a significance in as a recurrences, there is also some sensitivity for hypomethylating agents. DNMT3 mutated patients has more sensitivity for azacitidine or destabine, what we use in the treatment of AML.
That's correct. It has
I think that's what I was trying to point out, is that we're performing the testing to understand whether or not we have therapeutic options or risk options. And then we come up with these variants that we think may have therapeutic options, but we have to think of underlying causes of these mutations. So in that case example that I gave, that DNMT3A mutation, once found to be somatic, is actually not associated with that disease that the patient had. It was in an underlying clonal hematopoiesis. So the impact of that mutation on selection of treatment really didn't matter was inconsequential in that case, because it was in a different cell. It wasn't in the tumor cell. So that's why there's a lot more exploring of the single cell analysis, so we can begin to understand what cells are these mutations in.
May I request to ask a question, please?
Yes, Suraj, please go ahead.
Thank you. So first of all, I would like to thank that this session was so lovely. All the speakers in this session, in a clinical genetic counselor's perspective, how that complex clinical information could be transformed into a very beautiful presentation with all the human masalas added to it, that it lets us understand the great impact of how we can deal with the case. So appreciations for that to all the speakers. And my question is that we spoke a lot about somatic and germline testing, and it involves a lot of funding. That just was about to ask the question and Jane mentioned it. So what do we do here in India? What is the scenario? Probably this is addressed to Dr. Dar. Do we have such infrastructure to have the somatic germline? And we saw how evident it is to pick variants and understand if, so how do we drive all this with the lack of funding in the Indian scenario? And to add to what is a database that we refer to, do we have a significant amount of contribution in Cosmic or other international databases? Do we have an Indian database that we refer to currently? So how far are we in this journey? Please address.
That's a fantastic question. Thank you. So that's actually one of our key concerns in India, which is the cost of testing. But we have to give a lot of credit to our pharma partners. There are a lot of, we like saying the word coupons that are floating around in the market, which makes genetic testing, be it germline, the HRR panel, which seems to be the flavor of the season of late. So you've got that at very economical rates versus, where they tie up with good lab partners like MedGenome, SRL, Core Diagnostics. And these are good labs doing good work, which are they're CAP accredited labs with NGS. So we have, the Strand too, sorry. So you've got these labs over there which are doing fantastic work, and you have coupons, which is making this sort of testing accessible. At least the basic, the bare minimum, what is required in germline and in somatic. But I do know, like we say, Dili bahut dur hai. It's a long way to go by the time it's accessible to everybody. But we've started, it's baby steps, right? I think the acceptability of next generation sequencing in our clinical setup is barely 5-6 years old, where oncologists are comfortable sending this for NGS testing. I mean, those of you who've been here for, you've seen there to be a resistance to even send simple BRCA1, BRCA2. And now there's acceptability. So it's a concept change that is coming in India. And I do see that the cost has come down significantly. When I moved to India, it was around 40,000 for BRCA1, BRCA2. Today, it's barely 5,000, and it actually goes to whoever's the cheapest lab offering the best price, and they're doing some really good work. So as the demand goes up, I think the cost will come down. I do feel that there is more accessibility. Everyone who cannot afford a foundation, a garden, I think we should give a shout out to all our domestic labs that are doing a phenomenal job in actually recreating those panels and trying to give you, the gold standard that is available outside. And I think they're doing a very good job. But yes, it's still work in progress. Price is still an issue, but versus 5%, at least 15% can actually access that. So we're doing pretty well that way. Regarding databases, while I have praised all our labs, we don't share data, as we all are well aware of. It is unfortunately just with all the labs. But I think the change that we're seeing is that, through meetings like this, when you meet people from other labs, you build network, you build connections. I think everybody's end goal is to help a patient. So I can say that if I pick up the phone and call somebody from another lab and say, I've got this oddball mutation, have you seen it in your database? We are very helpful, and I think we do cooperate, but yes, data sharing is not there. I do know institutions like AIMS, RGCI, TMH, there's a lot of data information from a somatic perspective that is being given into TCGA and is and with Cosmic. So our Indian data is also being shared. It's something that's happening in the last couple of years. So slow and steady, I think we are making a presence, but we'll get there. I do feel we'll get there. I hope that answers your question.
So my question is to Aparna, Dr. Aparna. Hi.
Hi.
So the question is that, I come from a government sector and you come from a private setting. So there are a lot of lacunae in the, government setting, it, but the cancer care cannot wait. So we need to tie up with the private sector on these, levels. So how is it that a referral to a private clinic can be done from a government sector? You would be getting referrals from the government institutes like AIMS, PGI, I'm sure. So how do you go about it? How does it have to be routed?
So usually they have my number and the patient just calls and we get the appointment done.
Not that easy.
It's actually that simple.
No, it's not that easy for us to refer to you.
No, it is. So what we do is a platform that's worked brilliantly well is telegenetics. And we've been doing this pre-COVID, and that has actually allowed us to connect with patients pan-India and give the service of a cancer genetics clinic. So it's a simple thing of an email address or a phone number, and irrespective where the patient is, we get the job done. So we coordinate with the patient, and whatever testing, somatic, germline, whatever's required, it does get done through those clinics. And it's been pretty successful. So that's one way I think we can improve accessibility to a genetics clinic like this. And also, I think in a lot of cases with government institutions and all, with labs and all, you do have tie-ups. Different laboratories have tie-ups with, like we have some with AIMS, we have it with I can't think of anybody else. I can just think of AIMS right now because I had an AIMS patient in the morning. But we have this tie-up. So accessibility is there. I think we should connect offline after this, and I'm so sure I can help walk you through this and help address your patients with skin.
Okay, so the next question is for Julie, Tanya, and Dr. Aparna. So what total consideration should a genetic counselor make while offering a PGT for a familial cancer variants? So what are your thoughts on how you deal with such kind of, counseling session where a woman wants to go for a PGT and you have a husband who doesn't want to go for? So just you can address that, how you deal such cases.
Yeah, so full disclosure, we're kind of spoiled where I am located, where I do the cancer genetic testing, and then we have reproductive genetic counselors that are actually having the conversations about prenatal testing or PGT testing and really talking through those decisions. But we are all located in the same place and kind of share a lot of patients, obviously, so I can definitely give some perspective to it. I think a lot of it comes down to our counseling skills and really kind of making sure all the parties kind of know what the mutation means, what age it has implications, how high the risks are. Because I know I'm in New York City and I think we're kind of a PGT happy kind of zone where a lot of people are kind of looking for that and looking for it for anything. And then we get into the concept of like very moderate risk or even low penetrance variants and doing PGT for that, sometimes funds for some people are not an issue, and they just kind of want that testing for everything. So I think it's a mixture of education and then like counseling about their values and what they really want. But it definitely can be challenging, and very challenging when there's not agreement between a couple, of course.
I would think that, there's also an extra layer of complexity if the risk differs between the genders. So something like Lynch syndrome. Men can be affected, women can be affected, both genders have risk. But while somebody could have, if you're a male, you do have risk associated with BRCA1, of course, but the risks are higher for women. Then we get into that kind of dangerous territory of sex selection. And certainly in the context of the laws of India against that, that can become a little bit more complicated of a conversation.
Dr. Aparna, if you have your points.
I was just going to add, it really depends. Why are they doing PGD? Is it because it was a case of oncofertility where she has undergone chemotherapy? I've had a case where a patient's partner first agreed, so we did the egg preservation, and when it was time to have a kid, he refused. He backed out. He just did not want to be a part of this process. She was cancer-free, and he just didn't want to go down that path. So there are different complexities. I wish it was very simple. Are they doing it for BRCA? Are they doing it for whatever? But it could be anything across the board. And I think sometimes the best thing you can do is just be a good listener, a sounding board, and just hear it out. And somewhere in all of that, you'll realize that there's actually a far more deep-seated issue, which has nothing to do with the genetic test and something that is more interpersonal. And maybe you can help address that. And in some cases, I feel before they do this, route them to the right person, like even a marriage counselor, for example, to help address those issues. So that's what I said. It's just about listening sometimes to a patient. Sometimes it's less to do with us and more to do with what's happening between the two of them.
Right. We are actually flooded with questions here, but in interest of time, I would just like to ask one last question to our chairperson specifically. So we often get questions about prophylactic surgeries, and once we have, a mutation that has been identified and that puts them on a high risk of gynecological malignancies, the first thing that they come and ask us is prophylactic surgeries. So celebrities are talking about it, and so everybody wants to, know about it. They are very keen, but as a clinician, what would you suggest? What all considerations should be made before discussing or while discussing prophylactic surgeries?
Prophylactic thing is, one thing is it's available in breast and ovarian cancers, hereditary ovarian cancers, where if patient is having some genetic mutations, BRCA positive 1 or 2, then she can undergo for prophylactic mastectomy or risk-reducing salpingo-oophorectomy. It will be advised once patient completed her family, because most of the times if patient is having before completion, if she's detected BRCA, then usually advise fertility preserving surgery, then later she can undergo risk-reducing surgery. And in these cases, I think genetic counselors play a vital role where they can counsel the patients regarding their psychological issues, mental stability, and because the whole physical appearance and it has an important role in that case. But as mentioned earlier, BRCA mutations has got a high chances of breast cancer and also ovarian cancers in later stages. So always we advise better to go for surgery once if family is completed, or at least take some chemo prevention. But there are no as such standard drugs apart from tamoxifen or some aromatase inhibitors to give then some PARP inhibitors. Those are not standards, but surgery is a good option for them.
Can I ask a question?
Sorry,
yes,
who's that?
It's me, Aparna. I have a question.
Oh, sure.
So actually, my question is to Tanya and Julie. So in the case of Lynch syndrome, there is in the NCCN guidelines where they talk about using prophylactic like aspirin. I actually wanted to know what is the acceptance, because it's a very hard time for me explaining it to physicians over here to put our patients on. So it's easily acceptable, but with aspirin, I get a lot of pushback, and I wanted to know your experiences in your clinic as to How do your oncologists or gastroenterologists deal with this recommendation?
Yeah, I can speak to this. So I think there is acceptance among the like hereditary cancer knowledgeable providers. And typically we are encouraging our Lynch syndrome patients to go to those providers. So typically they are kind of very clearly explaining the data that we have about aspirin and offering it to people. It definitely sometimes takes into account their other health concerns if that's going to be an issue. I think one thing that's been tricky is just the data has really evolved in terms of if it seemed like the dosage that we should be using, if it's actually effective or not, how long people should be taking it for. And I think that can be really helpful. It's really hard to keep up to date with and have the patients keep up to date with that information, because a lot of our patients are maybe seeing that knowledgeable provider for their first visit and then getting their colonoscopies closer to home and maybe not having those like updates all the time. So that can definitely be tricky, but with other providers that I've interacted with, I do try to share the data that exists and share the guidelines and sometimes even share the papers that are showing the efficacy. And I find even just like screenshotting the NCCN guidelines really helps because it kind of shows there's an official recommendation for this.
I would say, I haven't received much pushback or much resistance, but I also don't know how often the GI doctor is giving that direction to their patient. We share the recommendations, and I think my job is to provide education and to provide guidance and to make them aware of what resources are out there. But ultimately, it's still a conversation between the physician and the patient. And like Julie said, I think that was an excellent point. It also depends upon what else is going on in that individual's health to make the final determination of which management strategies you want to follow.
Thank you.
Thank you. Dr. Vijaya, can we please have your opinion on this? Dr. Vijaya, can we please have your opinion on this?
Sounds are coming from so many directions. I'm not able to find out from where. No, just one point I want to add that nowadays, when these cancers of the reproductive organs are coming in the young women. Earlier, cancer means it was thought that it comes only in old age. That thing is gone now. Any age, it's being detected. So, and the other thing is women are getting into their careers, professions, and delaying their marriages. As a result of that, what Dr. Kiran was saying, that if the family is completed, you can go for prophylactic surgeries. But the problem is they're not even getting married, say by 30, 35, 40. And then what to do if there is something there, either in the breast or the ovary? So that's the problem. The woman, it's a big shock when they come and they say, oh, what is this? So a major role the counselor has to play there, to sit with them, hand holding, tell what it is. But one ray of hope here for them is that the assisted reproductive techniques have come up so much that even if they want to have their own genetical child, that can be preserved before doing any surgery. That should be counseled properly to them. Don't worry about that. If there is anything required, it is there. It can be stored and kept any number of years when it is frozen. The eggs are there. But after that, again, you'll have to go through all the various tests, the pre-genetic counseling, testing, pre-implantation genetic tests or screening or whatever, they go for that. that has to be done. So it's not that prophylactic surgery means everything is gone, but still you can preserve them. That's the little ray of hope for them. So I think I thank all the speakers.
Yeah. One last question.
Yes.
Dr. Aparna. How difficult is to get, because usually as a clinician, like we won't send for all patients genomic sequencing and all. Once there is a recurrence, then we'll send. At the time of recurrence, we'll be having some radiological recurrence where biopsy sample is not possible. And we'll be having that blocks, FFP blocks. In that, most of the time we are asked for fresh specimens to do the testing. And those are some challenging things. So how to get those tests done, one thing. And second one is, as you mentioned, like T790M mutation, whether it is a somatic mutation or germline mutation you're talking about, one. Because we do T790 mutation, somatic mutation, to know the drug sensitivity in adenocarcinoma for osimertinib tablets and to change over for the third generation tablets and all. So
for your first question, if there is a recurrence and rebiopsy is not an option, if it's grade 3B and above, I think liquid biopsy would be a good option, something that you can consider from a CAP accredited lab. If the patient cannot send it to Gardner Foundation or any of the other players, I think liquid biopsy is a good option in calling out these somatic mutations. Second, I was actually talking about EGFR T790M from a hereditary perspective. I know it's very common in our NSCLC adenocarcinoma subtype, but interestingly enough, and I actually have a data set where I've got breast cancer and lung cancer in the family, and it's EGFR T790M that's actually come positive in my patients. And this is triple negative breast cancer. I know that a lot of clinical trials from a therapeutic perspective of using EGFR with TNBC patients, but I was speaking more from a hereditary standpoint as to how it is evolving. I think the gene list just goes on changing again and again and again. So we are seeing mutations. I'm talking about the Indian cohort that I have with me right now.
All right. I apologize to interrupt this interesting discussion, and we still have a lot of questions, but in interest of time, I would request you all to get in touch with our speakers in the speakers lounge. I really like to thank all of you for joining this discussion, and I would just hand this session over to Ms. Supriya here. Thank you.
It was a wonderful and interactive session. I'm sure that the audience have a lot of take-home messages from esteemed speakers. I request Dr. Prochi to come on stage to honor our speakers and our chairpersons. I request Dr. Aparna Dhar. I request Dr. Prach. Sorry. I request Dr. Prachi to honor our chairpersons, Dr. Kiran PK and Dr. Vijay Lakshmi. I also request Dr. Prachi to honor our moderators, Ms. Prachi and Ms. Sutopa.
Ayush, thank you to all our speakers for joining us online. Please be online for a couple more minutes. We'll take a group photograph.
Jane, thank you so much for being a part of this session. On behalf of all of us, we really want to thank you. Julie, thank you so much. Tanya, I know you've been with us even last year, so we are very happy to have you back. Dr. Dil, thank you so much for joining all the way from Srinagar. We miss you here personally. And Dr. Aparna, of course, we are very happy to have you here in person. Thank you so much. Have a great day. We will connect again. Thank you.
Thank you.
Thank you.
Thanks. Bye.
Thanks all.